Okay. So am I audible? Let me just check. So the screen is clear and I'm audible, so that we can start the session. So if I talk about the first session which I am going to start today, actually it's a quick revision which is going to be covered in this session, and the topics which I am taking, these are a very important topic for your competitive exam. So I will try to cover as much as I can. I will try to cover all the important aspect included for the neuroanatomy. So today's session is neuroanatomy, and just a quick review of the topics which I am going to cover. So we'll start with the meninges of the brain. After that, I would like to cover with the dural venous sinuses, the cavernous sinus, which is a very important topic. Many questions in the previous year of the FMG examination, also for the NEET PG and INICT, is definitely going to be asked from the topic of cavernous sinus. Other than that, it's also important that we should know about the ventricles of the brain. So when I am talking about the ventricles of the brain, I would like to cover the fourth ventricle, the third ventricle, the lateral ventricles, and also I would like to talk about the CSF circulation. So in between, we will solve few MCQs related to the topic. Thereafter, we will cover up about the topics of the cranial nerve, the neural, all the functional component and the cranial nerve nuclei. All the important nerves, the visual pathway and the defects of the visual pathway will be covered in this session. And then we will go on with covering the functional areas of the brain, the cerebellum, the white fibers, the internal capsules, and the blood supply of the brain. So let's start with the session. So I would like to start with the meninges of the brain. So what do you understand by the word meninges? So anyone can write their doubt itself. Okay, itself in the chat box, and between I will check my mobile and I will check your messages. So when I am talking about the meninges of the brain, it means the protective covering of the brain. So as we are proceeding from outside to inside, the most outer covering and the most tough covering is called as the dura mater. So beneath the dura, we have got the arachnoid matter, and the innermost layer, which is quite adherent to the brain surface, is called as the pia mater. So when we go for dissection and when we cut the cranial cavity, we want to take the brain out, it becomes entirely difficult for us to separate the pia. So we can take out the dura and the arachnoid together, and the dura and the arachnoid together is called as the leptomeninges. The pia mater is quite adherent on the brain surface. Okay. Yeah. So Kelvin, you are absolutely right. So here Kelvin has given me absolutely right answer. He is telling that it's a covering. Yeah. So it's a covering. Yeah, very absolutely correct you are. Yes, it's a covering of the brain. Yeah. So we have to know about the characteristic feature of the dura mater, the arachnoid mater, and the pia mater. Okay. So let's move on with this. So I would like to show you this image. Actually, this is the image where the cranial cavity has been opened up. We have cut open the cranial cavity, and now we are introduced inside the brain, and we have to know the layers which we have to clean up so that we can reach to the exactly the brain. Now what I want you to tell, that it's very important that you should know about the scalp. When I am talking about the scalp, just spell the word scalp. What is the spelling of scalp? S-C-A-L-P. So my dear friends, here S stands for the skin, SC stands for the connective tissue, A for the aponeurotic layer, L for the loose connective tissue, and P for the pericranium. Let me just enlarge this image. So I am enlarging it. So when I am enlarging it, you can very nicely appreciate the outermost layer which you are seeing here is the scalp. Yeah, hello dear. So this is the scalp layer, and inside we can see the layers which is covering up. So we have got the epicranial aponeurosis. Good afternoon. Yes, good afternoon, Osama. So what is here? We can see this is the aponeurotic layer. This is the aponeurotic layer. So when I am using the word aponeurotic layer, let me slightly enlarge it. It is okay. I am enlarging this image so that you can understand the whole layers. The whole layers. So my dear students, what you can see, the aponeurotic layer, and it is having the epicranial aponeurosis. So we have got anteriorly F is for the frontal belly, and posteriorly we have got O for the occipital belly. So this is the layer where the two muscle bellies are lying in the scalp. The anteriorly we have got here the two frontal bellies, and posteriorly we have got the occipital belly, and the merging of these two layers is by the aponeurotic layer. So which layer is merging it? The muscle bellies has been merged in between by the aponeurotic layer. Yeah. So now we have got the loose connective tissue layer, and it is very important for you to note down that the loose connective tissue layer is the fourth layer, which is exactly, what is it? It is the dangerous layer of the scalp. Okay, I'm not going much detail in the scalp because tomorrow's session is of head and neck series, and I hope when we will go with the head and neck series, all these things will be covered up. Now, this is the cranium, and the today's class is about the meninges of the brain. So, as I told you, the outermost layer is the toughest layer, and the toughest layer is the dura mater. Please mark this layer. What is this? This is the toughest layer, that is the dura mater. Beneath it, we have got the arachnoid. So beneath it, we have got the arachnoid. Yes, you are absolutely right, Dr. Med. Yeah, you are absolutely right. And the brain surface you can see here. Here you can see the brain surface, and this brain surface is covered by the pia mater. This is the three layers of the meningeal covering which we are going to talk today. The outer and the toughest layer is the dura mater. It is tough. It is tough. It is inelastic. It is made of fibrous tissue. The arachnoid layer. So the outermost layer is the dura mater, next is the arachnoid mater, and when I talk about the arachnoid mater, it is actually a delicate avascular membrane. It is delicate avascular membrane. Yeah, you are absolutely right, dear. Dura wali dura mater passes pia mater beach mein arachnoid. Yeah. So here, yes, you are absolutely right. You are absolutely right. So arachnoid is avascular layer, and the innermost layer is the pia mater, which is the most delicate one. So let's write few important points about this. So when I am talking about the few important points, write down layers of meninges. So I am here talking about layers of which meninges, dear? I am talking about the layers of the cranial meninges. We are talking about the layers of the cranial meninges. So here the outermost layer is the dura mater, which is the toughest one, which is the tough, opaque, which is tough, which is opaque, which is inelastic membrane, which is the inelastic membrane made of fibrous tissue. It is made of fibrous tissue. Now, inner to it, we have got the arachnoid mater, the arachnoid mater. And if I talk about the arachnoid mater, this is the first layer, this is the second layer. It is cobweb-like, delicate, it is cobweb-like, delicate avascular membrane. And what about the innermost layer? The innermost layer is the pia mater. And when I talk about the pia mater, it is actually adherent to the brain surface. It is adherent to brain surface. So it is adherent to the brain surface. Now, my dear aspirants, what happens? The arachnoid and pia, if I take the layer, if I take arachnoid and pia together, it is called as leptomeninges, and this was the question being asked in the previous year of exam. There they have exactly asked about this, which two layer constitute the leptomeninges. The answer is the arachnoid and pia together constitute as the leptomeninges. The dura mater is mesodermal in origin. What is the origin of the dura mater? It is mesodermal in origin, and that of the arachnoid and pia are ectodermal in origin, derived from the neural crest cells. So, okay, a quick revision of it. The three layers, the dura the toughest, being mesodermal in origin, the arachnoid and pia together is called as leptomeninges. If you want, you can write it also. Here itself you can write arachnoid matter plus the pia matter together is called as leptomeninges. Is called as leptomeninges. These are together called as leptomeninges. Okay. The other important point is the dura will be the Dura is mesodermal in origin and the arachnoid pia is ectodermal in origin. That means it is derived from neural crystal. Now, one of the important point about the dura mater is that if I talk about the dura, we are talking about which dura? We are talking about the cranial dura mater. Okay, we are talking about the cranial dura mater. So, if I talk about the cranial dura mater, it is made of two layers. It is made of two layers. So, the outer layer is, if I talk about the outer layer is endosteal layer. The outer is endosteal layer and the inner is the meningeal layer. The inner is the meningeal layer. Now, what happens? Actually, when we are talking about the spinal layers, they are different. Actually, there are few differences between the meningeal covering of the brain and the meningeal covering of the spinal cord. अगर हम cranial dura की बात, if we are talking about the cranial dura, it is just made of the two layers, the outer being the endosteal and the inner being the meningeal layer. Actually, these layers are adherent to each other except at certain reason. At certain places, they are not adherent to each other where they enclose. So, where they are not adherent to each other, they enclose as dural venous sinuses. And at times, the inner layer of the cranial dura mater is reduplicated and lead to the formation of dural septas, which is also called as the dural folds. Okay. So, please write on these 2 points. These two layers of, so these two layers of dura mater is adherent to each other. It's adherent to each other. It's adherent to each other and except where it contains dural venous sinuses. And the other important point is, this was the point 1 and the B point which I want to talk about here. The inner layer is folded. The inner layer of the dura mater is folded and this leads to the folding leads to the formation of dural septa. The inner layer is folded and it is folded and leading to the formation of dural septa or dural folds. This leads to the formation of dural septas or the dural folds. So, this is important points about the cranial dura. Now, what I want, the next important topic which I want you to explain is about the cranial dura folds, the dural folds, and together we have got 4 dural folds. So, together we have got the 4 dural folds. Before proceeding to that, I just want everybody to appreciate this image. Why? Because this is exactly, let me slightly enlarge it. If I am enlarging it, so I think it's quite visible to you. Now, when I enlarge this image, you can appreciate the layers. You can appreciate the layers of the scalp and that of the layers of the meninges. Now, here the point is that we are already knowing that the dura mater is having 2 layers, the endosteal, perosteal or the meningeal layer. And the splitting of these 2 layers, when these 2 layers are splitted up, it leads to the enclosure of dural venous sinuses. And beneath the arachnoid matter, we have got the subarachnoid space, and you can quite clearly see that the pia mater is adherent to the brain surface, that it is adherent to the sulci and the gyri of the cerebral hemisphere. Now, done with this. Now, all of you please appreciate this image. Actually, there are how many dural folds? There are together of 4 dural folds. So, if you want, you can just write it also. So, I am just enlarging this image here just to make you clear. So, please write down. Dural folds. Dural folds. When I am using the word dural folds, I mean to talk that how many dural folds together we have got. So, together we have to know about the 4 dural folds or the dural septas. You have to know about the flux cerebri. You have to know about the tentorium cerebelli. you have to know about the flux cerebelli and you have to know about diaphragma sella. Diaphragma cellae. So these are the 4 dural septas of the dural folds which you have to know. One by one we will talk about these. Okay. So one by one I will talk about these. So let's talk about the first, that is the flux cerebri. Now here in this diagram, if I am going to enlarge this, you can appreciate the sickle shaped fold. So exactly this is the flux cerebri. I am just going to enlarge this. I am just enlarging this image. So once I am enlarging this image, you can appreciate here. Let me set it for you. So we are talking about this dural folds. Can you appreciate? I'm just highlighting this image so that you can have an idea of the dural folds which I am talking about. It is the flux cerebri. It is the flux cerebri. Now you can see here this is the whole outline of the flux cerebri. Okay, so this is flux cerebri. So what is the shape which you can appreciate? It is sickle shaped and it is dipping in between the right and the left cerebral hemisphere. Exactly, it is dipping between the right and the left cerebral hemisphere. Actually, it is lying in the longitudinal fissure which is lying between the right and the left cerebral hemisphere. So it's important to know that it is attached. So exactly it will have an attached border and it will have a free border. So this is the anterior end. This is the ANT. This is the anterior end which is narrow and it is attached to the crista galli. It's attached to the crista galli, and when I talk about the posterior end is merging over the tentorium cerebelli. So what is this? This end is the POST, posterior, and this is resting over the tentorium cerebelli. So if I talk about the flux cerebri, the flux cerebri is sickle shaped fold of dura mater, sickle shaped fold of dura mater. Its narrow anterior end, is attached to crista galli and its broad posterior end, is attached to tentorium, upper aspect of tentorium cerebelli, Now, the next important point is that it will have a convex attached part which is attached to the sagittal suture. Its lower free margin will be concave. If I talk about lower aspect, lower free margin is concave, which is free, but its attached border is convex. The dural venous sinus. Yes, dear. Yes, Fawad, I am coming to that point. Fawad. Actually, the most important function. Yes, definitely, Fawad. Yes. So actually, when I talk about its function, the function is to enclose the dural venous sinuses. So अगर हम flux cerebri की बात करें, so here Fawad want me to talk about the function. The most important function of this is to enclose. The most important function attached to the flux cerebri is it encloses important dural venous sinuses. So exactly, dural venous sinuses also, and actually other function which I want to tell. So I am talking about that function. Actually what happens inside in the cranial cavity, it restricts excessive movement of the brain. So Fawad, for you I am telling it. So exactly what happens if it is lying inside the cranial cavity. For example, the next dural fold which I will talk about is the tentorium cerebelli. So you will see the tentorium cerebelli is saving the small brain, that is cerebellum, so that it is not getting crushed by the occipital lobe of cerebral hemisphere. So that means it is restricting excessive movement of the brain parts. Is it okay, Fawad? Okay, it is restricting excessive movements of the brain parts. Now, if I talk about the flux cerebri, it encloses the dural venous sinuses. Okay, so the important dural venous sinuses enclosed by flux cerebri are, so important, we'll come to this important points then, yeah. Important dural venous sinuses enclosed. So we are talking about important dural venous sinuses being enclosed by flux cerebri. So if I talk about the important dural venous sinuses being enclosed by flux cerebri is superior sagittal sinus. Yes, yes, medicine with Sahil is right, superior sagittal sinus. Then we have got inferior sagittal sinus. Yes, you are right. And what about the third? The third is straight sinus. Its third is straight sinus. You are absolutely right. You are absolutely right. A thumbs up goes for you. You are absolutely right. Now, the thing is that we have to see what I have actually told you is the flux cerebri is lying over the tentorium cerebelli. So, let's talk about that. So, I just want everybody to appreciate the another cadaveric image. So, I am just enlarging it. So, see here, if we talk about this is the flux cerebri. So, exactly what happened, the cranial cavity is opened up from the posterior aspect and you can see the two cerebral hemisphere lobes. So, these are the cerebral hemisphere lobes and here you can see this is the tentorium cerebelli. What is it? This is tentorium cerebelli. This is tentorium cerebelli and exactly you can see the tentorium cerebelli is lying just below the flux cerebri. So, flux cerebri posterior end is resting over. So, if we see this flux cerebri, it is resting over the tentorium cerebelli and a dural venous sinuses is enclosed here. So, there is an enclosure of dural venous sinuses which has been shown here, that is called as the straight sinus. So, you can also appreciate here, one important point, that our small brain, the little brain, that is called as the cerebellum, is not being crushed. It is not being crushed by the occipital lobe of cerebral hemisphere. It is quite protected. If there was no such kind of tentorium cerebelli, which was not lying in between the occipital lobe of cerebral hemisphere and that of cerebellum, the chances would happen that the cerebellum might be crushed by the occipital lobe of cerebral hemisphere. So, it is quite protective. So, that is the point. So, I just want to show you another image where you can see the dural venous sinuses enclosed by the flux cerebri. So, when I am enlarging it, you can clearly see this is the tentorium cerebelli which has been shown, this tent-like structure which you are seeing. And here you can see this is the flux cerebri. So, superiorly if you will see, in the superior aspect you can see a sinus, a dural venous sinus is enclosed. And what is the name of these dural venous sinus? Superior sagittal sinus. We have got inferior sagittal sinus and merging with that of the straight sinus. Also we can see it merges with that of the straight sinus. Straight sinus. So, that is all. Now, let's talk about the next fold, that is the tentorium cerebelli. So, we will talk about the next fold that is called as tentorium cerebelli. So, I just want everybody to concentrate here. I am just enlarging this image. So, when I am enlarging this image, so see here, when I am enlarging this image, this tent-like fold, so I am just highlighting this. Can you see here? This tent-like fold of the dura mater which you are seeing and this tent-like fold of the dura mater which has been appreciated in this image, you can clearly appreciate that this is the tentorium cerebelli. What is it? It is the tentorium cerebelli. It is tentorium cerebelli. Now, here I just want to show you This is the superior sagittal sinus. This is the transverse sinus which has been shown, and this is the straight sinus. So can you appreciate here? No, sorry, here this is the superior petrosal sinus, this is transverse sinus. So exactly, if I talk about the tentorium cerebelli, it is enclosing two sinuses. So here this is the attached border. If we talk about this border, this is A for attached border, and this is F for the free border. So this is F for the free border and this is A for the attached border. So when I am talking about attached border, it is enclosing two dural venous sinuses. So this is the superior, this is actually superior petrosal sinus, and this is the transverse sinus which is enclosed by it. And it is a tent-like fold which is saving the occipital lobe of cerebral hemisphere, not crossing the cerebellum below. So here another image is there, which I have already shown you also. Here we can see this is exactly the tentorium cerebelli, which is lying between, below we have got the cerebellum, above we have got the occipital lobes of two sides cerebral hemisphere. That means it is also restricting the excessive movement of the parts of the brain, and it is saving the cerebellum being not crushed. So that is important. So what is important? So let's write the important point about tentorium cerebelli. So if I talk about tentorium cerebelli, it is tent-like. It is tent-like semilunar fold of dura mater which forms sloping surface. It forms a sloping surface for posterior cranial fossa. So it is forming a sloping surface for the posterior cranial fossa and located between the occipital lobe of cerebral hemisphere and the cerebellum below. Now here one more point is important, please write down. The outer convex border anterolaterally is attached to the superior border of petrous temporal bone and also to posterior clinoid process. If I talk about the inner concave border, absolutely right, the inner concave border is free and it is actually enclosing a oval space structure. This space structure is called as tentorial notch. It is called as tentorial notch. Now anybody can tell me what is the importance of the tentorial notch? Which structure passes from the tentorial notch which is connecting two important areas of the brain? Can anybody tell me which structure traverses through the tentorial notch? Which structure traverses through the tentorial notch? Anyone? The structure traversing through the tentorial notch is midbrain, which is connecting the hindbrain and the forebrain. So got it? Now dural venous sinus is enclosed by it. So the next important thing is to know the dural venous sinus is enclosed. So write down dural venous sinuses enclosed. Dural venous sinuses enclosed. And the dural venous sinuses enclosed are two. One is superior petrosal sinus. Superior petrosal sinus, and the other is transverse sinus. Absolutely right. So if I talk about the superior petrosal sinus, it is enclosed in the anterior half of the attached border. And if I talk about the posterior part, posterior half of it attached border, it is enclosing the transverse sinus. It is enclosing the transverse sinus. So we have done with this, and the next important point which I want everybody to know is to know about the flux cerebri and diaphragm sella. So let's move on to the next image. So let's talk about flux cerebelli. So if I am talking about flux cerebelli, it's a small fold of the sickle cell fold of dura mater. So in this image only you can see this small fold. We are talking about this small fold, this small sickle cell fold of dura mater, that is flux cerebri. It is exactly lying between the or intervening between the two cerebellum hemisphere. Yes, along the line of internal occipital crest. You are absolutely right, dear. You are absolutely right that you are absolutely right that it is attached to internal occipital crest. So, write down flux cerebelli. So, if I am talking about flux cerebelli, it is a small sickle. It is a small sickle shaped fold of dura mater. And it intervenes between two cerebellar hemisphere. It is attached to internal occipital crest. It is attached to internal occipital crest, and it encloses one dural venous sinuses that is called as occipital venous sinuses. So, it is enclosing one dural venous sinuses that is called as occipital venous sinuses. So, what does it enclose? It encloses just one sinus, and what is its name? Occipital sinus, venous sinus. It encloses occipital venous sinus. So, done with this? Yes, right. You are right. Absolutely, you are right. Now, let's talk about diaphragm sella. The other name of diaphragm sella is, it is called as, if I talk about the another name of diaphragm sella, it is also called as Tentorium hypophysis. Hypophysi. Tentorium hypophysi. It is also called as Tentorium hypophysi. Diaphragm sella is a small fold of dura mater. If I talk about diaphragm sella, it's a small fold of circular fold of dura mater. So here this is the diaphragm sella. So you can see here this is the diaphragm sella. It's a small circular fold of dura mater, and this circular fold of dura mater is having a gap, and through this gap passes the pituitary scalp. I would like to show you another image. Can everybody appreciate this image? So you can see there is a gap in the diaphragm sella, and through this gap the structure which is traversing is the pituitary scalp. Which structure is traversing? The structure which is traversing is called as the pituitary scalp. So please write down that about diaphragm sella. Diaphragm sella is a small circular fold of dura mater. It's a small circular fold of dura mater. It's a small circular fold of dura mater which roofs the pituitary fossa. It roofs the pituitary fossa, the sella turcica, and it is having a gap in the center. So what we have seen a gap in the center, and that gap in the center is an opening for the stalk of pituitary gland. So it is having a gap in the center, and that gap in the center is for the pituitary stalk. It's for the stalk of pituitary gland. Done with this. Now let's talk about the hematomas. So let's talk about the hematoma. So if I talk about so exactly it is important to know about the extradural hematoma, and it's important to know about the subdural hematoma. So actually there are two types of hematoma which I want everybody to understand. So अगर हम बात करते, so actually in this diagram you can see we are talking about the hematomas. The other name of extradural hematoma is also called as epidural hematoma. So if there is a injury to the skull lateral aspect, if it is a direct injury on the skull to the lateral aspect, what happens? On the lateral aspect there is a suture. The name of that suture is terion. It is an H-shaped suture, and there is the location of the frontal or anterior division of frontal trunk of the middle meningeal artery. So there is a direct injury on the on this artery, and there is a bleeding leading to the accumulation of epidural or extradural hematoma. So exactly there are two types of hematoma, and the basic difference between both the types should be known to you. The other name of extradural hematoma is epidural hematoma, and mainly the bleeding is because of the middle meningeal artery. So what is the source of bleeding? The source of bleeding is from the middle meningeal artery. But in case of subdural hematoma, the communicating bridging vein is there, and the bleeding is from the bridging vein. So the bleeding is from the bridging vein. Actually, in case of extradural hematoma or epidural hematoma, there is lucid interval. No such kind of lucid interval is present in subdural hematoma, which is most serious condition. The most serious condition is subdural hematoma, and the prognosis is not so good as that of epidural or extradural hematoma. So done with the clinical aspect, I would like quickly to tell you about the arterial supply. So if I am talking about the arterial supply, the anterior cranial fossa is mainly getting its arterial supply from anterior meningeal artery. Middle cranial fossa is from middle meningeal artery, and or some meningeal arteries which is accessory meningeal, which is a branch from maxillary artery. If I talk about posterior cranial fossa, it has got multiple source of arterial supply from posterior meningeal arteries, from the meningeal artery which is a branch of ascending pharyngeal artery, meningeal branches of vertebral artery and occipital artery. So what we can appreciate in short, that the dura mater of the anterior, posterior, middle cranial fossa has got a multiple source of blood supply. Now the question has been asked about its nerve supply. अगर हम nerve supply के, if we are talking about the nerve supply, now exactly we can divide the whole of the interior part of the dura into supratentorial compartment and innervation of infratentorial compartment. So supratentorial dura mater is getting innervation from the meningeal branch of all the three division of trigeminal nerve. So what do you understand by V1, V2, V3? Any idea? It is called as ophthalmic, maxillary and mandibular division of trigeminal nerve. So here V1. Okay dear. So Korean Queen is telling, ma'am, please explain slightly slowly. Okay. Okay. So here, if I talk about the nerve supply of the dura mater is from multiple sources. So it is getting its innervation or nerve supply from multiple sources. It is getting innervation from the trigeminal nerve, which is having three divisions. What is the three divisions, dear? We have got the ophthalmic, we have got the maxillary, we have got the mandibular division. So these are three divisions of the these are the three divisions of trigeminal nerve which is giving innervation. The innervation of infratentorial dura is from the cervical nerves and also the branch of vagus. So exactly these are the source. Other than that, it can also receive innervation from the other sources. So sometimes vagus nerve is there, other sources are also there, which is forming an important source of innervation. So we have got possibly the source can be. So most common sources from the cervical, ophthalmic, maxillary, mandibular. Other than that, it can also receive innervation from vagus nerve, also from 12th cranial nerve at times, also from that of the facial nerve sometimes. Now, arachnoid matter. What is the next layer? The next layer is the arachnoid matter, which is the avascular membrane. and it is whole covering the brain. If I talk about the layer, it is lying inside the dura mater. What about arachnoid matter? It is located in the interior of the dura and it is thin transparent. It is thin and transparent and it is avascular. So what is important for you to note down that if this is the arachnoid matter, below arachnoid matter we have got subarachnoid space. And what does subarachnoid space contains? Everybody is knowing that subarachnoid space is containing cerebrospinal fluid. Subarachnoid space is containing CSF. What it contains? It contains CSF. It contains subarachnoid fluid. It contains subarachnoid fluid. It contains CSF, cerebrospinal fluid, and it's very important that there is certain arachnoid villi in the certain dural venous sinuses, most commonly with the superior sagittal sinus, the absorption of the CSF takes place. Okay, now I would like to tell you about arachnoid villi. When I am telling you about the arachnoid villi, so अगर हम arachnoid villi की बात करते हैं, we are talking about arachnoid villi. They are small finger-like projections from the surface of arachnoid matter, and the function of these is to absorb the CSF. So they project in the dural venous sinuses, and the important function is absorption of CSF. Is it okay? The tuft of arachnoid villi will lead to the perforation of the dural venous sinuses, and they will also help in conveying CSF to the blood sinuses. Now, I would like to tell you about some of the location of the dural venous sinuses. So actually, I would like to talk about the subarachnoid space, and the certain area, the subarachnoid space is having substantial amount of cerebrospinal fluid. So that is called as subarachnoid cistern. What is it called as? Subarachnoid cistern. So is it okay? Is it okay? Is it okay? Are you understanding? Please let me know. Are you understanding? If we are talking about subarachnoid cistern, the location of subarachnoid space is that it contains CSF. What it contains? It contains CSF. So below the arachnoid layer, below the arachnoid matter, there is subarachnoid space, and in certain location the subarachnoid space is having substantial amount of CSF. So it is having substantial amount of CSF. So it is slightly dilated, and that area is called as subarachnoid cistern. So it is important that we should know which important structures are residing in this subarachnoid cistern. So I would like to slightly enlarge it. So if I am enlarging it, you can appreciate. So the important cisterns are, so you can see here, that is cisterna magna. The first cistern which has been written here is the cisterna magna, that is the cerebellomedullary cistern, and by the name only it is clear that it is lying between the medulla oblongata and the inferior aspect of cerebellum. The next is the pontine cistern, that is also called as the cisterna pontis, and it located on the ventral aspect of the pons. Okay. So if you are remembering this, so just concentrate on the name. Okay. Don't see the entire thing. I will just explain the name and you can understand it. Okay. When I am using cistern means the area where there is more amount of cerebrospinal fluid in the subarachnoid space. The important cisterns are cerebromedullary cistern, which is also called as cisterna magna. If I am using the word magna or cerebromedullary cistern, it means it is lying between the medulla and the cerebellum. Pontine cistern lies on the ventral aspect of pons. Interpeduncular cistern is located in the interpeduncular space. Cistern of lateral sulcus. We know that on the cerebral hemisphere we have got the sylvian or the lateral sulcus. So in relation to that we have got the lateral sulcus. We have got the cistern of the of this lateral sulcus. Great cerebral vein of Galen cistern is also called as cisterna ambiens. It is located in relation to the splenium part of corpus callosum. So exactly what happens, if you will see the corpus callosum, so exactly अगर हम cisterna ambiens की बात करते हैं, we are talking about cisterna ambiens. It is located below the cerebellum. We have got a corpus callosum, the white fibers. Below the posterior part of it is called splenium. So below it we have got cisterna ambiens. So what is the name of important cistern? Cerebellomedullary cistern, pontine cistern, interpeduncular cistern, cistern of lateral sulcus, and that of cisterna ambiens. Cisterna ambiens is lying in close relation with the splenium of corpus callosum. So here pontine cistern is containing the basal artery, interpeduncular cistern is containing the circle of Willis. Sylvian cistern is related with the middle cerebral artery, and the cistern of great cerebral vein of Galen is containing the great cerebral vein of Galen. Okay. Now this is done. I just want to show you the important cistern. So can you see this image? This is an image of sagittal section. Here we have got interpeduncular cistern on this location. We have got pontine cistern that is related with the pons. This is pons. We have got great cerebral vein of Galen. Actually, this is corpus callosum, and this part is the splenium of corpus callosum. So below the splenium of corpus callosum, we have got great cerebral vein of Galen, and here we have got the in between the cerebellum and medulla. This is M for medulla and this is C for cerebellum. So this is the area of the cerebromedullary cistern. So actually these are certain areas where important cisterns are located. These are certain areas of the brain where important cisterns are located. Done with this. Now in this diagram, I want you to show the pia mater. Can you see here? This is exactly the layer of arachnoid and the pia, and pia mater is quite adherent. It's a transparent vascular membrane. It is a transparent vascular membrane. It is adherent to the brain surface. Now important function of the pia mater is, it is important to know the function of the pia mater. So pia mater is actually many vessels are going in and out of the brain surface. So pia mater is covering it. So they are forming perivascular sheath. Pia mater is forming perivascular sheath around the vessels, entering and leaving the brain. Okay. So please let me know, Fawad and Korean, Kyun and everyone, are you understanding? My pace is okay? It is forming perivascular sheath. It is forming perivascular sheath around the vessels. Okay, around the vessels, entering and leaving, entering and leaving, entering and leaving brain surface. So other than that, pia mater is also forming tila chorioida. So it's also important that pia mater is also forming tila chorioida. Pia mater is also forming, so it is also forming tila. So after this, we will discuss few MCQs also. It forms tila chorioidae of third and fourth ventricles. Now I just want you to tell about epidural hematoma or hemorrhage. So exactly अगर हम epidural hemorrhage और hematoma की बात करते हैं, तो exactly if we are talking about this, I told you the epidural or extradural hemorrhage occurs due to the rupture of which artery? What is the name of that artery? The artery. So actually if there is a direct hit on the lateral aspect of the skull, there can be bleeding from the middle meningeal artery, which is located at the H-shaped suture called Terion, and this could lead to the extradural or epidural hematoma. Now let's solve few MCQs. Let's solve. So all of you please try to solve this, those who are live. Okay. Yes, you are right, Fawad. Yes, you are absolutely right, Fawad. Now the next thing is dura mater is supplied by all the cranial nerve except. So my question to you here is, please try to solve this. All of you, please try to solve this. Dura mater is supplied by all the cranial nerve. Yes, yes, Krista Medins. Yes, dear. Yes. So Crystal Medico is telling 12. Okay, Cristo Medico is telling 12. What about others? So I got an answer from Maphosa who is telling 4. I got a mixed answer. So I am getting 12, 4, 12, 4, which is the right one. So those who have given the answer, those who are given the answer 4 is absolutely right. Absolutely right. 4 is absolutely right, because you just note down dura mater is most of the time supplied by C2, C3 spinal nerves, spinal segment of the nerves. It is supplied by V1, V2, V3, that is ophthalmic, maxillary and mandibular nerves most of the time. It is also getting innervation from vagus nerves sometimes, not always. Sometimes it can get innervation by the 12th cranial nerve, and possibly sometimes also by the facial nerve, and possibly also from the 9th cranial nerve. Okay, these are rare cases, but never by 4th cranial nerve. So can you tell me, 4th cranial nerve is giving innervation to which structure? Never by the trochlear nerve. 4th cranial nerve is giving innervation to one muscle. What is the name of that muscle? It is not giving innervation to dura mater. What is the answer? It is giving innervation to dura mater, supplied by all cranial nerve except. So exactly what will be the answer? It is giving innervation to lateral rectus. No, lateral rectus, Crystal. Lateral rectus is by 6th cranial nerve. Can you remember this? Yes, superior oblique. Absolutely right, Fawad. Absolutely right. Yes. Superior oblique, SO4 LR6. SO4 LR6. Lateral rectus is supplied by 6th cranial nerve, and superior oblique is supplied by the trochlear nerve. You're absolutely right, dear. You are absolutely right. Now, all of you, please try to solve this. Actually, head and neck has not been done. So I am going other way. Actually, head and neck is not done, but I'm going. So I'm going the other way. I'm just checking your messages also. So exactly, agar head and neck if we have already covered head and neck, then I would have told you about the important arteries. So we are going the other way. But then also try to solve it. Let me slightly enlarge this and read it for you. So I think it's visible to you or not. Yeah. So a 23-year Caucasian female is brought to emergency department unconscious after a motor vehicle accident. A linear skull fracture is seen at the junction of four bones, the frontal, the parietal, the temporal and the sphenoidal. So that is a hint which is giving you the which suture it is involving. And can you tell me the important artery being injured or severed at this place? Occipital, maxillary, middle cerebral, ophthalmic or sphenopalatine. So the time starts now, and my dear students, this is a question being asked for the NEET PG exam previously. Can you tell me the right answer? So I would like to give you few seconds to solve. What is the right answer here? What is the right answer? Middle meningeal artery. Yes, yes, middle meningeal artery is the right answer, but there is no middle meningeal artery in this. So Crystal, you are right. Middle meningeal artery is the right answer, but in the option middle meningeal artery is not given. But in the option middle meningeal artery is not given. That means you have to tell me that middle meningeal artery is a branch of which artery. That will be the right answer. So the hint for your correct answer is middle meningeal artery is a branch of which artery? That will help you to give the right answer. Middle meningeal artery is a branch of which artery? Maxillary. No, yes, absolutely right. Now I got the right answer. The correct answer is maxillary artery. Absolutely right. Middle meningeal artery is a branch of maxillary artery, and because of that, maxillary artery is the right answer. Absolutely correct. Yes, absolutely correct. Now I just want everybody to concentrate on this image. Actually, in this image, you can see this is the edge-shaped suture. So this is an edge-shaped suture. Okay. So here this P is for parietal bone, this F is for the frontal bone, this T is for temporal bone, and this S is for the sphenoid bone. So what we can appreciate in this image, that the four bones are meeting at a H-shaped suture, and that suture is called as the pterion. What is it called as? It is called as the pterion. That is, it is the meeting point of temporal, it is the meeting point of frontal, it is the meeting point of parietal, it is the meeting point of sphenoid bone. And exactly that is the point where we have got the location of middle meningeal artery. Middle meningeal artery. So you can see here the four bones which is exactly uniting at this place with the H-shaped suture called as pterion, and this H-shaped suture is the location of middle meningeal artery, and we know that middle meningeal artery is a branch of first part of maxillary artery. It's a branch of first part of maxillary artery. So that is the reason we will mark maxillary artery as the right answer. Got it? So my dear students, if you have got any doubt, please write it. Everybody, is it okay? The question is right. Any doubt? Any doubt you are having? Okay. Now let's talk about intradural venous sinuses. So actually the formation of, so the next topic, we have completed one of the topic. We have completed one topic. Now coming to the next topic, we are going slightly slow because students are telling me to go slow. But we have to complete the neuroanatomy today. Okay. So please, we can slightly increase our space. Actually, this is not the session of whole day. I will try to take the session longer, but please let's start with the second topic. Intradural venous sinuses. Intradural venous sinuses is, there are two ways to form intradural venous sinus. The two ways are separation of the dural folds. So we have already seen the dura mater is made of two layers. We have got the endosteal layer and we have got the meningeal layer. So if I am talking about the dura mater, it's made of two layers, and if there is a suppression of these two layers, there is formation of dural venous sinuses which is located here, and also it is formed by the reduplication of the meningeal layer. So two reasons. So I just want to tell two reasons for the formation of the intradural venous sinuses is, okay. So it's craniotomy, dear Crystal. It will be a craniotomy. Okay, Crystal. So two ways of separation of the cranial dura mater. It's by the separation of two layers. It's by the separation of two layers of cranial dura mater. And the second reason is by reduplication of meningeal layer. Okay. Okay. So this is the reason which will lead to the formation of dural venous sinus. So it is important to know the important features of the dural venous sinuses. So let me just check with you. Okay, Okay. Okay. So exactly, it's important to know there are certain features which is common to all these dural venous sinuses. So let me just check with the live chat. Yeah. So there are certain features which has to be no, so they so I actually, Crystal, I'm not getting your point. There is one procedure that is called as craniotomy. Clidodectomy is the clavicle being removed, and craniotomy is the burr hole which is made in the cranium to drain out the blood. Okay. Okay, so so now if I talk about the features, they are located between the two layers of the dura mater. They have not got any smooth muscle in their wall, and they are just lined by endothelium. Okay, like if I am talking about the histological aspect and the features of the veins and the vessels, there are certain features in the case of intradural venous sinuses which is separate. Okay, if I am talking about intradural venous sinuses, they are not having valves. So what is the importance? Can anybody tell me? Can anybody tell me here what is the importance if there is not having any valves here, or what is the disadvantage of not having valves in the dural venous sinuses? Can anybody tell me? Can anybody give me the answer? Anybody who wants to give me the answer? Okay, Dr. Puneet is telling, please repeat. Okay. Now, my question is that generally veins has got valves, but dural venous sinus is an odd man out. It is not having valves. So, what will be the importance of it or disadvantage of not having valves in the dural venous sinuses? Dr. Puneet Med, disadvantage of not having any valves in the dural venous sinuses. Okay. Crystal, you can also give the answer. Fawad, you can give the answer. And other Mephosa, everyone can give the answer. And your clinodectomy, supraciliar tumors, okay, actually that neurovascular approaches is done by this surgical procedure, okay. So actually the blood, I will give you the answer, the blood can flow in either direction. So the advantage of, if I talk about the advantage of valves is that this provide unidirectional blood flow. But if there is no valves, what will happen? The blood which is flowing inside the intracranial dural venous sinuses can flow in either direction. That means infection which is lying on the exterior of the scalp can be drained into intradural venous sinuses. So these are certain features, okay. So if I just talk about the features, yes, you are absolutely right, Dr. Punit. You are absolutely, a thumbs up goes for you. A thumbs up goes for Dr. Punit. Yeah. So exactly what happens, no valves, no smooth muscles, no smooth muscles in their wall, receive, they receive valveless emissary veins, lies between, yes, that is right, lies between layers of dura mater, receive venous blood and CSF. Okay, so exactly these are certain points which is common to all dural venous sinuses. So the next important thing is to know the important dural venous sinuses. So in the previous year of examination, the question has been asked about also about the paired and unpaired dural venous sinuses. So there was a question regarding this. So there was a question regarding the paired and the unpaired dural venous sinuses. So I just want everybody to note down that list. Okay, so if I am talking about the paired, so you can see the important unpaired dural venous sinuses: superior sagittal sinus, inferior sagittal sinus, the straight sinus, the we have got posterior and anterior intercavernous sinus, which is not shown here, and we have got basilar venous plexus. They are unpaired, but the paired one is we have got the cavernous sinus as the paired. We have got transverse sinus. Occipital sinus is unpaired. So exactly, I just want everybody to write on the list of dural venous sinuses. So please complete the list. So you can just write down the list of unpaired dural venous sinuses. Unpaired dural venous sinuses. So if I am talking about unpaired dural venous sinuses, they are superior sagittal sinus, they are inferior sagittal sinus, then there is inferior sagittal sinus, there will be inferior sagittal sinus, there is occipital sinus, there is anterior and posterior intercavernous sinus, there is also an anterior and there is a posterior intercavernous sinus. There is also basilar venous plexus. Inferior petrosal sinus. Inferior petrosal sinus is paired one. Dr. Punit, your if we talk about inferior petrosal sinus, that is paired one. Now, firstly, I am writing the list of unpaired dural venous sinuses. Unpaired dural venous sinuses. So now we will write the list of paired dural venous sinuses. Now the list of paired dural venous sinuses. So the important paired dural venous sinuses are following. So please write on the list. The list is, we have got cavernous sinus in this list. Yes, you are right, Dr. Punit. There is superior petrosal sinus. There is inferior petrosal sinus. There is sigmoid sinus. There is sphenoparietal sinus. There is petrosquamous sinus. These are important paired dural venous sinuses. These are important paired dural venous sinuses. Now, the next topic which I want everybody to understand is the cavernous sinus. Done? I would also like to show you a image here that is called as confluences of sinus. So you can just see this is confluences of sinus, and here you can appreciate on the level of confluences of sinus, important sinuses like superior sagittal sinus is meeting with the straight sinus. You can see here we have got a location of straight sinus, superior sagittal sinus, and we have got the transverse sinus. So here exactly this is the location. So this is exactly the location of meeting of these all sinuses, okay, and this is called as confluences of sinus, where we have got the meeting of occipital sinus, superior sagittal sinus, straight sinuses and transverse sinuses meeting. Now the next thing is to know the cavernous sinus. Yes, great cerebral vein of Galen also. Yes, great cerebral vein of Galen also. Yes. Now, come to the next topic, that is cavernous sinus. So, if I talk about cavernous sinus, actually cavernous sinus is an important topic not only for NEET PG but also for your FMG INICT examination. So, let's talk about cavernous sinus. So, I would like to complete this topic slightly detailed. So, exactly cavernous sinus are located in either side of sphenoid body. Yes, you are right. It is located on either side of body of sphenoid. And where it is located? It is located in middle cranial fossa. And it is exactly, you have to know the important points of the cavernous sinus. So, for that I would like to show you this image. So, if I am enlarging this image, if I am just enlarging this image, can you see here? So, I am just enlarging this image, and when I enlarge this image, you can appreciate this is the cavernous sinus which has been outlined, and this cavernous sinus is located in the either side of the body of sphenoid, and this is what is this structure which I am talking? So, this is exactly the middle cranial fossa in which it is located on the side of the body, and here you can see it is extending from the apex. So, exactly this part is the petrous bone, and this is superior orbital fissure. So, one more image I will show you. Yes, see this image. So, this is showing the location and extent. So, if I enlarge it, you can see the cavernous sinus which I am talking about. It is extending from the, its apex is lying close to the, its apex is lying. So, its apex is lying close to the superior orbital fissure, and its posterior end is lying over the superior petrosal sinus. So, it is extending anteriorly to superior orbital fissure and posteriorly to the level of superior petrosal sinus. Cavernous sinus. So, if I talk about cavernous sinus, it extends antero-posteriorly from superior orbital fissure, close to superior orbital fissure, to apex of petrous temporal bone. Done? Done. Now I would like to show you another image. So, I just want to slightly enlarge it. So, when so here I just want you to show this blue color structure which you are seeing is the cavernous sinus, which is actually having trabeculae inside. And so, here you can see on the superior aspect it is related to, this is the cavernous sinus. Superiorly it will be related to internal carotid artery, it will be related with the optic chiasma. Medially it is related to the pituitary gland. Medially, it is related to the pituitary gland and that of sphenoidal sinus, SS for sphenoidal sinus. Laterally, we have got the temporal lobe of the cerebral hemisphere, and exactly anterior and posterior extent we are already knowing. In the lateral wall of cavernous sinus, we have got basically oculomotor nerve, trochlear nerve, we have got also the ophthalmic and maxillary nerve. You can see this is the abducens nerve and ICA, internal carotid artery, which is exactly traversing. If we see the internal carotid artery and abducens nerve, it is going to and fro inside the cavernous sinus. So, exactly it is passing to and fro inside the cavernous sinus. Okay. So, these are important relations of the cavernous sinus. You can just write down this. Relations of, yes, Dr. Punitam, you are right. Relations of cavernous sinus. So if we are talking about the relations of cavernous sinus, we have got following structures related to it. Laterally, it is related to temporal lobe of cerebral hemisphere. Superiorly, it is related to ICA, internal carotid artery and optic chiasma. Medially, it is related to sphenoidal air sinus. Pituitary gland, pituitary stalk or pituitary gland. So actually I am not writing the anterior and the posterior extent, which we have already done. Anteriorly, if you talk, so if you want, you can write anteriorly. As I told you, it is related to superior orbital fissure close to the apex of orbit, and posteriorly you can see it is related to the petrous part of temporal bone. Now it's also important to know the forecranial nerve which is traversing in the lateral wall of cavernous sinus. So let's see that. So exactly, this is also important for you to note down. So write down cranial nerves in lateral wall of cavernous sinus. So that is cranial nerve in the lateral wall of, or nerves in the lateral wall of cavernous sinus. So the nerves in the lateral wall of cavernous sinus are following: oculomotor nerve, trochlear nerve, ophthalmic division of trigeminal nerve, and also sometimes maxillary division of trigeminal nerve. Now these are the four nerves. So many times the MCQ has been asked, and these are the four nerves which is lying in the lateral wall of cavernous sinus. Other than that, it is also important to know the two structures which is traversing through the cavernous sinus. So structures passing through the cavernous. The next point will be structure passing through cavernous sinus. So if I talk about the structures passing through cavernous sinus, the structures are two structures are there. One is internal carotid artery and the other is sixth cranial nerve or abducent cranial nerve. So what do you mean? That means that all the nerves which is giving innervation to the extraocular muscle is related to the cavernous sinus. So that means if there is an injury in the cavernous sinus, there is a cavernous sinus thrombosis condition, there will be the involvement of nerve giving innervation to extraocular muscles. So let's talk about communication. So done with this. Now I would like to tell about the communication and tributaries of the cavernous sinus. So exactly, I just want to enlarge this image. So when I am enlarging it, you can appreciate the tributaries of cavernous sinus. So these are tributaries of cavernous sinus. Okay. So if I am talking about the tributaries of cavernous sinus, you can just so we Please breathe. Okay, I will just, yeah. Wait a minute. Okay, we were in which slide? Just a minute. Oh yeah. Okay, I will once open this, just a minute, the screen. Okay, where were we? We were in the, it's okay, okay dear. Coming to this, okay, coming to that part. We were in the cavernous sinus, okay, just a minute. Okay, so I just want you to tell about the tributaries of the cavernous sinus. So when I talk about the tributaries of the cavernous sinus, there are three sources of tributaries of the cavernous sinus, and that three sources are from, so you can just see there is a source from the, okay, so three sources of tributaries, that is the blood is directly draining into the cavernous sinus. So one is from the orbit, the other is from the meninges, and the other is from the brain, and the other is from the brain. So we have got these three sources, as you can see. So from the meninges, from the brain, so we have got these three sources of the tributaries which is draining blood directly. Okay. So I just want that you should know the name of these tributaries. The word tributary means the blood is directly draining into cavernous sinus. So when I am talking about the orbit, three veins are carrying blood to the blood directly in the cavernous sinus, and these are superior ophthalmic vein, inferior ophthalmic vein, central vein of the retina. From meninges, we have got two sources, that is sphenoparietal sinus, middle meningeal vein, and from the brain we have got superficial middle cerebral vein and inferior cerebral vein. So three vein sources from the orbit: superior ophthalmic vein, inferior ophthalmic, central vein of the retina. From meninges we have got sphenoparietal and middle meningeal vein. From the brain we have got the inferior cerebral vein and superficial middle cerebral vein. Actually, what is important for you is to know the name of all these veins, because they are carrying directly blood to the cavernous sinus. The other thing which you can see is the draining channels and the communication. So it is important that you should know important communications and the tributaries. Tributaries is already mentioned in this image. So I just want everybody to write important communication. So please write down important communications of cavernous sinus. Important communications of cavernous sinus. So important communications of cavernous sinus are following. So we have got the communications. So if I talk about transverse sinus, transverse sinus is communicating with the superior petrosal sinus, and just draining the blood in the cavernous sinus. The other communication is via inferior petrosal sinus. The communication is formed. The communication is going towards the internal jugular vein. So are you understanding? Are you understanding? Few communications are important. Okay, Dr. Punit and everybody, few communications are important. Okay. Other than that, we have got the communications like other communications. For example, we have got a anterior and posterior intercavernous sinus communication. Anterior and posterior intercavernous sinus communication. Now, other than that, few more communication. One of the communication is very important, that is via facial vein. So, one of the communication is very important, that is via facial vein. Why this is very important, I will tell you. Actually, this is a route of infection. So, the dangerous area of the face or the dangerous triangular area of the face, the infection can drain inside the cavernous sinus, dural venous sinuses and leading to cavernous sinus thrombosis. So, there are two routes of communications. Two important routes of communication is there. One is superior ophthalmic vein. This superior ophthalmic vein will communicate with angular vein. The angular vein will communicate with the facial vein. The facial vein will communicate with the emissary vein. So, actually one of this communication which I want directly, we will talk about superior ophthalmic vein, and this is communicating with the angular vein and the communication is via facial vein. The other route of communication will be via emissary vein. So, emissary vein communicate with pterygoid venous plexus and will communicate with the deep vein, deep facial vein, and hence it communicates with the facial vein. So, these are the two routes of communication. Deep facial vein. So, exactly these are the two routes of communication which is very, very important for you to understand. So, done. Now, I would like to talk about, these are the most important communications which I have mentioned. Other than that, there is few more communications. So, we were in the anterior, posterior, and this is the fourth, that is the facial vein, and the other communication is, one of the important communication is also via superior sagittal sinus, triple S. I am writing triple S for superior sagittal sinus, which is forming communication via superior middle cerebral vein. Superior middle cerebral vein, and this will form the communication via superior anastomotic vein. The other route of communication is internal vertebral venous plexus, internal vertebral venous plexus, and this forms communication with the basilar venous plexus. So, these are few important communications. I would like to talk about cavernous sinus thrombosis. Actually, cavernous sinus thrombosis is a condition where the infection from the external aspect is reaching into the interior of cavernous sinus and leading to cavernous sinus thrombosis. So, basically the clinical features, if I talk about the clinical features which is seen in this patient of cavernous sinus thrombosis is, the patient will complain of severe pain in eyes and the forehead. The patient will complain of severe pain in the eyes and the forehead, and the reason of this severe pain is due to the involvement of ophthalmic nerve, and we know that ophthalmic nerve is giving sensory innervation to forehead and the eye area. So, this is due to the reason of, due to involvement of ophthalmic vein. As we already know, the ophthalmic vein is an important vein lying in the, we know that ophthalmic vein is an important vein lying in the lateral wall of cavernous sinus. So, due to cavernous sinus thrombosis, the ophthalmic vein is involved and it will lead to severe pain in the eye and the forehead region. Also, this was one of the clinical aspects and the features. Other than that, yes, abducens nerve means sixth nerve. Yes, you are right. So we know that the third cranial nerve, the oculomotor nerve, the trochlear nerve, the abducen nerve. So if all these nerves are also involved, what will it cause? It will cause the paralysis of extraocular muscle, and the patient will have so exactly the patient will have also will have ophthalmoplasia. So all the extraocular muscles are paralyzed. Also the patient will have marked edema in the around the eyes, and the patient will have exophthalmos because of the congestion. What is the reason of exophthalmos which is seen in the cavernous sinus thrombosis? So the reason is congestion. The reason is due to congestion of ophthalmic vein, congestion of ophthalmic veins. So done with this, I just want you to show the image. Actually all the nerves which is giving innervation to extraocular muscle will be involved, and it will lead to the paralysis of extraocular muscle and causing the ophthalmoplasia, edema, marked, the eyes is bulging out, exophthalmos is there. Now let's talk about MCQ. So I just want to solve few MCQs related to this topic. So is it okay? Can we have an MCQ session? Yes. So septic emboli, all of you can take your time of few seconds and you can give me the right answers. All of you, I just want everybody to take a time of few seconds and give me the answer. Septic emboli in the facial vein can cause cavernous sinus thrombosis because facial vein makes clinically important connections with the cavernous sinus. The most commonly involved communicating vein is superior ophthalmic vein, deep facial vein, inferior ophthalmic vein, and pterygoid venous plexus. So yes, so it's a very good thing. So okay, so I got students from Southern Sudan. Okay, so that's great. That's really great. Thank you, doctor. So can everybody please take your few seconds and you can give me a correct answer. The septic emboli of the facial vein forming cavernous sinus thrombosis. So here the facial vein, clinically important connection being formed with the cavernous sinus. So can you tell me the important vein involved as a communicating vein and forming this communication? The most common answer will be pterygoid venous plexus, inferior ophthalmic vein, deep facial vein, or superior ophthalmic vein. That means I am asking the most common pathway of infection causing cavernous sinus thrombosis. So I am just giving you a hint. I have given you two communications and you have to pick the first communication, and that is the right answer. The correct answer will be superior ophthalmic vein. The correct answer is superior ophthalmic vein. Superior ophthalmic vein communicating with the angular vein and then forming the communication with the facial vein. Now, all are the features of cavernous sinus thrombosis except all of the following are the features of cavernous sinus thrombosis except the option are papilloedema, proptosis, sensory deficit on the face due to the involvement of three branches of the trigeminal nerve, external ophthalmoplasia due to the compression of motor supply of extraocular muscles. So can you just tell me the right answer? So Dr. Punit is telling C. Not all three branches. Yes, Punit is absolutely correct. So Dr. Punit, a thumbs up goes for you. So yes, Punit, you are absolutely correct. The correct answer is sensory deficit of face due to the involvement of three branches is wrong because mandibular nerve is not involved. Only ophthalmic and maxillary nerve is injured in the case of cavernous sinus thrombosis. The mandibular nerve is not involved in this case. So absolutely the C is the right answer. Yes, a thumbs up goes for you, and also a thumbs up goes for Abraham. Abraham, again a thumbs up goes for both of you. Which of the following is not a tributary of cavernous sinus? So please tell me which of the following is not a tributary of cavernous sinus. Sphenoparietal sinus, superior petrosal sinus, superficial middle cerebral vein, inferior ophthalmic vein. So we have got 4 options and you have to give me the right answer. Which is not a tributary of cavernous sinus? Yes, the answer is 2. Yes, Abraham, you are right. The superior petrosal sinus is not a tributary, direct tributary. It is a communication. Yes, you are right. The correct answer is 2. It is a communication. It is a communication. It's not a tributary of cavernous sinus directly. Following are the tributaries of cavernous sinus except. So, can you tell me which is the odd man out, which is not a tributary of cavernous sinus? Superior ophthalmic vein, central vein of the retina, the great cerebral vein, the inferior ophthalmic vein. So, can you tell me which is not exactly the tributary of cavernous sinus? C is absolutely right answer. Great cerebral vein of Galen is not a tributary of cavernous sinus. Yes, again a thumbs up goes for you. Absolutely correct. Now, let's move on to the next topic, that is ventricles of brain. Let's talk about the ventricles of the brain. So, if I talk about the ventricles of the brain, it's again another topic. So, don't worry students, I will give you a break after some time, okay. So, so I just want to continue because we have to finish the whole neuroanatomy today. So, I will give you a break after some time. We will have a break, don't worry about this. So, ventricular system of the brain. So, we have to know, so if I talk about the ventricles, oh, thank you dear, thanks. Okay, so exactly if I talk about the ventricular system of the brain, we have got following ventricles. So we have got the lateral ventricles. So in this diagram, we can see we have got the largest ventricle, which is one for the each cerebral hemisphere, lying below the corpus callosum. That is the lateral ventricles, which is shown in red color. We have got the third ventricle. We have got the fourth ventricle, and it is important that we should know the communications of these ventricles. So exactly if I talk about the lateral ventricle, it is communicating with the third ventricle via interventricular foramen of Monro. What is the communication, dear students? The communication of the communication of the lateral ventricle with the third ventricle is via interventricular foramen of Monro, and third ventricle is communicating with the fourth ventricle via cerebral aqueduct of Sylvius. Cerebral aqueduct of Sylvius. So we have to know this. Done. Now, let's talk about firstly the fourth ventricle. So I would like to tell you about all the ventricles, but the first ventricle which I want everybody to understand is the fourth ventricle. So let me slightly enlarge this. So when I am enlarging this image, you can appreciate the location of fourth ventricle. So exactly, let me just outline the fourth ventricle. This is exactly the outline of the fourth ventricle. So I have just outlined this. So if you are confused, let me use another color for it. So this is the fourth ventricle. Okay. So that triangular outline which you are seeing, just see here, that triangular outline which I am showing you is the fourth ventricle, and exactly the location of fourth ventricle is, it is lying anterior to the cerebellum and it is lying posterior to the pons and medulla oblongata. To be more specific, it is lying posterior to the lower part of the pons and posterior to the upper part of the medulla oblongata. That means the tent like the triangular outline of the fourth ventricle has been shown in the sagittal section of the brain, and in the sagittal section of the brain you can appreciate the fourth ventricle, which is a tent like cavity of the hind brain. It is lined by ependyma and it is filled with cerebrospinal fluid. It is situated in the posterior cranial fossa, and exactly if I talk about the posterior cranial fossa, it is exactly located and sandwiched between the cerebellum and that of pons and medulla oblongata. So done with this. Now if I talk about fourth ventricle, so please note down about the fourth ventricle. So fourth ventricle is a tent like cavity, Fourth ventricle is a tent like cavity of the hind brain, it's a tent like cavity of the hind brain, lined with ependyma, filled with CSF, and located behind the pons and upper part of medulla. Now, I also want you to tell the communication of the fourth ventricle. If you will see the superior communication of the fourth ventricle, superiorly it is communicating with the cerebral aqueduct of the midbrain and forms communication with the third ventricle. Inferior communication is, it is communicating with the canal of medulla oblongata, and it will also can communicate with the central canal of the spinal cord. The features, if you will see the outline of fourth ventricle, it is having certain features like recesses. It is irregular, and it's important to know the name of the recesses. It's important to know the boundaries. It's important to know the roof and the floor of fourth ventricle. So it's important that the fourth ventricle is having recesses, that is 5 in number, that is irregularities which will be seen. So it is having 2 lateral recesses. It is actually, if we talk about 2 lateral recesses, these recesses are laterally extending between ICP, inferior cerebral peduncles, and the flocculus, which we talk about, and it is having one median two lateral dorsal recesses. So total there is 5 recesses in the fourth ventricle, and it's also important to know that so just for now what you can understand, that these are the recesses which is the irregularities and the extent of fourth ventricle. You have to know about the boundaries of the fourth ventricle. So let's talk about the boundaries. So let me just show you this image. So exactly in this image we can appreciate the roof, but we can also see the boundaries of the fourth ventricle. So this is a schematic diagram of the fourth ventricle where you can understand the boundaries, you can understand the roof structures, and one more diagram I will show you where you can understand the content of the floor of fourth ventricle. So if you will see, I am just enlarging this. Here you can see there is superior cerebellar peduncles. Superior cerebellar peduncles are there on either side. So you can see this is superior cerebral peduncles. So if I talk about the boundaries, supralaterally it is bounded by superior cerebral peduncles. Infralaterally it is bounded by inferior cerebral peduncles. So you can just appreciate the boundaries. So infralaterally it is bounded by inferior cerebral peduncles, and supralaterally it is bounded by superior cerebral peduncles. Okay, and also exactly if you will see there is a you can see there is a superior medullary velum which is stretching between. If you will see this, I am just enlarging this. So you can appreciate This is superior medullary velum. So you can see this superior medullary velum is the name given to, it's the superior medullary velum is the name given to the stretching structure, which you can see, which is stretching between the two cerebral peduncles. So actually it is made of thin white matter, and this is stretching between the superior cerebral peduncle, forming the upper part of the roof, and the lower part of the roof, as you can see, the lower part of the roof, which is lying between the two side inferior cerebral peduncle, is having few communications. So you can see it is having two gaps. So it is one gap which you are seeing here. This is called as foramen of mesendi. What is it? This oval gap is foramen of mesendi, and two lateral gaps are there, which is called as foramen of Luschka. So actually these gaps are very important. I will tell you why. Because via foramen of Luschka and via foramen of mesendi, the CSF of the ventricular system will traverse into the subarachnoid space. Actually, if I talk about the CSF, cerebrospinal fluid, where it resides, the cerebrospinal fluid is residing into the ventricular system of the brain, and it is residing into the subarachnoid space. So there should be a communication between the subarachnoid space and that of the ventricles. So that communication is via two openings which is seen in the roof of fourth ventricle. What is the name of that opening, my dear students? The name of that opening is, we have got a midline foramen of mesendi, we have got laterally a foramen of Luschka. So via these two foramens, which is lying in the roof of fourth ventricle, in the lower part of the roof of fourth ventricle, the space of subarachnoid space, CSF, can communicate with the ventricular system of the brain. So these are certain points which you have to note down. So I just want quickly give you the notes. So quickly write the important points about so let's write the boundaries of fourth ventricle. So boundaries of fourth ventricle. So if I talk about the boundaries of fourth ventricle, infrolaterally, it is bounded by inferior cerebellar peduncles. Inferior cerebellar peduncles. Supplemented by, again, other than that, it is also supplemented by other structures infrolaterally, the gracile tubercle, the gracile and the cuneate tubercles. So these are the structures which is forming the boundary of fourth ventricle infrolaterally. Now talking about the boundary supralaterally. Supralaterally, it is bounded by superior cerebellar peduncles. Superior cerebellar peduncles. So is it okay? What is the boundary of the fourth ventricle? In the inferior aspect, infrolaterally, we have got the inferior cerebral peduncles. So what do you understand with these peduncles? Actually, the afferents efferents fibers which is connecting the midbrain with that of the cerebellum is called as superior cerebral peduncle, and the fibers which is connecting the medulla oblongata with the cerebellum, that afferent efferent fibers are constituting the inferior cerebral peduncles. So this is the boundary. Now let's talk about the roof of the fourth ventricle. Roof of fourth ventricle, that is roof. So exactly, if I talk about the roof of fourth ventricle, it is having upper and the lower sloping surface. So if you want to see the sagittal section of the brain, once again I just want you to show the sagittal section. So you can see the sagittal section, and you can see it is the whole outline of the fourth ventricle is highlighted in green color. And if you will nicely see this image, you can appreciate, just a minute. So this is the U and this is L. So when I am using the word U and L, what do you mean by that? When I am using the word U and L, it means it is the upper sloping surface and this is the lower sloping surface of the roof. So U and L means the upper and the lower sloping. So this is tent-like structure, and this will be the upper and this will be the lower sloping surface of the roof of fourth ventricle, which is going inside the core matter, white core matter of the cerebellum. And we have to know the structures which is residing in the upper part of the roof of the fourth ventricle and the structures which is residing in the lower part of the roof of fourth ventricle. And exactly, if we are talking about this structure, so this is the pons, this is the pons, and this is the medulla oblongata. So exactly the upper part of the medulla oblongata, dorsal surface, and that of the pons together, these are will form the floor structure. So here I just want to write F for the floor. So this is forming the floor of fourth ventricle. So now talking about that, the important structures in the roof of fourth ventricle. So if we are talking of the roof or the posterior wall of fourth ventricle, it is tent shaped structure, has upper and lower sloping surface, and has got upper and lower sloping surface. So upper part of the roof is formed by upper part of roof upper part of the roof is formed by the convergence of, it is formed by the convergence of two superior cerebellar peduncle, two superior peduncles, and thin sheet of white matter which is lying between the convergence of two superior cerebral peduncle is by superior medullary velum. So that fibers, if we are talking about the white fibers, which is just forming a connection between the convergence of the two superior cerebral peduncles, and that white fibers is exactly what is called as the superior medullary velum. That means the upper part of the roof is formed by superior medullary velum. It's formed by the superior. So it is formed by the convergence of the two superior cerebral peduncle, and it is having a thin sheet of white fibers. The thin sheet of white fibers, white matter, which is lying in between, is called a superior medullary velum. And this superior medullary velum is bridging that triangular gap which is lying between the convergence of two superior cerebral peduncles. Now we have to know about the lower part of the roof, and that is formed by the inferior medullary velum, and the lower part of the roof of fourth ventricle is very important. Why it is very important? Because it is made of non-nervous tissue, but it is actually lined by ventricle ependyma and the pia mater, and it is having the choroid plexus of the fourth ventricle, that the capillaries which is important for the formation of the CSF. And also there is three communication. There is one foramen of mesentery and there is two lateral lusca. So these are the three communication which is very important, that the CSF from the ventricular system can reach into the subarachnoid space. So please write down that. So we have done with the upper part. Now I want everybody to know about the lower part of the roof. So let's talk about the lower part. Lower part of roof. Lower part of roof is formed. So please don't get so just now the light will be on. Don't worry. So lower part of the roof is formed okay. Okay, just wait for a few seconds. Just so we are now talking about the lower part of the roof. So when I'm talking about the lower part of the roof, yeah. So lower part of the roof. When we are talking about the lower part of the roof, yes. So lower part of the roof is formed by non-nervous tissues, that is the inferior medullary velum. The inferior medullary velum, which is formed conjointly by. So if I am talking about inferior medullary velum, that is formed conjointly by, this is formed conjointly by ependyma and the pia mater, which is having tila choroidea. So actually tila choroidea is a fold of pia mater which will have choroid plexus inside, and here we have to know choroid plexus is very important. Why it is very important? Because it leads to the formation of the CSF. So exactly, if I talk about the choroid plexus of the fourth ventricle, it is formed by the branches, capillary branches from the posterior inferior cerebellar artery. Now it is having few apertures, so I just like to tell that in the roof of the fourth ventricle, if we are talking about the roof of fourth ventricle, there are few apertures in the roof of fourth ventricle lower part, and that few apertures are, I just want everybody to know the name of that aperture. We have got the apertures in the midline, that is called as foramen of mesenchyme. And we have also got the apertures in the lower part, which is very important for you to know down that the lower part, that communication is via foramen of Luschka. Actually, these are the two foramen which will form communication of the ventricular system of brain with the cerebromedullary cistern. So it is forming communication with the cisterna magna. And the cisterna magna means it is the other name for the cerebromedullary cistern. So actually the double fold of the pia mater is the tila choroidea, which is containing choroid plexus, and here in the case of fourth ventricle, the choroid plexus of the fourth ventricle is formed by the branches, capillary branches from that of the posterior inferior cerebellar artery. So got it? So here we have done this. So if you want, you can just add on this one point. Choroid plexus of fourth ventricle is actually formed by the branches from posterior inferior cerebellar arteries, formed by PICA, that is posterior inferior cerebellar artery. Now let's talk about the floor of fourth ventricle. So exactly as I have already told you, the floor of fourth ventricle, if you will see the outline of the floor of fourth ventricle, so what you can see, it is rhomboidal shape. So this is the whole outline. So this is the whole outline of the floor of fourth ventricle, and it is rhomboidal shape, and it is having upper and the lower triangular space. Actually upper and the lower triangular space, so in between the upper and the lower triangular space, the structures traversing is, so I just want to use a green color for that. And the structures traversing in the midline, this is the structure which is dividing into upper and the lower triangular area, and that triangular area, so that space, this is stria medullaris. So this is the white fibers which is traversing, and this is stria medullaris. So you can see here, this is the stria medullaris, and which will divide the whole area into upper and the lower triangular spaces. Now what happens in the so now I just want everybody to understand the structures which is lying in the upper triangular space and the structure which is lying in the lower triangular space. So if you will see this image, you can see the importance. So first thing is that there is a median sulcus. So you can see here, this is the median sulcus which will divide the entire triangular area into, which will divide the whole rhomboidal area into a right and the left triangular space. And then there is a laterally another sulcus which is called as sulcus limitans. So you can see here, this is the median sulcus, and this is the sulcus limitans. So we have got median sulcus and we have got sulcus limitans, and also you can see the sulcus limitans superiorly is having superior fovea, and so this is superior fovea superiorly, and we have got an inferiorly, we have got an inferior fovea. Now what happens, the area which is lying, so if we talk about the area which is lying just adjacent to this median sulcus, this whole area is called as median eminences. Median eminences. Now in this median eminences you can see many important features are there. So there is a rounded structure, as you can see, rounded swelling. What is this rounded elevation called as? This rounded elevation which you are seeing, so this rounded elevation which you are seeing is called as facial colliculus. What is it? It is called as facial colliculus. So this rounded elevation is called as facial colliculus. So let me just explain you. So this is facial colliculus, and this is formed by the motor fibers of facial nerve which is winding around the abducens nerve nucleus, and that is formed by the internal genu fibers of facial nerve. So deep to it lies the abducens nerve nucleus, and the fibers which is winding is the facial nerve fibers. Also here you can see at the upper end where the sulcus limitans is having superior fovea, there is another structure which is shown, that is called as locus cerulus. So this locus cerulus which is seen here is actually bluish in color, actually because of the, it is containing actually bluish gray in color because it contains melanin pigment which contains substantia ferruginea. The lower part you can see again is having inferior fovea, and it is again having different structures which is residing there. So on either side there is also, we have already talked about facial colliculus, and other than lower down you can see other triangular areas. So we have got an hypoglossal triangular area, we have got vagal triangular area, we have got area prostremia. So one by one I will like to tell about all these structures. So please write down few important structures seen in the floor of fourth ventricle. So floor of fourth ventricle is formed by posterior surface of pons It is formed by posterior surface of the pons and the upper part of medulla oblongata. Now, divided into right and left. So it is divided into right and left by median sulcus. So I just want to tell you about important features of certain structures. Like for example, I would like to talk about locus cerulus, which is bluish in gray color. This is bluish gray in color. And the reason why it is bluish gray in color is because of the constituent of the melanin pigment. What it contains? It contains melanin pigment, and this melanin pigment is bluish gray in color because of the presence of substantia. It is containing substantia ferruginea. Okay. Now, so, and I would also like to talk about facial colliculus, which is very important for you to note down. So, I am just telling about the important features, not all. So, the most important structures. So, there is another structure which is called as facial colliculus. So, this facial colliculus, so on either side in the median eminences. What is the location of facial colliculus? It is located in median eminences, and it is an oval swelling. So, it is an oval swelling which is called as median eminences, formed by fibers from motor nucleus of facial nerve hooking around abducens nucleus. So actually, and these fibers which is hooking around, these are the which fibers? These are the internal genu of facial nerve. So these fibers are called as internal genu of facial nerve. So this is the important point. Now if we go more, so if we go other than that, I told you in the floor of fourth ventricle, if you go lower down, you can also have another important structure. So you just write down the name, because I just want everybody to know the name of the structures which is lying more. So if we talk about the important structures, so in the lower part, lower triangular region, we have got many triangular structures, like for we have got hypoglossal triangular area which is containing the hypoglossal nerve nucleus. We have got a vagal triangle below. So vagal triangle will contain the nuclei of ninth cranial nerve, 10th cranial nerve, and cranial part of accessory nerve. And if I talk about hypoglossal nerve nucleus, it contains 12th cranial nerve nuclei, which is exactly lying there. Other than that, so these are the important structures which will be reside there, and this will be seen in the lower part of the triangular area, which will be seen in the lower part of the triangular area. Other than that, we will also have other nucleuses lying, like the intercalatus nucleus, area prostremia. All these structures will be residing. So done with this. Now let's move on to the next ventricular system, that is the lateral ventricle. So if I talk about the lateral ventricle, this is the if I talk about the lateral ventricle, the choroid plexus of the lateral ventricle is important. Why it is important? Because the choroid plexus of the lateral ventricle is forming maximum amount of CSF. Just a minute, I just want to take some water. So if I talk about lateral ventricles, so here we can see the corpus callosum in this diagram. So here we can see the location of corpus callosum. What is it? This is corpus callosum. So this is the whole outline of corpus callosum. So this is the whole outline of corpus callosum. And just below it, we have got a cavity. I am using different color for the cavity. This which I am using blue color cavity, this is the lateral ventricle. So we have got one lateral ventricle on either side of the brain cerebral hemisphere, right and the left cerebral hemisphere, one lateral ventricle. Okay, so we have got one lateral ventricle for either side of the brain area, and we have got this as CC for the corpus callosum. So here this part of the corpus callosum is called as G for genu. So exactly, I will just write here. Okay, this will be the beak-like rostrum, genu, body of corpus callosum, and this S for the splenium of corpus callosum. So these are the parts of the corpus callosum which I have highlighted, and below it is the cavity, that is the lateral ventricular cavity, one for each side of the brain, one for right and the left brain hemisphere. So lateral ventricle. Okay dear, lateral, if any of the student is having any doubt, please let me know. Okay, after completing the ventricular system, again I will like to solve few MCQs with you. So if you have got any doubt, you can let me know. Lateral ventricle is one for each hemisphere. There is one lateral ventricle for each hemisphere, for each CH means cerebral hemisphere. So roughly, if we will see the cavity, it is C-shaped cavity wrapping around. So exactly, it wraps around. It wraps around. Wrapping around. It wraps around. It wraps around thalamus, lentiform nucleus, and caudate nucleus. So this is exactly, actually if I talk about thalamus and hypothalamus, the cavity related to it will be that of the third ventricle. So yes, we will have a break. We will have a break after completing this ventricular system. So I just want to complete this ventricles of the brain, and because it will take another 20-25 minutes, I think we have to complete this ventriculars of the brains, and then I will give you a break. Is it okay? I could have a suggestion from the students. Is it okay? So after completing this ventricles of brain, I will give you a break. So the whole ventricular system of the brain is divided into parts. So after completing this, after completing ventricles of brain. Okay, now here we can see this is the showing you lateral ventricle parts. So this is showing you the parts of lateral ventricle. So this is the two lateral ventricles, one for each part of the brain. So this is the anterior horn, A for the anterior horn. Okay, this is the central part, C for the central part or the body of lateral ventricle. This P for the posterior horn, and this I for the inferior horn of the lateral ventricle. So you can see the A for the anterior horn or anterior extension of the lateral ventricle, which is extending into the frontal lobe of the cerebral hemisphere. C is the central part of the body of the lateral ventricle, which is lying in the just below the body or the trunk of corpus callosum, related with the parietal lobe of the cerebral hemisphere. P is the posterior extension of lateral ventricle, which is residing into the occipital lobe of cerebral hemisphere, and I for the inferior extension of the lateral ventricle, which is the main cavity of lateral ventricle extending into the temporal lobe of cerebral hemisphere. So for appreciating the relation of each individual component and part of the ventricle, we have to see a coronal section of the brain. So in coronal section of the brain, we can appreciate the individual part of the ventricular system of the brain. So lateral ventricle parts. So how many parts it is having? It is having a central part, which is also called, it is having a anterior horn. It is having a posterior horn. It is having an inferior horn. Okay. So here I just want you to tell the relations of the central part of lateral ventricle. So one by one you can have the relations of individual part of lateral ventricle. So the first is to know about the relations of the central part of lateral ventricle. So when you are seeing this image, you can appreciate this is the central part of lateral ventricle. Superiorly it is related with the corpus callosum. So what will be the superior relation? Superiorly it is related with the corpus callosum, and if I talk about the floor, so this all structure is forming the floor. So it is related with caudate nucleus, striate terminalis, thalamostriate vein, thalamus, and also the there will be the body of fornix, as you can see, and also there will be the choroid plexus related. Medially, we have got the septum pellucidum. Actually, septum pellucidum is separating the ventricle of the brain of both the side. So these are the structures which is forming the whole of the boundaries of the central part of lateral ventricle. So that is important. So please write down relations of central part of lateral ventricle. Relations of central part of lateral ventricle. Okay. So roof is formed by under surface of body and trunk of corpus callosum. Then floor. If I talk about the floor, many structures are related to the floor. So we have got many structures related to the floor. So we have to know the structures which is traversing from up to down and forming the path. So from lateral, so floor structures, we have got following structures from lateral to medial. which is forming the floor structures, and these structures are body of caudate nucleus. These structures are body of caudate nucleus. We have got stria terminalis. We have got thalmostriate vein. Which is related, and we have got also the part of thalamus. We have got choroid plexus, and we have got the body of fornix. So all these structures, so this is 1, this is 2, this is 3, this is 4, 5 and 6. All these structures are related and forming the floor of the lateral ventricle. So one more thing is important, that is the medially. If I talk about medial relation, medially the two sides are separated by septum pellucidum. Medially, septum pellucidum is forming the boundary between two sides of lateral ventricle. So done with this, now we will talk about the relations of the anterior horn of lateral ventricle. So actually the anterior extent of the lateral ventricle, as I told you, it is extending into the frontal lobe, and we have got, so again we have got a coronal section, and we can see the cavity of anterior horn of lateral ventricle has been shown. Superiorly it is by the corpus callosum, as you can see here. Medially we have got septum pellucidum. The rostrum of corpus callosum is forming the floor. The genu will form the anterior relation, and superiorly is the body of corpus callosum, and laterally there is caudate nucleus, as you can see in this diagram. Caudate nucleus is lying in the lateral relation. So write down relations of anterior horn of corpus callosum. Relations of anterior horn of lateral ventricle. So if I talk about the relations of anterior horn, it is triangular in outline. So it will have following relations. So its floor will be formed by rostrum of corpus callosum. Its roof will be formed by the under surface of the body of corpus callosum, under surface of body of corpus callosum. It will have medially, it will be formed by septum pellucidum. Laterally, it will be related with the head of caudate nucleus. Anteriorly, if we see the anterior relation, it is formed by the genu of corpus callosum. So all these structures are lying in relation with the anterior part of lateral ventricle. So now talking about the relations of the posterior part of lateral ventricle, relations with the posterior part of lateral ventricle. And if I talk about the posterior horn of the lateral ventricle, we have got anterior and medial aspects. So posterior part of lateral ventricle is diamond shaped in outline, and if you will see the major structures, that is the roof, the lateral wall and the floor. So if we talk about the roof, the lateral wall and the floor, all these structures are related with the tapetum fibers. Tapetum fibers, which is an extension from the white fibers of the brain corpus callosum, separating it from optic radiation. And medially we have got two elevations. So one is called as the elevation is formed by the fibers of forceps major, which is formed by the corpus callosum only, which form bulb of posterior horn, and another is formed by the calcarine sulcus. What is calcarine sulcus? It's a deep indentation is there in the cavity of the lateral ventricle, and that is forming calcar avis. So please write down the relations of posterior horn of lateral ventricle. So if I talk about the relations of posterior horn of lateral ventricle, it is related with the following structure. So the roof of posterior horn of lateral ventricle. So exactly if I talk about roof, if I talk about lateral wall, and if I talk about the floor, all these structure is having the fibers, that is tapetum fibers, which is an extension from the corpus callosum, but floor is having two elevations. So floor is having, if I talk about the floor part, here what we can see, so we have got the floor lateral. If we see the medial aspect, sorry, if we use the word, most correct will be medial part, and medial part is having two ridges, and these two elevation or ridges is calcar avis, and there is also bulb of posterior horn. So calcar avis is an indentation formed by the calcarine sulcus, and bulb of posterior horn is an indentation which is formed by the forceps major fibers of corpus callosum. Now talking about the relations of inferior horn of lateral ventricle. So if I talk inferior horn, it is we will talk about the relation in the form of roof and in the form of floor. So floor is having collateral sulcus forming collateral eminences. If I talk about the roof is having many important structures we will have in the roof. As you can see, there is tail of caudate nucleus, stria terminalis, choroid plexus are there. So all these structures and collateral so exactly if I talk about the floor, there is collateral sulcus and there is hippocampus fibers which is related here in the floor. So please write down relations of inferior horn of lateral ventricle. So roof, if I talk about the roof is formed by tapetum part of corpus callosum. It will also have relation with the tail of caudate nucleus and stria terminalis. Now if I talk about the floor structures will have the relations, will have collateral eminences. Actually collateral eminences, if we are talking about collateral eminences, it is a deep indentation which is seen in the cavity of inferior horn of lateral ventricle, which is formed by a collateral sulcus, which is very deep enough to produce an indentation in the inferior horn of lateral ventricle. And the other structures related will be hippocampus, along with its other part that is also related. So it will have a relation of alveus, fimbriae and all structures. So done with this, now we will move with the third ventricle, and other than that I would also like to tell you that if we are talking about the choroid plexus of the lateral ventricle, so these are formed by the important capillary springe which is actually the branch. So these are derived from the two arteries. One is anterior choroidal artery and another is posterior choroidal artery. So we have got two arteries, one is anterior choroidal artery and the other is posterior choroidal artery. So if I talk about anterior choroidal artery, the if I am talking about the choroid plexus of the lateral ventricle, its anterior choroidal artery is a branch of ICA, internal carotid artery, and the posterior choroidal artery is a branch of PCA, that is posterior cerebellar artery. Now I would like to talk about the third ventricle. So here I just want to enlarge this. When I am talking about the third ventricle, you can see third ventricle is a very small cavity which can be outlined here. This is the cavity of the third ventricle, and exactly this is lying between, this is the cavity of Dancephalon. So this is the cavity of Dancephalon and it is exactly lying between this structures. So it is exactly lying between the thalamus and the hypothalamus. So basically it's a very small cavity, and this cavity is lying between T for the thalamus and HT for the hypothalamus. So it's a cavity of Dancephalon. Third ventricle, it's a cavity of It's a cavity of Dancephalon, and the whole of the outline of it is irregular. So it will have an outline which is very irregular. It will have recesses and diverticula, and importantly, it is also it's called as it is located like a slit like cavity between the thalamus and hypothalamus of either side. What is important is to know the boundary. So for that, I just firstly want everybody to appreciate this image. So this is the location of lateral ventricle. This is the location of third ventricle. This is the location of fourth ventricle. And the communication. So this lateral ventricle is communicating with the third ventricle via foramen of Monro. And this two, that is third and fourth, is via communication with cerebral aqueduct. So cerebral aqueduct of Sylvius is forming communication between third and fourth, and that of between the lateral ventricle and third ventricle is via interventricular foramen of Monro. Now third ventricle, boundaries and the relations you have to know. So for knowing the boundaries and relation, I would again like to show you an image for it. So you can see here, we can see that whole outline of third ventricle is very irregular. So exactly in the anterior aspect, in the anterior wall, we have got the anterior column of the fornix, the anterior commissure, and the lamina terminalis. So these are the three structures which you are seeing. These three structures are lying in the anterior relation. अगर हम if we are talking about the posterior wall, posteriorly it is related to posterior commissure, P for the posterior commissure, visually, yes sure, yes sure, yes sure, yes sure. Okay, I just request everyone, let me finish the ventricles. So this is the ventricles of the brain. I will just finish the ventricles of brain, and then I will give you a break of 20 minutes. Is it okay, everyone? Just the ventricles of brain. I have got, this is the last ventricle which I am completing. This is the third ventricle. Okay, let me just complete this. And in the floor structures, if I talk about the floor structures from before to backward, it is having optic chiasma, infundibulum, hypophysis cerebelli, mammillary body, posterior perforated substance, and tegmentum of the midbrain. So these are floor, and in the roof we have got the tila chorioida of third ventricle. So I just want quickly write down, all of you write down the relations of the third ventricle outline. So anterior wall is having following structures from above to down. It is related with the anterior column of fornix. It is related with the anterior commissure. It is related with lamina terminalis. Posterior wall. If we talk about posterior wall, it is related to pineal gland. Is it okay, everyone? Please write in the message that I will just finish, take 10 minutes to finish it. Okay. It is related to pineal gland. It is related to posterior commissure. And it is also related posteriorly to the commencement of cerebral aqueduct. Now, again, if I talk about the floor, so the floor structures from before to backward, if I talk about the floor structure, the floor structures are, it is related to optic chiasma, it is related to pituitary stalk, it is related to mammary bodies. All these things I have shown you in the image. Let me just enumerate this. These relations are important. Also, it is related with the posterior perforated substance and tegmentum of midbrain, and also related with the tegmentum of midbrain. Now talking about the lateral wall, it is related with a curved sulcus. So actually this curved sulcus is called as hypothalamic sulcus. And this hypothalamic sulcus is exactly lying between the thalamus hypothalamus. It is running between interventricular foramen of Monro to cerebral aqueduct. So this about floor, anterior wall, lateral wall we have done. And what about the roof? So the roof is having ependyma. Actually this ependyma is stretching through the upper limit of two thalami. So exactly two thalamus on either side, the ependyma is stretching. And in the roof only we will have the choroid plexus. So actually it's also important to know that we have got many recesses and all, which is name has been given, but yeah. So if I talk about choroid plexus, so the choroid plexus of the third ventricle is formed by formed by the medial part of posterior choroidal artery, and we know that this is a branch of posterior cerebellar artery. Now, so exactly we have finished visually we have finished with the ventricular system of brain. Quickly I would like to tell about the CSF circulation, and then I will give you a break. So lateral ventricle communicate with interventricular foramen of Monro, then communicate with third ventricle, passes through, so CSF will pass through cerebral aqueduct and will reach the fourth ventricle and can communicate with the central canal. The whole CSF can also traverse through the opening in the fourth ventricle, that is foramen of mesentery and foramen of Luschka, can pass through the tentorial notch and can reach to the subarachnoid space. So cerebrospinal fluid, what is cerebrospinal fluid? It is much similar to the blood plasma, interstitial fluid, and its composition is more or less similar to it. Maximum amount of CSF is, if we talk about circulation and absorption, so maximum amount of CSF is formed by the lateral ventricles of brain, from the lateral ventricles of brain. So exactly if you will see, this is the showing you the CSF circulation formed by the choroid plexus of the lateral ventricle, maximum amount, then interventricular foramen of Monro reaching the third ventricle, then via cerebral aqueduct it will traverse towards the fourth ventricle. From fourth ventricle roof, they are the median apertures are there. These are the median and lateral apertures. Communication is towards the subarachnoid space, and ultimately it will traverse to subarachnoid space and get absorbed by the arachnoid granulations of the superior sagittal sinus. So I just want everybody to know about the circulation. So exactly exactly CSF has got a composition similar to that of blood plasma. Actually it is having low protein than the blood plasma. Content of glucose is approximately half of the blood, and specific gravity will be slightly alkaline, and so it's all important point. But the important point is CSF is circulation. So heading will be circulation of CSF. So one by one you can write down the step. The first one is CSF is maximum amount of CSF is formed by choroid plexus of lateral ventricle. From here it will pass through interventricular foramen of Monro and will reach the third ventricle. From third ventricle, so this is the third point. So now from third ventricle, the CSF will be traverses to cerebral aqueduct of Sylvius. It will be passing through which structure? Cerebral aqueduct of Sylvius. And from cerebral aqueduct of Sylvius, it will reach the fourth ventricle. and from the fourth ventricle it will traverse through foramen of Mazendae and Luschka. So exactly, you know the foramen of Mazendae and Luschka, and these are the foramens in the roof of fourth ventricle. These are the foramens in the roof of fourth ventricle, and via this the communication will be, it will pass through the tentorial notch, and will traverse through the inferior surface of brain. It will traverse through inferior surface of cerebral hemisphere, then through the pulsation of the arteries surrounding. Ultimately, from the inferior surface, it will reach to the supralateral surface of the brain, and ultimately it will be absorbed by arachnoid granulations of, superior sagittal sinus, triple S. So this is how the maintenance of the CSF circulation is maintained. This is how the CSF circulation is maintained. Is it okay? Now clinical aspect. So we have done with this. Okay. So just let me complete. So we have done with CSF circulation, thus the clinical aspect and MCQs, and we have done for the ventricles. So there actually in clinical aspect there can be either so hydrocephalus, that is the increase amount of CSF, and if there is an increase amount of CSF, what happens? The many important features like large head, the babies will have large head, the tense bulging fontanelles. So the babies will have tense bulging anterior fontanelles. There will be thin scalp, the veins will be dilated, cracked pot sound on the skull percussion. So actually I just want to tell that these are the things which you will also study in the case of the other will be the baby will have dementia in the case of medicine and pediatrics. So motor functions delayed. So all those bulging head will be there, fontanelles will be large, and hydrocephalus can be communicating and non-communicating. Two types are there. One is communicating and the other is non-communicating. So can anybody tell me which is more dangerous? Which will be more dangerous? Anyone wants to tell which will be more dangerous? When I am using the word communicating, it means there is either some problem with the formation or the absorption of CSF because of any kind of meningitis or infection. Non-communicating means there is some kind of obstruction in the communication, like there is obstruction in foramen of Luschka, foramen of Mazendae, interventricular foramen of Monroe, cerebral aqueduct. So the more dangerous is the non-communicating one. And other than that, I would also like to talk about, I would also like to talk about another condition which is called as Froen syndrome. Okay, so when I am talking about this condition, that is Froen syndrome, it is important for you to note down that this is also called as loculation syndrome. And the reason of Froen syndrome or loculation syndrome is block in the vertebral canal. Block in vertebral canal. So if there is a block in vertebral canal, what will happen? It will be the fluid circulation, the obstruction to the flow of CSF will be there. So if there is any kind of block in the vertebral canal, there is obstruction in the CSF blood flow, and the CSF below the obstruction will show. So the CSF below the obstruction, so special features. So there will be certain special features in the CSF which is lying below the obstruction, and the features will be, what will happen? It will be yellow in color. Yellow in color, the reason of yellow coloration is xanthochromia. Xanthochromia due to altered blood pigment. So the CSF lower to it will have change of color, that is called as xanthochromia. And the reason of formation of xanthochromia is due to altered blood pigment. Now, the CSF below it will coagulate. So, there can be coagulation, coagulates. So, there will be coagulation spontaneously. So, the reason is protein is increasing below the obstruction and coagulation will be spontaneously. And also, if there is a sudden increase in intracranial pressure, it is not transmitted to the CSF lower down. So, that intracranial pressure is not transmitted lower down. So, done with this. Now, I just want everybody to concentrate. We will solve few MCQs related to the topic. So, everyone, let's solve few MCQs related to the topic, and then I will give you a break. Is it okay? The arachnoid, so let me. The arachnoid villi responsible for CSF absorption protrude mainly in which of the following sinuses? Superior sagittal sinus, inferior sagittal sinus, straight sinus or transverse sinus. So, the absorption via arachnoid villi is done by which of the following sinus? Question number 1. Please mark the right answer, those who are live. So, just a minute. All of you can mark the right answer. Okay. So, anyone who wants to give me the right answer, the correct answer, the arachnoid villi responsible for maximum amount of CSF absorption is residing in superior sagittal sinus. So, we have got superior sagittal sinus is the right answer, dear. So, the superior sagittal sinus is the right answer. Now, lateral ventricle is connected to the third ventricle via. Lateral ventricle is connected to the third ventricle via. Lateral ventricle is being connected to the third ventricle via foramen of Monro, foramen of Luschka, foramen of Mazendae or median foramen. So, please mark the right answer. So, lateral ventricle communication with the third ventricle is via interventricular foramen of Monro. So, the right answer is interventricular foramen of Monro. So, got it? So, everyone is exhausted, I think. The floor of fourth ventricle contains all except. The floor of fourth ventricle is containing all except abducens nucleus, the facial nucleus, the dorsal vagal nucleus, the hypoglossal nucleus. According to you, which is the right answer? Anyone? The right answer is, my dear, the right answer will be facial nucleus. Actually, facial nucleus, actually if I talk about the motor facial nucleus fibers, which is called as the internal genu, is winding around abducens nerve nucleus in the case of floor of fourth ventricle. But exactly facial nerve nucleus is not residing in the floor of fourth ventricle. Okay, its fibers are winding. Its fibers which is winding is called as internal genu and it is not exactly residing. So, this is the odd man out. Pineal gland forms floor of third ventricle. Pineal gland is forming the anterior wall of third ventricle. Pineal gland is forming the posterior wall of third ventricle. It is forming the roof of third ventricle. Which is the right answer. Pineal gland is forming the posterior wall of third ventricle. So, we have got posterior wall of third ventricle as the right answer. Pineal gland is forming the posterior wall of third ventricle. Anterior horn of lateral ventricle is closed anteriorly by. Anterior extension or the anterior extension of lateral ventricle is closed anteriorly by which of the following structures? The options are thalamus, septum pellucidum, lamina terminalis and corpus callosum. So the right answer is corpus callosum. So corpus callosum is forming the anterior. So genu of corpus callosum is anteriorly extending for the anterior horn of lateral ventricle. So yes, we are done with this. The next is the cranial foramina. So the next topic is cranial foramina. So what I want, I will give you a break of 15 to 20 minutes, and then we can again have your coffee, tea, and take break, and then again we will come for this session. So just a break is for 15 to 20 minutes. So we'll write back in 15 to 20 minutes. So now is the breaks. Is it okay? If you have got any doubt, you can write in the message. So break now. I will just write it also. So yes, so let me just check, am I audible? The screen is clear so that we can start the session. So am I audible? Okay. Yeah. So the next topic is the cranial nerve. So next topic is the cranial nerve. After this, I will cover up the cranial nerve. So firstly, I would like to talk about the cranial foraminas, and then we will go with the cranial nerve. So actually, that is very important topic, and I want everybody to understand the cranial foraminas of the brain. So you should have an idea of cranial foraminas because that is highly important. Okay. So exactly, if I am talking about the cranial foraminas, I would like to talk about the cranial foraminas in anterior, posterior and the middle cranial fossa. So you have to know about all the cranial fossas and you have to know about the details of entire cranial foramina. So exactly, let me just show this image. So we have got this as the part of anterior cranial fossa. So this is anterior cranial fossa which you are seeing. Okay, this is ACF, anterior cranial fossa. Then this is the outline of MCF, that is middle cranial fossa, and this will be the posterior cranial fossa. Okay, so three cranial fossas are there and you have to know about the anterior, middle and the posterior cranial fossa and the structures and the foraminas which is lying in it. So you have to know about the foraminas. So exactly, many important foraminas are lying there. Okay, so you can see here, this is the cribriform plate. This is exactly the cribriform plate which you are seeing, and this is the cribriform plate of ethmoid bone. Then we have got the foramen ovale here. This is the foramen ovale. Then we have got the foramen spinosum close to it. This is so exactly here we have got superior orbital fissure, the optic canal, the foramen rotundum, ovale, foramen lusnerum is there. So actually foramen spinosum is there. So many foraminas is there. So one by one you can see all the important foramina. So in the middle cranial fossa also you can see multiple of foramens are there, and it's highly important that you should know the important structures traversing through this foramens. Now in the other structures you can see here, this is a foramen magnum. Here you can see the internal acoustic meatus is also lying there. The jugular foramen, the hypoglossal canal and the foramen magnum. So individually you have to know about all the foraminas, and the structures passing through this individual foramen is very important for you. So I would like to talk about all the important foramens. So let's start with the first. So I would like to firstly talk about the foraminas of the anterior cranial fossa. So if you will see this, you can see this is the anterior cranial. This is the anterior cranial fossa. So this is the cribriform plate of the ethmoid bone. This is optic. So exactly if we are talking about the anterior cranial fossa, we have to talk about the cribriform plate. We have to talk about the foramen cecum, and two on either side here will be anterior ethmoidal foramina, and this will be the posterior ethmoidal foramina, and this will be the FC for foramen cecum. So these are the four foraminas in the anterior cranial fossa, and one by one you have to know the structures passing through these cranial foramina. So let's start with that. So write down structures passing through anterior cranial fossa foramina. So let's start. Structures passing through anterior cranial fossa. So if we are talking about anterior cranial fossa, the important foraminas are, the first one is the foramen cecum. So in the anterior cranial fossa, we have got the foramen cecum, and through the foramen cecum, the structures passing is the emissary vein. And if I talk about emissary vein, it is actually forming a communication. Emissary vein is actually forming a communication, which is forming a communication with the nasal mucosal vein with that of superior sagittal sinus. So emissary vein is forming communication with the nasal mucosa to that of superior sagittal sinus. The next important foramina is cribriform plate of ethmoid bone. Cribriform foramina. So exactly, cribriform foramina is present in ethmoidal bone, and many important structures are exactly olfactory nerve rootlets, many important olfactory nerve rootlets which is surrounded by the leptomeninges. And today itself I have told you about leptomeninges. What is leptomeninges? It is having a covering of pia and that of arachnoid. So cribriform plate, the structure passing through cribriform plate will be the olfactory nerve rootlets, will be olfactory nerve rootlets which is surrounded by leptomeninges. Which is surrounded by leptomeninges. Done. Now structures, so other than that, we have done with the two foramina. Other than that, we have got we have done with the foramen cecum and cribriform plate of ethmoid bone. Other than that, we have got two more foraminas in relation to anterior cranial fossa. One is anterior ethmoidal foramina. One is anterior ethmoidal foramen, and the other is posterior ethmoidal foramen. So if I talk about anterior ethmoidal foramen, the structures passing is very easy. It's very easy to remember the structure passing from anterior ethmoidal foramen and that of posterior ethmoidal foramen. The structures passing through anterior ethmoidal foramen will be anterior ethmoidal nerves and vessels. It will be anterior ethmoidal nerves and vessels. If I talk about posterior, the structure passing will be posterior ethmoidal nerves and vessels. So we have got anterior and posterior ethmoidal nerves and vessels passing through anterior and posterior ethmoidal foramina. So it's very easy to remember. Here anterior ethmoidal nerve will be a branch from ophthalmic nerve. So actually anterior ethmoidal artery, which will be a branch from ophthalmic artery, which will be a branch of internal carotid artery. Same goes with posterior ethmoidal artery, branch of ophthalmic artery, branch of internal carotid artery. So done with this. Now the important foramina to be studied in the case of. So again, now we are going to talk about the important foramina in the middle cranial fossa. So if I talk about middle cranial fossa, the important foramina are following. This is optic canal. This is superior orbital fissure. This will be the, so this is the superior orbital fissure and optic canal. This is foramen rotundum. This is foramen ovale. This is foramen spinosum. This is the foramen lacerum. This irregular foramen is the foramen lacerum. So actually all these foramens are the foramens of middle cranial fossa. One by one I will talk about this foramina and the structures passing through it, which is very important for you to note down. So the important foramina of middle cranial fossa. So firstly let's talk about optic foramen. Okay, firstly we talk about optic foramen. So if I talk about optic foramen, the structures passing through optic foramen will be optic nerve and ophthalmic artery. So 2O, optic nerve and ophthalmic artery. It will be optic nerve and ophthalmic artery. Now the second is We have got foramen rotundum. So the structures passing through foramen rotundum can be memorized by the mnemonic ME. So M for maxillary nerve and E for emissary vein. Actually, there is also superior orbital fissure, but we will talk about superior orbital fissure later. The foramen rotundum. So through the foramen rotundum, the structures passing will be maxillary. The structure passing will be the maxillary nerve and emissary vein. Will be the maxillary nerve and emissary vein. Now talking about the structures passing through, so we have got the optic nerve, we have got the foramen rotundum, and other than that, if we are talking about so actually this foramens, actually if we talk about these foramens, it could have also been it could be covered also in the head and neck. Actually cranial nerves and foramens and all is overlapping topic. Why I will tell you, because it is an important topic which can be covered also in the case of head and neck part, and also can be covered in the neuroanatomy. So I am taking this part in neuroanatomy itself. Is it okay? So all the students, if they have got any doubt, they can let me know. If you have got any doubt, you can let me know. Okay. Okay. Now, so structures passing from middle cranial fossa. So here we have got also superior orbital fissure is already explained. So I just want to show you this image. Actually, if you will see the orbit from the front aspect, if you, this is showing the orbit as you see from the anterior aspects, and you can see this retort shaped structure which you are seeing. This retort shaped structure which you are seeing is the superior orbital fissure, and important structures passing through superior orbital. So exactly the overall superior orbital fissure will be divided into is divided into three parts by common tendinous ring. So what is common tendinous ring? The common tendinous ring of Jin is actually the origin of the four recti muscle. So this will give rise to the four recti muscle, and we have to know the structures passing within the common tendinous ring or the structures passing above and below this common tendinous ring. So exactly there is a schematic diagram here. In this schematic diagram, you can see the common tendinous ring, which is exactly the origin of the four recti muscles. So we have got the origin of superior, middle, inferior, lateral rectus muscle, and this is dividing the whole of the part of the superior orbital fissure into three components. So you can see from the upper or lateral part we have got okay, so if we are talking about this part of the superior orbital fissure, you can remember by a mnemonic LFT, LFT lacrimal frontal. So we have got LFT. So we have got the lacrimal frontal trochlear nerve, fourth nerve, and other than that we have got superior ophthalmic vein. These are the important structures, and in the middle part we have got the third and the fourth. We have got the third nerve, and we have got the sixth cranial nerve and nasociliary nerve. So exactly both the division of upper and lower division of oculomotor nerve, and below it we have got inferior ophthalmic vein. So if we divide the entire superior orbital fissure into three parts, the structures passing through the lateral part. So if we are talking about the structures passing through the lateral part of superior orbital fissure, if we are talking about the lateral part of the superior orbital fissure, the structures passing are superior ophthalmic vein is the superior ophthalmic vein, lacrimal nerve, frontal nerve, trochlear, and the recurrent meningeal branch of the lacrimal artery. So all these structures are passing through the lateral part of superior orbital fissure. LFT and the superior ophthalmic vein and recurrent branch of the lacrimal artery. So the middle part, if I am talking about the middle part means intermediate component of superior orbital fissure, we have got the structures which is passing through the middle part, we will have superior inferior division of oculomotor nerve, nasociliary nerve. In between the oculomotor nerve, superior inferior division and abducens nerve. Inferior part, we have our inferior ophthalmic vein and also sympathetic plexus traversing around the internal carotid artery. So all these structures which has been mentioned are the structures passing through superior orbital fissure. Now, other than that, I would like to talk about few other foraminas and the structures passing through these foraminas. So let's talk about the important structure. So we have already talked about foramen, superior orbital fissure, and we have talked about the foramen of rotundum. The next is foramen of ovale. Foramen ovale. So if I talk about foramen ovale, the structures passing through foramen ovale can be memorized by the mnemonic male. M-A-L-E. So here M, Vrishali. No dear, it's easy. It's easy dear. No need to mug up. For example, no, you can remember. For example, if I am talking about optic canal, the two structures related to eye, optic nerve and ophthalmic artery. Okay, Vrishali, optic nerve and ophthalmic artery is passing. If I am talking about foramen rotundum, the mnemonic is me, M-E, maxillary nerve and emissary vein. If we are talking about foramen ovale, the structures passing is male, M-A-L-E. If I am talking about superior orbital fissure, so LFT, the mnemonic is LFT. So if we write down foramen ovale, the mnemonic is male, M for mandibular nerve, A for accessory middle meningeal artery, accessory MMA for middle meningeal artery. So accessory middle meningeal artery. L for lesser petrosal nerve. And E for emissary vein. E for emissary vein. So we can see these are the structures which is passing through foramen ovale. M-A-L-E. So these are four structures which is passing through foramen ovale. Now, structures passing through foramen spinosum. So the word spinosum is there and the structure passing is nervous spinosum. So how you are two important structures pass through foramen spinosum. The one is the middle meningeal artery and the other is nervous spinosum. So the structures passing through foramen spinosum will be middle meningeal artery, followed by nervous spinosum. Followed by nervous spinosum. The next is the structure passing through foramen lacerum. So if I talk about foramen lacerum, not a very important structures as you can say is traversing to and fro, but few structures are related. For example, the structure is meningeal branch of ascending pharyngeal artery. The passing structure is meningeal branch of ascending pharyngeal artery. Meningeal branch of ascending pharyngeal artery is passing. The other structure passing is emissary vein. So exactly the emissary vein. What do you mean? Any idea? What do you mean by emissary vein? Students, have you got the idea of emissary vein? Emissary vein, have anyone has the idea? What do we mean by emissary vein? Emissary vein means those vein which is connecting the veins of the outer scalp with that of the veins of the dural venous sinuses. So if I am talking about emissary vein, if I am talking about the emissary vein, this emissary vein is forming communications from, so it forms a communication from cavernous sinus, CS means cavernous sinus, to the pharyngeal venous plexus, to the pharyngeal venous plexus. Now, other than that, the other structure passing is internal carotid artery, which is also having sympathetic plexus covering it. And the fourth structure is greater petrosal nerve. GPN means greater petrosal nerve, which joins with deep petrosal nerve and leads to the formation of nerve of pterygoid canal. It leads to the formation of nerve of pterygoid canal. So through foramen, lacerum, these are the structures traversing. Meningeal branch of ascending pharyngeal artery, emissary vein, internal carotid artery, general that is the greater petrosal nerve, deep petrosal nerve, and ultimately leads to the formation of nerve of pterygoid canal. So in short, we have done with all the foraminas which is passing through the cranial fossas of the middle cranial fossa. Now the next is to know the foraminas of the posterior cranial fossa. So I will just enlarge this. So when I am enlarging it, you can see here the foraminas of middle cranial fossa. So in this we have got the foramen magnum. We have got the foramen magnum. Foramen magnum. We have got the foramen magnum here. So we have to know all the structures passing through foramen magnum. Then we have to hypoglossal canal is there. We have to know about the structures passing through hypoglossal canal. By the name only it is the, we have to know about the structures passing through internal acoustic meatus and that of the jugular foramen. So all these foraminas which I have highlighted, these are the important foraminas of the posterior cranial fossa, and you have to know all the foraminas passing through it. You have to know about the foraminas passing through it one by one. Okay. So now I just want you to write this. So please write important foraminas. So I just want everybody to write the important foraminas of the posterior cranial fossa and the structures passing through it. So the first foramina in this case is the internal acoustic meatus. Internal acoustic meatus. So if I talk about internal acoustic meatus, the structures passing through internal acoustic meatus is following. Through it passes the 7th cranial nerve. We have also got the 8th cranial nerve which is traversing through the foramen, that is the internal acoustic meatus. Here I just want to tell that in between the actually in between the motor branch of the 7th cranial nerve and between the vestibulocochlear, the 8th cranial nerve, the other structure which is traversing. So one more structure is traversing. What is it called as? It is called as nervus intermedius. What is it called as? It is called as nervus intermedius. Then the other structure passing is labyrinthine vessel. Is the labyrinthine vessels. The other structure passing is the labyrinthine vessels. Okay, these are the structures which is passing through it. Also the labyrinthine vessel is passing through it. Now, I would also like to talk about the other foramina. So, exactly, I also want to talk about the jugular foramen which is passing through it. So, let's write about the jugular foramen. The next foramen is the jugular. I think jugular foramen I have already explained here also. So, I just want to show you that. Actually, if you will see the jugular foramen, it is also divided into 3 compartments. And one time the question, I think in 2021, 2022, the question was asked about the jugular foramen, that which nerve is traversing and passing through a different compartment. So we know that 9th, 10th and 11th cranial nerve is passing through jugular foramen, but it should be noted down that the 9th cranial nerve which is passing through jugular foramen is passing through singly, and but 10th and 11th will traverse together. So we have divided the whole of the jugular foramen is divided into 3 parts or compartments. For the anterior part, the structure passing is inferior petrosal sinus. Through anterior part, the structure passing is inferior petrosal sinus. Okay, and through the intermediate part, the structure passing is the glossopharyngeal, vagus and that of accessory nerve. Vagus and that of accessory nerve. And if I talk about the posterior compartment, the sigmoid sinus continuing as in the internal jugular vein and the branches of occipital, meningeal branches of, so the branches of meningeal branches of occipital and that of ascending pharyngeal artery. So all these structures are passing through jugular foramen, through the jugular foramen. Now, I also want everybody to note down. So, in short, you can just remember 9th, 10th and 11th cranial nerve is passing through the jugular foramen. Now, I just want everybody to note down the structures, other structures, the structures passing through hypoglossal canal. The other name of hypoglossal canal is anterior condylar canal. It is called as anterior condylar canal. So, the structure passing through hypoglossal canal or anterior condylar canal should be known to you. So, the structures passing is, two important structures passes. One is 12th cranial nerve. And what is the other name of 12th cranial nerve? 12th cranial nerve is also called as hypoglossal nerve, and the other is meningeal branch of ascending pharyngeal artery. Meningeal branch of ascending pharyngeal artery. Meningeal branch of ascending pharyngeal artery. So done. These are the structures passing. Now I would like to talk sometimes what happens. Sometimes if we talk about, sometimes what happens if we talk about this hypoglossal canal or anterior condylar canal. Other than that, sometimes there is presence of posterior condylar canal also. Ma'am, could you explain what is tetany? So we'll talk about that. Let me just finish this. Okay. Okay. So if, okay, Naveen Chaudhary. Okay. So actually, let me finish this. Actually, in general term, if you want to know what is tetany, it's a involuntary contraction. It's a contraction of the muscle. Is called as tetany. And in terms of, there is one syndrome which is related with the injury of 9th, 10th, 11th cranial nerve, where I will tell you about the Werner syndrome or jugular foramen syndrome. In general term, wherever the word tetany means, it is the contraction. It is involuntary contraction of the muscles which is taking place. So exactly, it is involuntary contraction which is caused by the disorder, which is actually increasing the so exactly, it is caused by the disorder, and that is increasing the action potential and frequency of the muscle cells residing. So it is involuntary contraction. In general terms, you can understand it is involuntary contraction. Okay, dear. Okay, Naveen Chaudhary. Okay. Now we will cover this topic. So now sometimes there is presence of posterior condylar canal. So if I am talking about posterior condylar canal, if it is present, it is sometimes only present, and if it is present, the structures passing will be emissary vein. The structure passing will be emissary vein. And this emissary vein which passes to the posterior condylar canal is forming a connecting link. So it is connecting the venous plexus. It is connecting venous plexus. That is which venous plexus? Suboccipital venous plexus. It is connecting the suboccipital venous plexus with that of sigmoid sinus. So this is an important structure which is passing. Other than that, the other structure passing is the meningeal branch of occipital artery. Meningeal branch of occipital artery. So done. Now let's talk about one more foramina which is very important and which is the largest foramina, that is foramen magnum. So exactly, I would just like to enlarge this. So all of you just see, I'm just enlarging this. So what I have enlarged here is the foramen magnum. So let me just outline. So what is this foramen which I have outlined? Wait a minute. This is foramen magnum. What is this foramen? This foramen is foramen magnum. So this entire foramen is the foramen magnum. And it is divided into two parts. So if you will see, it is divided into two parts, A and P, and this is actually what? This is actually the alar ligament. So this ligament is the alar ligament which is attached to the tubercle of occipital condyles, and this alar ligament will divide it into A and P, that is anterior and posterior part. And we have to know the structures passing through the anterior part of foramen magnum, and we have to know the structures passing through the posterior part of foramen magnum. Actually, only osteoligamentous structure, so no nerves and the vessels, no nerves and vessels are passing through it, only ligaments are passing, so it is called as the osteoligamentous compartment. The anterior part is called as osteoligamentous compartment and the posterior part is having nerves and the vessel passing through it, so it is called as neurovascular compartment. So here first thing is that the alar ligament is dividing it into two compartments, anterior and posterior, and the anterior compartment is the compartment which is called as osteoligamentous compartment, and three structures will pass through it. Apical, so here three structures are passing through it. The apical ligament, the three structures are passing through it. The apical ligament of Dens, the upper band of cruciate ligament, and membrana tectoria. Membrana tectoria, these are the three ligaments which is passing through the anterior part of foramen magnum. Now talking about the posterior part, if I talk about the posterior part, we have got neurovascular structure which is passing to the posterior part, that is lower part of the medulla oblongata, fourth part of vertebral artery, and anterior posterior spinal arteries, the sometimes the tonsil of cerebellum, also an accessory nerve. So exactly you can see, so if you will see the anterior part, you can see only green color structures, that is the ligament which is passing through it. Okay, so that is exactly the ligament which is passing through it. But if I talk about the posterior part, it's the medulla lower end and also the arteries and the fourth part of vertebral artery. So we have got spinal accessory nerve, vertebral artery, anterior posterior spinal arteries, tonsil of the cerebellum. All these structures will pass through the posterior part of foramen magnum. So is it okay? Can we solve few MCQs related to it? Okay, so let's talk few. See few MCQs. I just want everybody to concentrate here so that we can solve the MCQs related to this topic. So I just want everybody to solve few MCQs related to this topic of cranial foraminas, which is highly important for you. Okay, dear. So let's talk about this question. So let's solve it. Everyone, let's solve few MCQs. Let's solve the MCQs. Okay, I want those who are live to participate in this. So I just want everybody to participate in this. Okay, so let me read the first MCQ for you. Let me slightly. So I will read this first MCQ for you. Yeah, this is okay. I just want to keep this here so that I can see what you are asking. Okay, a 67-year-old woman with a metastatic lung cancer complains of recent hoarseness and difficulty following the swallowing process. On examination, there is loss of gag reflexes there. On the left side, uvula is deviated to the right. When the patient is prompting the word ah, there is also weakness of her sternocleidomastoid and trapezius muscle. Okay, there is weakness of these muscles also. A lesion involving which of the following structure is most likely to be affected in the patient condition? The options are cribriform plate, foramen ovale, foramen rotundum, hypoglossal canal, internal acoustic meatus and jugular foramen. So all of you please mark the right answer. According to you, which is the right answer? So according to you, which is the right answer? The key words I will highlight. There is paralysis of sternocleidomastoid and the trapezius muscle. There is paralysis of sternocleidomastoid and trapezius muscle. There is loss of gag reflex. There is loss of gag reflex. There is difficulty, hoarseness of voice and difficulty in swallowing also. So anyone, what will be the answer? Actually, head and neck is not done. We are going the reverse way. We are starting with neuroanatomy and then we are coming to head and neck. Actually, we should have started with head and neck and coming to the neuroanatomy. So no worries. I just want everyone to give the hint. The person is not able to breathe quickly, is not swallowing difficulty is there, then that means pharynx, larynx is affected, gag reflex is affected, that means again the glossopharyngeal nerve afferent can be affected, sternocleidomastoid and trapezius is affected, that means nerve supply is affected, and we know that these two nerves are getting innervation from accessory cranial nerve. And what is accessory cranial nerve? Accessory cranial nerve is the 11th cranial nerve. So in short, I have told you about important things. Can you tell me the right answer now? Can you tell me the right answer? So we have got 9th, 10th and 11th cranial nerve affected in this case. 9th, 10th and 11th, and I just told you a foramen through which this 9th, 10th and 11th cranial nerve is passing. So the nerve injured is 9th, 10th and 11th cranial nerve. Okay, so the answer will be jugular foramen. So that is the reason jugular foramen will be right answer, because 9th, 10th, 11th cranial nerve passes through which foramen? 9th, 10th and 11th cranial nerve. No, tomorrow. No, tomorrow. So this is the 9th, 10th, 11th cranial nerve passes through jugular foramen. No, I will take neuroanatomy, Vrishali, tomorrow. Tomorrow is Sunday and I will start early. Tomorrow I will start early at 11 a.m. I will start with head and neck. Today I am going to cover neuroanatomy important parts. Okay. So today is the neuroanatomy. Today I am going to cover neuroanatomy. Tomorrow is the head and neck. So that head and neck part will start at 11. So exactly jugular foramen is the right answer. Cribriform plate is wrong. Why? Cribriform plate, the structure passing will be olfactory nerve rootlets. So exactly olfactory nerve rootlets passes through it. Foramen ovale is wrong because mandibular nerve passes through it. Foramen ovale is wrong. Foramen rotundum, the maxillary nerve passes through it, so it is wrong. Hypoglossal canal wrong because the 12th cranial nerve passes through it. Internal acoustic meatus is wrong because the 7th and 8th cranial nerve passes through it. 7th and 8th cranial nerve passes through it. Okay. Now, the patient is having a sign and symptoms and the involvement is of jugular foramen, and we know that through jugular foramen 9th, 10th and 11th cranial nerve is passing, and the compression of these nerve by any kind of tumor or any structure. So, we can see here, so I just want you to show the internal acoustic meatus, the structure passing will be 9th, 10th and 11th, and we know that the patient's sign and symptom is consistent with jugular foramen syndrome. Actually, this syndrome is called as jugular foramen syndrome. The other name of jugular foramen syndrome is Wernicke syndrome. What is it called as? It is called as Wernicke syndrome. It is called as Wernicke syndrome. So, loss of taste sensation is from the posterior 1/3 part of the tongue. Loss of taste sensation is from the posterior 1/3 part of the tongue. Reduced parotid secretion is there because of involvement of 9th cranial nerve, loss of gag reflex 9th, 10th, 11th involved, dysphagia, dysphonia due to involvement of vagus, dysphagia, difficulty in eating and all, 9th, 10th, soft palate deviation due to 10th nerve, sternocleidomastoid muscle and trapezius muscle is paralyzed because of accessory or 11th cranial nerve being involved. Now, these all are wrong as I have told you, because cribriform plate, the olfactory nerve rootlet passes, foramen ovale, the mandibular nerve rootlets passes, foramen rotundum maxillary, hypoglossal canal, 12th cranial nerve, internal acoustic meatus, the 7th, 8th cranial nerve passes through. Now, which foramen transmit nerve branches to meninges? Which foramen transmit nerve branches to meninges? So, we have got 5 options and we have to mark the right answer. Which foramen transmit nerve branches to meninges? Foramen spinosum, mastoid foramen, jugular foramen, foramen magnum and foramen ovale. So, according to you, which is the right answer? So, anyone wants to give the answer? As I have told you, foramen spinosum, the structure passing is nervous spinosum. So, the right answer will be foramen spinosum, through which passes nervous spinosum, which is giving innervation to the meninges, which gives innervation to the meninges. So, A is the right answer. Okay. Now, which foramen? So, foramen magnum is leading to the passage of all the following structure except the options are medulla and meninges, vertebral arteries, spinal root of accessory nerve, dural veins, internal carotid artery. According to you, which is the right answer? According to you, which is the right answer? So, we know exactly internal carotid is the right answer, because internal carotid artery will traverse through carotid canal. It will not pass through the foramen magnum. Else, I can say medulla, meninges, vertebral artery, spinal root of accessory dural veins, all will pass through it. So, all these structures will pass through it, but not the internal carotid artery will not pass through it. Now, jugular foramen transmit all of the following. So, those who are live, I just want everybody to participate in this MCQ, and today I just want to complete more of few topics like spinal cord and cranial nerves and all, and tomorrow will be head and neck, and if one or two topics are lying, we can just merge that also, no worries about that. But so don't, I want to continue and complete as much as we can complete the important topics related to neuroanatomy, because this will help you to get a better rank and better marks in your competitive exam. Okay. So, just so you have to concentrate. I can understand if we take long sessions for the live session, at times the students get not able to concentrate for long duration of time, but it's okay. We will have a small break in between and then also we can continue. Okay. So, jugular foramen transmit, but now I am going to continue for another 1 hour and more. After 1 hour, I will give you a small tea break of 10 minutes. Okay. Jugular foramen transmit all except. So all of the following structure transmitted by the jugular foramen except glossopharyngeal nerve, ninth, vagus, accessory, inferior petrosal sigmoid or sympathetic plexus. So anyone who wants to give the answer, just now I told you also about the jugular foramen. So according to you, which is the structure which is not passing through the jugular foramen? The right answer is sympathetic plexus. Sympathetic plexus doesn't pass through jugular foramen. Foramen of cribriform plate, through which structure passes? Which structure passes through foramen of cribriform plate? Which structure passes through foramen of cribriform plate? I will just wait for a few seconds. Please mark the right answer. Foramen, the structures passing through cribriform plate. Which structure passes through cribriform plate? The correct answer is axons of olfactory cells passes through it. In addition to optic nerve, the optic canal transmit which of the following structures? Ophthalmic vein, oculomotor nerve, internal carotid artery, ophthalmic artery, nerve branches to meninges. In addition to optic nerve, optic canal, okay. In addition to optic nerve, optic canal transmit which of the following structure? So if you remember, I told you the optic canal 2O passes, 2O. So which is the other structure which is passing through the optic canal? Ophthalmic artery is the right answer. So we have got ophthalmic artery as the right answer. Now maxillary division of the trigeminal nerve. If we talk about maxillary division of trigeminal nerve, it passes through which of the following foramen? Foramen rotundum, foramen ovale, superior orbital fissure. Maxillary division of trigeminal nerve is transmitted through which foramen? Foramen rotundum, foramen ovale, superior orbital fissure, foramen spinosum, foramen lacerum. Which is the right answer? So I think it will be there, but I want everybody to be live, okay? So that I want to cover two, three more important topics, because like after this foramens and all, I want to give you the idea of the cranial nerve nuclei and functional component, and I want you to cover that nerves also, and spinal cord and brain stem syndromes and all. So if you be live, then it is good for us. You can see it afterwards also, I feel, but I just want everybody to be live. Okay, so just just complete this. So maxillary division of trigeminal nerve. Okay, so the maxillary division, the correct answer will be the foramen rotundum. Is the foramen rotundum. Okay. Which foramen is located in anterior cranial fossa? Which foramen is located in anterior cranial fossa? Yes, Sham, you are right. Yes, Sham, you are right. Okay, yeah, some students want it to be go in a faster pace, but when I was going at a faster pace, some students want me to keep slow. So that is the reason we have to go according to the various students. So can you tell me the right answer? Which foramen is located in anterior cranial fossa? Foramen cecum, optic canal, superior orbital fissure, foramen ovale, condylar canal. Which of the following foramen which is mentioned in the option? So here Azan is right. Azan, foramen cecum is right. Yes, Azan, you are right. Absolutely right. So yes, Azan is right. Okay, okay, dear. Now let's come to the next topic, that is cranial nerve nuclei and functional components. So exactly to understand all the cranial nerves, if we talk about all the cranial nerves, it's important that we should have an idea of functional component of the cranial nerves nuclei, then only we can go for the entire cranial nerve. So I just want everybody to understand that, that is the functional component and cranial nerve nuclei. So let's start with this. Okay, so let's talk about the cranial nerve. So how many pairs of cranial nerves are there? So anybody knows how many pairs of cranial nerves are there? As we already know, we have got 12 pairs of cranial nerves. So that is exactly there. But other than that, we have also got the 13th pair, which is called as the zero pair. So other than that, we have also got the 13th pair or the zero pair. So exactly there are 12 pairs of cranial nerve, and we know that here olfactory is the first cranial nerve, optic is the second cranial nerve, oculomotor is the third cranial nerve, trochlear is the fourth cranial nerve. Yes, but we have got the zero pair also. So fifth is the trigeminal cranial nerve, sixth is the abducen. Can you tell me the zero pair cranial nerve? Sam and everyone, can you tell me the zero pair cranial nerve, which is also called as the 13th pair? Then we have got the 7th cranial nerve. Then we have got the 8th cranial nerve, vestibulocochlear. The is the 8th cranial nerve, glossopharyngeal is the 7th, vagus is the 10th, accessory is the 11th, which is having the cranial and spinal part, and hypoglossal canal is the 12th cranial nerve. So altogether there are 12 cranial nerves, but there is also a 13th pair which is called as the zero pair cranial nerves. So as I told you, there is a 13th pair cranial nerve which is also called as zero pair, and the other name of this 13th pair cranial nerve is, if I talk about 13th pair cranial nerve, it is also called as, the other name is, it is also called as nervi terminalis. It is also called as nervi terminalis, and this is also called as the zero pair cranial nerve. Now the function of this nervi terminalis or zero pair cranial nerve is that it is related with the function of smell mediated sexual behavior. Oh, it's okay. So yes, please wrote down. Please write down the 13th pair cranial nerve. So if we talk about 13th pair cranial nerve, that is called as the zero pair. At the function is established, at the function is yet to be established, and the function is, it is lying close to so if we talk about the zero pair, it is lying close to anterior perforated substance. It is lying very close to the anterior perforated substance, and the location of this 13th pair cranial nerve will be posterior to the olfactory stria. Where is it is located? It is located posterior to olfactory stria, and the function of this 13th pair cranial nerve is, it is related with smell mediated sexual behavior. Smell mediated sexual behavior. Now let's talk about morphological classification of cranial nerve. So if we want to just classify the cranial nerves, we can use three categorization: So the first will be the categorization of the muscles which is derived from the cranial myotomes. The second will be the categorization of the muscles which is derived from the pharyngeal arches and getting innervation, and the third will be associated with the special sense. So altogether we have got a three classifications. So we have got three classification: first, second and third. So the first, so please write down. The first category will be cranial nerves, CN for cranial nerves supplying muscles derived from cranial myotomes. And the category of these cranial nerves are, the category of these cranial nerves will be third, fourth, sixth and 12th cranial nerve. The next is the category of the cranial nerves supplying muscle derived from branchial arches. And these cranial nerves are fifth, seventh, ninth, 10th and 11th. The next category is of the cranial nerves which is associated with the function of special, senses, associated with the function of special and these kind of cranial nerves are first, second and that of eighth. First is with the function of olfactory. Second is for the vision, and eighth is for vestibulocochlear nerve. Eighth is of vestibulocochlear nerve. So done with this. Now let's talk about the functional column and cranial nerve nuclei. Actually, if we are talking about the few years, so in the FMG examination also, it's very important that you should know functional component and cranial nerve nuclei. So exactly to understand it, you have to know slight embryology of the spinal cord development. So the development of functional component and cranial nerves should be well understood to you. So exactly, if I talk about the function of developmental aspect of the functional columns, you have to know that during the development of spinal cord, what happens? There is an appearance of longitudinal groove in the lateral wall. So when, as we know, when the So exactly, if we talk about the functional component and cranial nerve nuclei, so it's very important that you should know about this. So during development of spinal cord, there are certain changes which is going on, and because of that changes which is going on, there is an appearance of longitudinal groove, that is sulcus limitans, the lateral wall of the neural tube. We know the spinal cord will be formed from the neural tube. So when that developmental process is going on in the lateral wall of the neural tube, there is appearance of sulcus limitans. It will divide the lateral wall of neural tube into two components, that is the dorsal and the alar. Now, the dorsal part is also called as the alar, which is the sensory, and the ventral part is basal, and which is motor in function. So, I would like to start with that. Development of functional component and cranial nerve nuclei. So, during development, okay, during development, so during development of spinal cord, due to appearance of due to appearance of longitudinal groove that is the sulcus limitans, the lateral wall of neural tube, NT means neural tube, is divided into two parts. Neural tube, it is divided into two parts. It is divided into two parts. In two parts or lamina. So we have got so it is divided into dorsal alar lamina and it is divided into ventral basal lamina. So when we talk about when we are talking about dorsal alar lamina, the dorsal alar lamina is sensory and the other one, that is the basal or the ventral one, is the motor. Now it is important for us to understand that how the further development. So this is the initial development. After so now we are at a position where the lateral wall has been divided by sulcus limitans into two components. So the dorsal is the sensory one and the ventral is the motor. Further, what happens? The cells of these laminas are getting arranged in the form of functional column, and there is formation of how many functional columns? There is formation of 4 functional columns. So we have started with the topic of the development of the spinal cord. The neural tube is being divided into two parts, its lateral wall, and after the formation of the sensory and the motor component, there is yet another change which takes place. That is, the cells of these two laminas get organized into form of longitudinal columns following 4 functional columns. So from ventral to dorsal, what do you mean? That means from anterior to posterior, we will have how many functional columns now? We will have 4 functional columns. We will have general somatic efferent column. We will have general visceral efferent column. We will have general visceral afferent column. We will have general somatic afferent column. That means 2 sensory and 2 motor. So together how many? 4. So write down the cells of these two laminae, get arranged in two longitudinal column. It arranged into 2 longitudinal columns. The somatic and visceral. So there are 4 functional components. So there are 4 functional columns. So altogether there are 4 functional columns. Please write down the name: 2 sensory and 2 motor. So we have got general somatic efferent column, we will have general visceral efferent columns, we will have general visceral afferent columns, and we will have general somatic afferent columns. So that is GSE, GVE, GVA and GSA. So these are together. So that means together we have got following functional columns formed. So there are 4 functional columns till now formed. So there is formation of 4 functional columns to be formed here as shown. Okay. Okay, dear. So we have got these functional columns. So till now, how many functional columns are formed? 4. But the overall target is to formation of 7 functional components. So and columns. So here, as you can see, I just want how the 7. So actually, after that, now the next step of development comes, and after that, what happens if we are talking about the next step of development which is coming up? There are when the development of hindbrain happens, there is 2 changes which happens. Okay. So the neural tube will widen, and now the fourth ventricle, neural tube widens to form fourth ventricle, and you can see here the fourth ventricle will form and the neural tube is widening. So the arrangement of the functional component or column which was from anterior to posterior is now arranged from medial lateral. So there is actually opening of the lamina. So opening of. So when the cavity was like this, now it has opened up. So the alar lamina is opened up like the opening of the book. So the alar lamina has opened up like the opening of the book, and the arrangement of the functional column has been changed from ventral to posterior to that of medial and lateral. Now again there is actually in between the general visceral and general somatic columns, there is addition of special visceral or branchial. There is addition of special visceral or branchial columns. So here together there will be 6. And at the 7th or lateral most position, there is addition of special somatic afferent. So how many? 7 functional columns are formed. So this will lead to the formation of 7 functional columns. So the neural tube widens and the fourth ventricle forms. Alar lamina splashed up like opening of the book, and the arrangement of the functional column from anterior to posterior is now changed from medial to lateral. Mediolateral. So it has changed from mediolateral, and there is actually already we know that there was already 4 functional component. In between there is an addition of special visceral efferent, special visceral afferent, and the last one, that is special somatic afferent, that is an additional one added at the lateral most position. So together, as in this diagram also you can see, there is formation of 7 functional component. Okay. So here because of this, as I have already explained, because of the changes which is happening up, there is formation of 7 functional components. So there are formation of 7 functional component, and I have just explained the procedure. I just want everybody to write it, the name. So please write down the functional component name. So in short only I will write general somatic efferent, special visceral efferent, general visceral efferent, general visceral afferent, special visceral afferent, general somatic afferent, and the lateral most is the special somatic afferent. Now here first 3 is the motor columns. First 3 is the motor columns, and the last 4 is the sensory columns. Last 3 is the sensory column. So this is how the functional component has been formed, and a total of 7 functional component is formed. Now I just want that you should note down cranial nerve nuclei. Now it is important that you should know about the cranial nerve nuclei in relation to these functional components. So if I talk about general somatic efferent, if I talk about general somatic efferent, the general somatic efferent has got. So if I talk about general somatic efferent, it is in category of general somatic efferent column. When we are talking about general somatic efferent, that means they are giving innervation to the general somatic efferent की बात करते हैं तो general somatic efferent fibers are getting is giving innervation to the striated group of muscles. So what is the function? They are giving innervation to striated group of muscle. The muscle developed from somite, and in this category we have got 4 cranial nerve nuclei: oculomotor, trochlear, abducent and hypoglossal. When we are talking about special visceral efferent means they are giving innervation to the muscles derived from pharyngeal arches. So in this category we have got trigeminal motor, facial motor and nucleus ambiguous. This is a composite nucleus of 9, 10th and 11th. General visceral efferent columns की बात करें तो general visceral efferent column is for the parasympathetic outflow, cranial outflow for parasympathetic innervation, and in this category we have a total of 5 cranial nerve nuclei, that is Edinger-Westphal nucleus, superior salivatory nucleus, inferior salivatory nucleus, dorsal nucleus of vagus and lacrimatory nucleus. Now if I talk about now the so we have done with the efferents and the motor. Now I would like to talk about the afferents. So when I am talking about the afferents, it's very important to know that both general visceral afferent and special visceral afferent is having one cranial nerve nuclei, that is the nucleus of tractus solitarius. That is nucleus of tractus solitarius, which has got a so 2 functional column is having one cranial nerve nuclei. General somatic afferent column, अगर हम general somatic afferent column की बात करते हो तो this is for proprioceptive and that of exteroceptive sensation, and this is related with the 3 cranial nerve. This is related with the sensory nucleus of trigeminal nerve, which is having 3 parts: chief sensory nucleus of trigeminal nerve, mesencephalic and the spinal nucleus of trigeminal nerve. Special somatic afferent has got a special function of hearing and balance, and with this relation we have got 2 cranial nerve nuclei, cochlear and vestibulocochlear. Cochlear and vestibular nucleus. So we can see we have a total of 7 functional component, and this is related with following cranial nerve nuclei. The same thing has been shown here also. The 7 functional component, their location has been shown and their correlated location has to be known here. But I just want everybody that you should be aware in slight detail about the location of these functional cranial nerve nuclei. So I want that there are 7 functional components to which cranial nerve nuclei, which we have already talked. One by one I want to give you the details. So there are 7. There is 7 functional component. There is 7 functional components, and in this relation you have to know the cranial nerve nuclei to which the it's belonging. So let's start with the first. So I would like to talk about general somatic efferent first. So we should know about the general somatic efferent. Okay, so if I am talking about general somatic efferent, in this categorization we have got 4 nucleuses. So I just want everybody to know about the location of these nucleuses. So the first one is oculomotor nucleus. So when we talk about the oculomotor nucleuses, you have to know that where it is located. So it is located in the midbrain. So it is located in the central gray matter of midbrain, ventral to cerebral aqueduct, and it is located at the level of superior colliculus. So it is located in central gray matter. It is located in central gray matter of midbrain, ventral to Vrushali, no, it will finish, Vrushali, it will finish by 9, by 9, by 9 p.m. Yeah, by 9 p.m. only I will finish, by 9 p.m. In between, I will give you 10 minutes break. Okay, let me complete this topic. I will give you 10 minutes break. Okay. So till 9 I will take, because I want to complete many important topics of neuroanatomy. So I just want that till 9 to hame continue, till 9 we should continue. In between, after 7 I will give you 10 minutes break, and then we will continue till 9. Is it okay? Central gray matter of midbrain, ventral to cerebral aqueduct. Ventral to cerebral aqueduct at the level of superior colliculus. At the level of superior colliculus. Okay, in this category itself, the second nucleus is the trochlear. The trochlear nucleus. So when we are talking about the fourth cranial nerve nucleus, that is the trochlear nucleus. In this category, I just want to tell that it is also located in the midbrain. It is also located in the midbrain at the level of inferior colliculus. The next is abducent nucleus, and when we are talking about abducent nucleus, the abducent nucleus is located in the lower pons beneath facial colliculus, beneath facial colliculus. And the fourth one is hypoglossal nucleus, and when we are talking about hypoglossal nucleus, it is an elongated nucleus. It is an elongated nucleus column. It is an elongated nucleus column extending throughout the length of, it is located lengthwise in the medulla in paramedian plane. In the paramedian plane. Okay. Now, in paramedian plane. In the paramedian plane. Now we have finished with the general somatic efferent. We have finished with the general somatic efferent nuclei and their location I want to show. So here they are on motor. So you can see in this category we have got the following important locations of this nuclei. So see here, we have got the oculomotor at the level of superior colliculus. In the midbrain we have got trochlear nucleus at the level of inferior colliculus, which you can see here. We have got the other one is the sixth, and so we have got the abducent nerve nucleus and the hypoglossal nerve nucleus. So abducent is in the pons, these two are in the midbrain. Hypoglossal is the elongated nucleus in the medulla. Now let's talk about the special visceral branchial efferents. If I talk about the special visceral branchial efferent, it is continuing. It is of following types. The one is the motor nucleus of trigeminal nerve. Motor nucleus of trigeminal nerve. And if I talk about the motor nucleus of trigeminal nerve, it is located in the upper part of pons. It is located in the upper part of pons. Now coming to the nucleus of facial nerve. Motor nucleus of facial nerve, and if I talk about the motor nucleus of facial nerve, it is located in the lower part of pons. But it emerge out from the pontomedullary junction. The third is nucleus ambiguous. The third nucleus is nucleus ambiguous. When I am using the word nucleus ambiguous here, now if we are talking about the special branchial efferent nucleus. So when I am talking about nucleus ambiguous, this is a composite nucleus in relation to 9th, 10th and 11th cranial nerve. So it is a composite nucleus in relation to 9th, 10th and 11th cranial nerve. And this nucleus has got an important function of innervating the muscles of pharynx, larynx and soft palate, and nucleus ambiguous is located, it's an elongated nucleus, and it is also located in the medulla. Now coming to the general visceral, the next is general visceral efferent nuclei. So if we are talking about general visceral efferent nuclei, the first nucleus in this category is Edinger-Westphal nucleus. So if I talk about Edinger-Westphal nucleus, it is also located in the midbrain and it is located close to the third cranial nerve, that is oculomotor nerve. Edinger-Westphal nucleus is located in the upper part of the midbrain and it is closely related to the main oculomotor nucleus. So it is located in midbrain close to main oculomotor nucleus. Now next is the superior salivary nucleus. Next is superior salivary nucleus, which is also called as lacrimatory nucleus. So if we are talking about superior salivary nucleus or the lacrimatory nucleus, actually they are indefinite cluster of small nerve cells. So they are indefinite cluster of small nerve cells in dorsal part of pons, and they are located medial to the nucleus of facial nerve and all. And let's talk about, let's talk about inferior salivary and dorsal nucleus of vagus. So this is about second and third together only. Lacrimatory nucleus is also very close to superior salivary nucleus, and the next is the inferior salivary nucleus. Inferior salivary nucleus, actually the function of all these nucleus will be done along with the cranial nerve. For example, inferior salivary nucleus is related to glossopharyngeal nerve and it is related for parasympathetic secretomotor secretion from parotid gland. So now I am just telling you about the nucleuses and their location, but I will correlate with the function in the cranial nerve. Inferior salivary nucleus is again a small cluster of nerve cell. It is located in the dorsolateral part of pons. It is located in the dorsolateral part of pons, just above the junction of, location is lying just above the pons junction with the medulla. It is located in dorsolateral part of the pons. The last nucleus in this category is dorsal nucleus of vagus. Dorsal nucleus of vagus. Actually, dorsal nucleus of vagus is a long vertical column. It's a long vertical column of cells extending throughout the medulla. So it is also extending in the medulla. And dorsal nucleus of vagus is located in the floor of fourth ventricle. So in short, again I will go to that image because we have done with all the motor one. So in short, we have done with all the motor one. So अगर हम बात करते हैं, if we are talking about the parasympathetic cranial outflow nucleuses and all, so we are talking Edinger-Westphal nucleus, we are talking about superior salivary nucleus, facial is the motor one, but inferior salivary nucleus, dorsal nucleus of vagus. So all these nucleuses are related with parasympathetic innervations, and we have got a few of the nucleuses related with the pharyngeal arches, like motor nucleus of the fifth nerve, facial nucleus, and that of nucleus ambiguous related with 9th, 10th and 11th nerve. So what you can see in this image, that this is an image showing the schematic diagram of the image showing brainstem. So here there is two colors used. One side red color is there for the location of motor nucleus and the blue color is used for the location of sensory nucleus. So the red color is defining the location of motor nucleus, blue color is defining the location of sensory nucleuses. So let's talk about So we have done with this. Now I would like to talk about the special visceral afferent. So let's talk about the special visceral. So exactly one of an important point is that if we talk about general, special and special visceral efferent functional column, one cranial nerve nuclei is there. So these two functional column is having one cranial nerve nuclei related to it, and the name of that nucleus is nucleus of solitary tract. So there is one nucleus related to it which is called as nucleus of solitary tract. So if we talk about the nucleus of solitary tract, it is elongated. It is elongated column of cells, and it is intimately related to group of descending fibers which forms tractus solitarius, So this is about the nucleus of solitary tract. This is about the nucleus of solitary tract which I am talking. So we have got two functional component, that is sensory one, which is having one cranial nerve nuclei, that is nucleus of solitary tract. So it is located in the medulla. So again, if you will see this image, you can see nucleus of tractus solitarius. So this is the nucleus of tractus solitarius. You can see it is elongated nucleus in the medulla part. It is elongated nucleus in the medulla part. Also, if we talk about general somatic afferent, so general somatic afferent is formed by the nucleus of trigeminal nerve, sensory nucleus, and you can see it is having three parts. The main sensory nucleus is in the pons. Upper extension from the sensory nucleus is forming mesencephalic nucleus, which is located in the midbrain. And the elongation lower down, you can see from the main sensory, there is a spinal nucleus of trigeminal nerve. Actually, it is going down till the second cervical. It is going down in the cervical segment of the spinal cord, and this is called as spinal nucleus of trigeminal nerve. So please write it. So if I talk about general somatic afferent nucleus, the three sensory nucleus of it is corresponding to three sensory nuclei of trigeminal nerve. And the three sensory nucleus of trigeminal nerve which it constitutes is, please write down the name, then one by one I will describe. The one is the chief sensory, the one is chief or the main sensory trigeminal nerve. So one is the chief sensory or the main sensory trigeminal nerve, chief sensory trigeminal nucleus. Then we have got mesencephalic trigeminal nucleus. Then we have got the spinal trigeminal nucleus, the spinal trigeminal nucleus. So together we have got the three trigeminal nucleus as the chief sensory, the mesencephalic and the spinal trigeminal nucleus, and we have to know the location of each one of it. So I just want with the first one. So firstly I would like to write everyone about the chief sensory trigeminal nucleus. So if I talk about chief sensory trigeminal nucleus, actually this is located in the dorsolateral region. What is the location? If I talk about the chief sensory trigeminal nucleus, it is located in the upper part of the pons. So it is located in the upper part of pons, and its location is lateral to the motor nucleus of trigeminal nucleus. It is located lateral to motor nucleus of trigeminal nerve. And exactly if we talk about chief sensory trigeminal nucleus, it is having intermediate position. Exactly, it is intermediate in location. When I am using the word intermediate, what does that mean? That means that chief sensory trigeminal nucleus is located in between the mesencephalic and spinal nucleus of trigeminal nerve. An important function with which the chief sensory trigeminal nucleus is concerned is it is concerned with tactile stability, tactile sensibility. So an important function of it is having a function of, it is concerned with the function of tactile sensibility. Now talking about the spinal nucleus of trigeminal nerve. So if I talk about the spinal nucleus of trigeminal nerve, it extends caudally from chief sensory nucleus, of trigeminal, from chief sensory nucleus, and sensory nucleus of, it extends from chief sensory nucleus of trigeminal nerve to second cervical segment, to the level of second cervical segment of the spinal cord. And what is the function with it is concerned? So it is concerned with the function of, it is concerned with the sense of pain and temperature. It is concerned with the sense of pain and temperature. The function is, it is concerned with the pain and temperature function. Now after this we will have the one more nucleus, that is the chief sensory and the spinal nucleus. We have got one more nucleus in this category, that is the mesencephalic nucleus of trigeminal nerve. So just write down the third one, mesencephalic nucleus of trigeminal nerve. So please don't get confused with this. I will just rub for this, otherwise you will get confused. This is for the general somatic afferent, no? So mesencephalic nucleus of trigeminal nerve. So mesencephalic nucleus of trigeminal nerve. So if I talk about mesencephalic nucleus of trigeminal nerve, it is actually an upward extension. It is an upward extension from the chief sensory. So it is upward extension. It is an upward extension from chief sensory nucleus to midbrain, where, and it is actually concerned with the sensation of, the function is, if I talk about the function of mesencephalic nucleus of trigeminal nerve, it is concerned with the function of, proprioceptive sensation. It is concerned with the function of proprioceptive sensation. So it is concerned with the function of proprioceptive sensation. Okay, so done with this. Now what so we have done with this. Now so we have done with this. Now we are left with the special somatic afferent nuclei. So when we are talking about special somatic afferent nuclei, we are concerned with the one nuclei related to it. Actually it is related with the vestibulocochlear nuclei. So it is related with the vestibulocochlear nuclei. That means it is having two components. One is the cochlear nuclei. So one is the cochlear nuclei. So cochlear nuclei has got a function of hearing, and vestibular is of balancing, vestibular nuclei. So they are further divided. So if we are talking about the cochlear nuclei, it is having dorsal and ventral cochlear nuclei located and placed dorsal and ventral to inferior cerebral peduncle. The vestibular nuclei is having four components: inferior vestibular nuclei, lateral vestibular nuclei, medial vestibular nuclei, and superior vestibular nuclei. And you have to know about the location of these vestibular nuclei. So please write down. Cochlear nuclei is of two varieties, dorsal and ventral. Dorsal and ventral cochlear nuclei, dorsal and ventral cochlear nuclei are arranged dorsal and ventral to inferior cerebral peduncle, ICP. I have written in short ICP. What do you mean by ICP? They are arranged ventral and dorsal relation with the inferior cerebellar peduncle. Inferior with the dorsal and ventral relation with the inferior cerebral peduncle. This is about the cochlear nuclei. Now talking about the vestibular nuclei. So I just want everybody to know about the vestibular nuclei. So if I talk about vestibular nuclei, so let's talk about the vestibular nuclei. So vestibular nuclei are four components we have got in the vestibular nuclei. One is inferior, vestibular nuclei, which is located in medulla, just medial to ICP. What is ICP? Inferior cerebral peduncle. The second one is lateral vestibular nuclei. The lateral vestibular nuclei is located cranial to inferior vestibular nuclei. So exactly it is located, if we talk about the lateral vestibular nuclei, it is located cranial to inferior vestibular nuclei. That means it extends into the pons. Also. And if I talk about the third category, that is the superior vestibular nuclei. The superior vestibular nuclei is the superior one is smaller in size and is entirely located in the pons. It is entirely in pons. Exactly, if we talk about the superior vestibular nuclei, it is located entirely in pons above the medial and lateral vestibular nuclei. Above the medial and lateral vestibular nuclei. Above the medial and lateral vestibular nuclei. The next is the last is medial vestibular nuclei. The last is medial vestibular nuclei. Okay, the last is, let me just check. So the last is medial vestibular nuclei. And if I talk about medial vestibular nuclei, this is extending into the medulla. It extends from medulla. To that of to the pons lower part. So done with all the vestibular nuclei we have done. So exactly we have done with all the important cranial nerve nuclei. Actually, what I think that for your that cranial nerve, so important nerves is that of the 7th, 9th vagus, and actually like for tongue I will teach, then hypoglossal nerve I will tell you along with it. And agar hum pathways, if I am talking about the pathways, the important pathway is the visual pathway. So let me discuss few MCQs related to this cranial nerve and functional component, and few of the important nerves like 3rd, 4th, 6th, 7th, 9th and 10th, and hypoglossal will be done with all the nerves and areas, so which we can also do in the next session. But if I want to talk about the next topic, which I will complete after this cranial nerve, I will go with that of the spinal cord and that of brainstem. So let's talk about the questions to be solved. So please solve few MCQs related to this, and after that I will give you a break of 15 minutes and then we will start. All of the following cranial nerve nuclei contains somatic efferents except. All of the cranial nerve contains somatic efferents except. So you can just pause. If you have written the notes along with me, you will be able to understand. All of the following cranial nerve contains somatic efferents except 7th cranial nerve, 3rd cranial nerve, 4th and the 6th cranial nerve. All of the following cranial nerve nuclei contains somatic efferents except. Somatic efferents except. What is the right answer here? What is the right answer? So exactly, if I talk about the right answer here, the right answer will be the 7th one, because 7th is related with the muscles derived from second pharyngeal arches. It is the special visceral efferent. So the 7th is the right answer. Other than that, 3rd, 4th and 6th is related with the somatic efferents. So the correct answer is 7th cranial nerve. Now, all of the following pairs regarding neuronal columns and associated cranial nerves are correct except. So, all of the pairing which is done between the neuronal columns and the cranial nerve nuclei associated with it is correct except. Which is the wrong pair? Which is the wrong pair? Hypoglossal nucleus, general somatic efferent, nucleus ambiguous, special visceral efferent, dorsal nucleus of vagus, general visceral afferent. Okay, tractus solitarius is special visceral afferent. So, one is the wrong pair and you have to identify which is the wrong pair. You have to identify the wrong pair. The correct answer will be dorsal nucleus of vagus, which is not general visceral afferent, it will be general visceral efferent. It should be general visceral efferent. So, this is the wrong pair, it should be general visceral efferent, not general visceral afferent. So, that is the wrong pair which has been used here. This is the wrong pair. Now, taste pathway come under which of the neuronal column? Taste pathway will come under which of the neuronal columns? Taste pathway will come under which of the neuronal columns? Taste pathway come under which of the neuronal columns? Special somatic afferent, general somatic afferent, special visceral afferent, general visceral afferent. So, the taste sensation is special visceral afferent. What is it? It is special visceral afferent. So, it come under special function, special visceral afferent. It is coming under special visceral afferent. So, the correct answer is C. The correct answer is C, special visceral afferent. Now, which of the following cranial nerve nuclei belong to general visceral efferent column? General visceral efferent column. Which of the following cranial nerve belongs to general visceral efferent column? Facial nerve nucleus, trigeminal nerve nucleus, dorsal nucleus of vagus, nucleus ambiguous. General visceral efferent. That is cranial outflow of parasympathetic innervation. So, when the question is being asked about general visceral efferent, that is for the cranial, that is for the cranial outflow. So, cranial outflow of parasympathetic innervation, and that correct answer will be dorsal nucleus of vagus. Correct answer is dorsal nucleus of vagus in this category. Now, nucleus ambiguous does not include, the next question, nucleus ambiguous does not include nucleus ambiguous does not include which of the following nucleus? 7th cranial nerve, ninth cranial nerve, 10th and 11th. So exactly if I talk about nucleus ambiguous, it is important for the innervation of pharynx, larynx and soft palate. So it is giving innervation to the muscles of pharynx, the muscles of larynx and the soft palate. So exactly if I talk about nucleus ambiguous, not including which nucleus, the correct answer will be facial nucleus. Facial nucleus is not the nucleus included in the category of nucleus ambiguous. Other than that, 9th, 10th and 11th is included in the category of nucleus ambiguous. So we have got A as the right answer. Okay, dear. So any of the student is having any doubt, so you can ask me. So exactly what I want everybody to understand, that we have finished many important things. We have finished the meninges, we have finished the dural venous sinus, we have finished the cavernous sinus, we have finished the all types of foraminas, we have finished about the cranial nerve nuclei and the functional component. The cranial nerves individually, few of this which is very important for examination, I will complete in the next session. But today I want to complete the brainstem. I want to complete the brainstem syndrome and spinal cord. So I just want everybody to get connected. So I will take another 2 hours session more. I am just giving you 10 minutes break, 10 to 15 minutes of break. Take a tea break, and again I will resume. Is it okay, everyone? So again I will resume for the session because I have to complete brainstem and spinal cord also. Is it okay, everyone? Okay. And tomorrow the session will be from 11, but I will just resume right itself. So I just want everybody that after, so I will give you a break of 15 minutes break, 15 minutes break. Okay. So there will be a break, and then again after 15 minutes I will start. So I will start firstly with the spinal cord, the clinical anatomy, general anatomy and gross anatomy and all. And then I will start with the brainstem, the pons medulla, and then I will also cover the brainstem syndromes. Okay. Okay, so let's start with the another part. Okay, so let's start with the. Okay, I was just checking whether I am audible or not. So yes, am I audible? So yes, I am audible. I just started now. So we will talk about the spinal cord now. Okay, so we are the next topic which I want to take is the spinal cord. I want to cover the spinal cord and the brainstem, very important topics, which is highly important. And let's start with this. So exactly, if I talk about, first thing is to know about the introduction of the spinal cord. I would like to talk about the introduction part. So what is the spinal cord? You have to know. What is its covering? You have to know. And let's start with this. So introduction, the spinal cord is the long cylindrical. If I talk of the spinal cord, it's a long cylindrical structure. And where is the spinal cord residing? So exactly, it is residing inside the vertebral canal. So it is residing inside the vertebral canal, and it is having a covering of membranes. So it is having the three meningeal covering which we have talked about. It is having the covering of dura mater, it is having the covering of arachnoid mater, it is having the covering of pia mater. So that is exactly which you have to know. So the spinal cord is a long cylindrical structure. The spinal cord, if I talk about the spinal cord, it's a long cylindrical structure. It is actually the lower part of central nervous system. So it's the lower part of the central nervous system. And it is actually, if we see the medulla oblongata, so this is actually when you continue the spinal cord rostrally, it will continue as the medulla oblongata. So that continuation is called as medulla oblongata, and it will end at the level. So it's very important to know the ending level of spinal cord, and that is determined as the conus medullaris. What is it called as? Conus medullaris. So any of the student is having any doubt, they can ask me. So the ending point of, if I talk about the area where the spinal cord is ending, that is called as conus medullaris, and definitely in case of adult, it corresponds to the level of first lumbar vertebra. So it is ending at the level of first lumbar vertebra, and the total number of the spinal nerves which emerge out from the spinal cord is 31 pairs of the spinal nerve. So there is a total of 31 pairs of spinal nerve. So there is a total of 31 pairs of spinal nerves which is emerging out. So exactly, and the part of the spinal cord from which one pair of the spinal nerve is emerging. If I talk about the part of the spinal cord from where one pair of spinal cord is emerging, that part is called as the segment. That is called as spinal segment. Okay. So it's very important that you should know what is spinal nerve and what is the spinal segment. So you have to know the differentiating point of both. It's very important that you should know the differentiating point of both. So any of the students, if you are not understanding anything, you have got any doubt, you can just write here in the message. Okay. Okay. Any doubt, dear? Any doubts? Okay. Now, here I just want you to show that below the conus medullaris, there is an extension of pia mater of the spinal cord, and that extension of the pia mater of the spinal cord is called as phylum terminal. So, what you can see, if I am talking about conus medullaris, what is conus medullaris? This is the part where the spinal cord is ending. It's the lower part of the spinal cord which is ending here. So, lower part of spinal cord, where it ends, it forms conus medullari. That is corresponding to the level of lower border of L1 lumbar vertebra and below the level of conus medullaris. So if I am talking about the level below the conus medullaris, so I just want to, there is a thread-like extension. Can you see this thread-like extension? This thread-like extension which you are seeing is called as spinal terminal. What is it? Phylum terminal. And phylum terminal is basically made of pia mater. Okay. We have got three coverings of the spinal cord, but if we see the extension of only the phylum terminal, if we are seeing the composition, so it is made of pia mater and it is made of some rudimentary fibrous tissues. So actually, so many times the MCQ has been targeted. The MCQ has been targeted about the ending point of the spinal cord. Where does the spinal cord is ending? So actually, what happens till third week of intrauterine life? So if I am talking about the third month of intrauterine life, the vertebral canal and the spinal cord is having the same target of movement. Okay, so both are having a similar pace of development, but after that what happens, the vertebral column is developing at a faster pace in comparison to spinal cord. So what you will see, so till in the embryo, till the 3rd month of intrauterine life, in embryo till the 3rd month of intrauterine life, the spinal cord and the vertebral column is corresponding to each other at birth. At birth, what happens? The spinal cord is ending at the level of upper border of L3 lumbar vertebra. So if I talk about the spinal cord and the vertebral column, it is ending at the level of L3 lumbar vertebra. And if I talk in the adults, the ending point of the spinal cord is corresponding to L1 lumbar vertebra. Actually, so many times it has been asked, it was asked in the previous year of AIMS entrance examination also, what is the ending point of spinal cord in case of babies, just born babies, birth, baby born, when the baby is born, what is exactly the level where the spinal cord is ending? And that level is corresponding to the upper border of L3 lumbar vertebra. So you can just write it also if you want. At birth, the spinal cord is ending at the level of upper border of L3 lumbar vertebrae. Okay, in adults. Okay, in adults, if I am talking about the adults, in adults, the spinal cord, in adults, the spinal cord is ending at the level of lower border of, at the level of lower border of L1 lumbar vertebra. L1 lumbar vertebra. Now let's talk about the covering. So if I talk about the coverings of the or the meningeal covering of the spinal cord, so that meningeal covering will be corresponding to the cranial covering only. Here also the meningeal covering will be of dura, arachnoid and the pia mater. So here also that is only the covering point, but there is slight difference. For example, in case of when we were talking about the cranial dura mater, it was forming a folds, dural septas and dural folds, but in case of spinal dura, there is no such kind of dural folds or septas form. Okay, so exactly you can see here the outer is the dura, then we have the arachnoid and the innermost is the pia mater. The spinal dura, actually these all points are very important for your MCQ sessions, and you just note down the spinal dura. If I am talking of the spinal dura, it extends from the level of foramen magnum to the lower border of S2 sacral vertebra. Very important. Actually, I have targeted this all points, and actually these are the points which will be very importantly asked in your examination. So what is the extent of the dura mater of the spinal cord? The extent of the dura mater of the spinal cord is from foramen magnum to the lower border of second sacral vertebra. The space which is lying between the spinal dura and the vertebral canal, if I am talking about the space between the spinal dura and that of the vertebral canal, that space is called as epidural space. What is that space called as? Epidural space or extradural space. The space contains, if I talk about the epidural space, what does it contain? It contains loose areolar tissues, it contains semi-liquid fat, and it contains internal vertebral venous plexus. So it is containing loose areolar tissue, it contains semi-liquid fat, it contains internal vertebral venous plexus. The space which is lying between the dura and the arachnoid matter is termed as subdural space, and it contains capillary layer of fluid. So that subdural space is containing which layer of fluid? It contains capillary layer of fluid. Actually, the extent, the ending point of the spinal dura matter, the ending point of the spinal arachnoid matter, the extent of the pia mater, and the spaces which it contains. For example, the question being asked in the previous year of examination was, what does the epidural space contains in terms of the spinal cord? So actually, in normal condition, the cranial dura mater is not having any case of epidural space or extradural space, but if there is an injury on the lateral aspect of the skull, the middle meningeal artery, bleeding occurs from the middle meningeal artery, rupture from the frontal trunk, and in that category there is collection of blood, and that collection of the blood is causing epidural hematoma, which is having the lucid interval. But in case of we are talking about the spinal dura, it is ending at the level of the second sacral vertebra. Now, the contents of the spinal epidural space is it contains internal vertebral plexus and loose areolar tissues and semi-liquid fat. If I talk about the subdural space is containing capillary layer of fluid. Now, the differences from spinal dura and all: spinal epidural space is there, is positive, it is present. There is no cranial epidural space. So, there is no such kind of cranial if it is negative in normal condition. Only in the case when there is excessive, only in the cases when there is an excessive hit on the lateral aspect of the skull, there can be a bleeding. The second important is there is no cranial there is no dural fold. So, in case of spinal dura, there is no dural folds. In case of cranial dura, there is presence of dural folds, and I know that dural folds are there, and already we have talked that dural folds in case of cranial dura mater. We have already talked about the cranial dura mater folds, and I believe you must be remembering in the first 1 hour of the session when I started with the neuroanatomy session, I have talked about all the dural folds. We have talked about the flux cerebri, we have talked about flux cerebelli, we have talked about the tentorium cerebelli and the diaphragm ocella. They are all the dural folds. So, they are all the dural folds which is present here. So, the dural folds are present in cranial dura. And what about in case of the third point is there is no dural venous sinuses. There is no dural venous sinuses enclosed in case of spinal dura, but there is presence of dural venous sinus. There is presence of dural venous sinuses. There is presence of dural venous sinuses in case of cranial dura. So, okay, this we are talking about the spinal dura, and this we are talking about the cranial dura. Now, let's after that I would like to talk about the arachnoid and the pia mater. When I am talking about the arachnoid and pia, arachnoid matter is a thin, delicate, transparent, but it is a avascular structure, and the ending point of arachnoid matter. If I talk about the upper continuation of arachnoid matter, the upper continuation of spinal arachnoid matter is it is continuing with the cranial arachnoid matter. But if I am talking about the lower ending point of the arachnoid matter of the spinal cord, it is ending at the level of second sacral vertebra. It is ending at the level of second sacral vertebra. Now, if I talk about the pia mater in case of this spinal. So, if I am talking about the pia mater, it's a highly vascular membrane. It's a highly vascular membrane which is closing or investing the spinal cord and continues below as a thread-like projection that is called as phylum terminal, which we have appreciated in the previous image also. Now, if I talk about the processes and extension of pia mater in terms of spinal cord, it is having extensions in the form of phylum terminal, it is having an extension in the form of ligamentum denticulatum, it is having the subarachnoid septums and all, and also linea splendens. These are the 4 modification of the pia mater in case of spinal cord. So, phylum terminal, the first thing which we talk about is the phylum terminal. Is the phylum terminal. So, if I talk about phylum terminal, it's a delicate glistening white thread like structure. It is extending from the tip of the conus medullaris. It is extending from the tip of conus medullaris and continue down. The overall length of the phylum terminal is 20 centimeter. It is having 2 parts. It is having 2 parts. So, if I talk about its whole part, it is inner part, it's 20, so phylum terminal internum. So, actually we have divided the entire phylum terminals into 2 parts. Overall length will be of 20 centimeters, but it can be again divided into 15 and 5 centimeters length. When we are talking about the phylum terminal which is lying inside the dural sac, what is the extent of dural sac in case of spinal cord? The extent is second sacral vertebra. So, beyond the level of second sacral vertebra, if we are talking about the length of the spinal we are talking of the length of the phylum terminal beyond the level of the dural sac, it is 5 centimeters, and that part is called phylum externum. So the same thing has been written here. Now the second modification is in the form of subarachnoid septum, which is a pial septum which is seen on the dorsal aspect of the spinal cord. Linea splendens is again a modification or extension of the pia mater which is seen in the anterior median fissure of the spinal cord. The fourth extension or modification of pia mater is called as ligamentum denticulatum or ligamentum denticulata. Actually, this ligamentum denticulata is a very important structure. Why? Because these are two transparent ribbon-like thickened band of pia mater. So, it is two transparent ribbon-like thickened band of pia mater, one on each side, and it is exactly located in between anterior and posterior nerve rootlets, which is extending from the which is extending from the spinal cord. So, what is exactly the location of ligamentum denticulatum? If I talk about ligamentum denticulatum, the total number of ligamentum denticulatum is 21 pairs. So, there are 21 pairs of ligamentum denticulatum, one on either side. What is the location? It is exactly located between anterior and posterior nerve rootlets. It is located between the ventral and the dorsal nerve rootlets, and it is anchoring, it is giving support to the spinal cord because it is an extension from the pia mater which is anchoring and going towards the dura mater. It gives strength. Actually, the ending point of this ligamentum denticulatum is a very important guide for surgical aspect for the neurosurgeon. It guides us the location where we are actually approached. So that is important. I just want you to show this image. So can you see this? So everyone please appreciate this triangular pia mater extension. The lower end of this ligamentum denticulatum is not triangular, but you can see it is fork-like. What is it? It is fork-like. You can see it is the fork-like. The last tooth is ligamentum denticulatum, and exactly if you will see the location of the last tooth like ligamentum denticulatum, it is actually ending at the level of T12 and L1. So it is exactly ending from the level of T12 and L1. So I just want everybody to note down this. It is exactly lying between T12 spinal nerves and that of L1 spinal nerve. So that is an important guide for the neurosurgeon to know the exact point where they have targeted the correct location or not. And I would also like that this is very important for your MCQ. The first teeth is at the level of foramen magnum. That is the first triangular extension of ligamentum denticulatum is lying at the level of foramen magnum. And when I am talking about the last fork-like extension, that is exactly at the level of T12 to L1 spinal segment. Now, here again, can you see this triangular? So, here you can see this is a triangular. If you will see this triangular ligamentum denticulatum extension, what you can appreciate is the location. Also, the anterior and posterior nerve rootlets can be assessed actually, because this ligamentum denticulatum is lying between the anterior and posterior nerve rootlets. So that is another guide for us. I would like to show you a cadaveric image for it. So if you will see this cadaveric image, you can exactly understand this. So actually, this structure which you are seeing is the ligamentum denticulate. This is the ligamentum denticulate. I just want to say this. I just want to say it. Okay. Now here you can see the exact location of ligamentum denticulatum is between the anterior and posterior nerve rootlets, and exactly other than that you can see it's covered by, also we can see the anterior median fissure. I just want everybody to locate this anterior median fissure, and exactly in this anterior median fissure we have got the anterior spinal artery traversing. Now, the clinical correlation, as I already told you, the clinical correlation will be the ligamentum denticulatum is serving as a guide for the neurosurgeon to approach for cordotomy operation. So when the sensory tract has to be sectioned, has to be has to be cut out, has to be operated, actually the condition has to be done to for relieving the pain. Actually, in cases of intractable pain, in case of cancer patient, and we are just giving them treatment, so that how many times we can give them painkillers and high dose of painkillers, they are not able to digest it also, and so many side effects are there. Ultimately, the treatment which is going on is just for some palliative treatments and all is going on to, so we want the patient to relieve of it. We know that it's a very painful condition, and what we can do, the knife is put in front of ligamentum denticulatum and sectioning is done. So when sensory tract has to be, so there are two sections can be. Motor tract sectioning is generally not done, only the pain sensation has to be done. So sensory tract sectioning of the pain sensation is done. So when sensory tracts required to relieve, the knife is put front of the ligamentum denticulatum, and if you want to section out the motor pyramidal tract, then you have to proceed, or you have to place the knife behind ligamentum denticulatum. So generally we want to relieve the patient from intractable painful conditions, so we will go for the sectioning of the pain tracts. And also the other important point which I already told you, the level where there is an ending point of ligamentum denticulatum is corresponding to T12 and L1. So that is very important. Now I just want another procedure. You must be knowing in the anesthesia session also, class of anesthesia, that the lumbar procedure is done. Lumbar puncture procedure is very important. Why? Because it is can be used for therapeutic purpose and can be used for the diagnostic procedure. So for this procedure, what happens? We will tell the patient to lie in the left lateral position. You can palpate the iliac crest, the highest point of iliac crest. If I talk about the palpation of the highest point of iliac crest, that is corresponding to L4 lumbar vertebra. Now I know anybody can give me the answer. What is the point? What is the vertebral level where the spinal cord is ending in case of adults? So can anybody can tell me this answer? The level where the spinal cord is ending, the level where the spinal cord is ending in case of the adults. So that level is lower border of L1. So it comes and in some of the person there can be slight deviation, and maybe the deviation can be one lumbar vertebra only. So we will take another that either it can go to L2 in some other cases, but the thing is that for a safe side, we will go with L3 and L4 lumbar vertebra. That means after the palpation of L4 lumbar vertebra, that is a corresponding line is drawn from the highest point of iliac crest. We can go one level above and we will reach the L3 and L4 lumbar vertebra gap. So exactly the needle is here and needle will penetrate following structure. So in this image, you can see the structure being penetrated by the spinal procedure, lumbar puncture spinal needle, and the structures being present. The first structure will be, I just want everybody to pick the structure. The first structure will be the skin, then we will have the subcutaneous tissue piers, then we will have the interspinous and that of supraspinous structures piers, then we will have the ligamentum flavum, dura mater, we will reach the epidural space. After that, we have to go with the subdural space, and then we have to go with the arachnoid and subarachnoid space. So that is how we will go. So I have written all the structures being pierced during the procedure of lumbar puncture. So in sequence, you can see here the first structure is the skin, then is the subcutaneous tissue, then we have got the supraspinous and interspinous ligament. Sorry, I have just made a mistake here. Please make a correction. Supraspinous, intraspinous, and the ligamentum flavum. So we will have the supraspinous, interspinous ligament, ligamentum flavum, then the epidural space, which will contain the internal vertebral venous plexus. Then we have got the dura, then we have got the epidural space, then the arachnoid mater, and finally the subarachnoid space. Actually, they are the only till the epidural space they have reached. Now, external features of the spinal cord. So if you will see externally the spinal cord, if we are going to see the external features of the spinal cord from the ventral and from the dorsal aspect. The spinal cord is divided into equal halves by taking the consideration of anterior median fissure ventrally and posterior median septum dorsally. So we have got anterior median fissure ventrally and posterior median septum, and also the posterolateral sulcus which is lying dorsally. So this will divide the spinal cord into two equal halves. And then we have to know about the enlargement of the spinal segment. If I talk about the enlargement of the spinal segment, it is enlarged in the cervical region forming cervical enlargement. It is enlarged in the lumbar region forming lumbar enlargement. So when we are talking about the cervical enlargement, it is for the innervation of the muscles of upper limb. It is innervating upper limb structures. Lumbar enlargement is for the innervation for lower limb structures. So exactly, this is again important for MCQ, the cervical enlargement and the lumbar enlargement level. So the spinal cord is having a slight enlargement at the level of cervical region, that is extending from C5 to T1 spinal segment. Lumbar enlargement is from L2 to L3. So exactly, cervical enlargement is innervating the upper limb and lumbar enlargement is innervating the lower limb. This level is important for your examination. I already told you about the spinal segment. Now I want everybody to give the concept of coda equina. What do you mean by coda equina? Actually, what happens in the initial time, we are knowing that the spinal nerves, and that of, if we talk about the nerves, we are talking about the spinal nerves, and we have seen in the spinal nerves that they are having an oblique course. Okay, the spinal nerves ultimately want to emerge out from their corresponding intervertebral foramina. So what is the target of the spinal nerve? The target of the pairs of the spinal nerve is that they will emerge out from the corresponding intervertebral foramina. So actually what happens, as we know, as the baby is born, and after that as the age advances, the spinal cord approximately length is 42 to 45 centimeters of the length, and that of the vertebral canal is 62 to 65 centimeters of the length. So the lower spinal nerves will have slight oblique direction. They will be more oblique. So why they are more oblique? Because they have to emerge out from their respective intervertebral foramina. So in that case, there is a bunch of nerves in the lower aspect which is formed by this bunch of nerves which is lying in the lower aspect, which is formed by L2, L3, L4 and all the sacral nerves and the coccygeal nerve. These all together forms the coda equina. So this bunch of nerve, if you will see the resemblance of this bunch of nerve which is formed by L2, L3, L4, L5 lumbar nerves, all the sacral nerves and that of the coccygeal pair of the nerves, they together gives a fancied appearance. They together give an appearance of the hostel, and that appearance is called as coda equina. Okay. So I just want to write down coda equina. So please write down how is the coda equina formed. Coda equina is formed by lower four pairs of lumbar nerves. Lower four pairs of lumbar nerves. So it is formed by lower four pairs of lumbar nerves. All the pairs of five sacral nerves. And I'm using, that means L2, L3, L4 and L5, all the pairs of sacral nerve and one pair of coccygeal nerve, and this is giving an appearance of a bunch of nerves like a horse tail, and this is called as coda equina. So done with this. Now let's talk about the spinal cord arterial supply. If I talk about the spinal cord arterial supply, it is having a multiple source of blood supply, multiple source of arterial supply. It is getting its arterial supply from the anterior spinal arteries, the posterior spinal arteries and segmental arteries. So here anterior posterior spinal arteries, which is mainly the branch from the vertebral arteries, they are arising from the vertebral arteries. So actually it's an elongated structure. If we talk about the spinal cord, it's an elongated structure, so that anterior and posterior spinal artery source of blood is not enough to feed. It's not enough to feed the entire spinal cord. So it wants an additional food, no? It wants an additional nutrition. So how it will arrive its additional nutrition? The additional nutrition will be served by the segmental artery, and we have to know the corresponding length of the segmental arteries. One of the segmental artery is very large enough. It is called as the artery of Adam-Cave. It has been asked several times in the FMG exam, also in the NEET PG exam, that artery of Adam-Cave is a branch or is giving blood supply to its structure. So we have got anterior spinal artery, which is supplying anterior 2/3 part of the spinal cord, posterior two spinal arteries which is giving blood supply to the posterior 1/3, as shown in this diagram. Also we can see the anterior spinal arteries and we can see the posterior spinal arteries. Other than that, we have got actually an artery of Adam-Kivich. I told you the artery of Adam-Kivich, definitely it is more commonly seen at the level of T11, it's very large enough and gives an additional source. It's a large segmental artery. Largest segmental artery is the artery of Adam-Kivich, which is providing the blood supply to the spinal cord. Venous drainage is corresponds, we have got a together of 6 venous channels. So together of 6 venous channels are there. We have got 2 median, 2 anterolateral, 2 posterolateral. These are the 6 venous channels which is giving blood supply to the spinal cord. Now, if I talk about the internal structure of the spinal cord, briefly you have to know the location of the central gray matter, which is arranged in the form of butterfly, the surrounding white matter. So the gray matter is made of nerve cell bodies and the surrounding white matter is made of that is of the nerve cell fibers. It is myelinated. So actually what is important for us to know is the constituent of the gray matters and the constituent of the white matter. Actually most important is that you have to know about the all the tracts which is residing in the spinal cord. You have to know in the white matter of the spinal cord we have got tracts, and you have to know the function of ascending and descending tracts. That is very important. You have to correlate with the function of ascending tracts and you have to correlate with the function of descending tracts, because this will be asked several times in the examination. Okay, so that is highly important. So when we see the gray matter, you can see in the section, when we see the section, we can appreciate that inside we have got a H-shaped, butterfly shaped gray matter is there. So we have got a, okay, just a minute. Yeah. So here in the cross section, when we see the cross section of the spinal cord, so we will have interiorly a gray matter which is having cell bodies, neuronal cell bodies. The outer will be the white matter. In the central, and there will be a central canal in the center of gray commission. Actually, what is the lining epithelium of the central canal? This has also asked in the examination. The lining of the central canal is biciliated columnar epithelium, and that is called as ependyma. What is it called as? It is called as ependyma. Ependyma, which lines the central canal of the spinal cord, which is lined by ciliated columnar epithelium. It is lined by ciliated columnar epithelium. Now, if I talk about the white matter, the surrounding the gray matter as saved, it will be made. If I talk about the white matter, it consists of the nerve fibers. It is having a actually it is having a nerve fibers is having a myelinated appearance, which is giving it white appearance. It is giving it white appearance. Now, when we talk of the spinal cord and when we talk about its division, the spinal cord white matter is again divided into the region that is anterior white column, posterior white column, and there is also lateral white column. And we have to know the important constituents of the tracts which is residing here, and the function of these tracts is important. So exactly, I want you to show this image. This is the gray matter which you are seeing. So exactly, this is the gray matter. In the center, there is a central canal lined by the ependyma. Okay, the posterior column or the posterior column of the gray matter is sensory. The anterior one is the motor one, ventral or the anterior horn, and the surrounding area. So this is exactly gray area. This is the gray matter which you are seeing. And the surrounding area, if you will see, this is all white matter which is made of myelinated nerve fibers. This is the dorsal column, because this is anterior median fissure, so this will be the anterior column, and the area between these two will be the lateral column. Okay. Okay, now Now we will have, this is anterior median fissure, the deep one. The anterior median fissure is the deep one which is containing the anterior spinal artery along its, and this is the posterior median septum. This is AMF, anterior median fissure. This is posterior median septum or sulcus. Now, now we have to know the tracts. If I talk about the definition of tracts, it is made by the collection of nerve fibers within the central nervous system, which is having the same origin, the same course and the termination. They are referred to fasciculus or bundles. They are referred to fasciculus, bundles or limniscus, and we have to know about its origin. We have to know about its course and termination. So I just want that you should have an idea of all the important ascending and descending tract, and I want everybody to also know about its important functions of this ascending and descending tracts. Okay, so you can see the important tracts, and one by one I would like to write this tracts, and I would like to write the function of this. So I would like to start with the motor tracts, the descending, ascending is the sensory tract. So let's start with the motor tracts. So here also in this diagram, the ascending and descending tracts. So generally we use red color for the descending tracts and sensory one is the ascending tracts for blue color. So all the important tracts in their location has been shown. What I want is to know the function. So actually this is also done in the physiology session, but quickly we will revise it. So major descending tracts, please write along with me. Major descending tracts. So major descending tracts. Major descending tracts are lateral corticospinal tract, lateral corticospinal tract. So we will talk about lateral corticospinal tract. So if I talk about lateral corticospinal tract, first thing is its location. So its location is in lateral white column. So it is located in lateral white column. Origin will be, I just want, I will speak the important points, but the function I will write. So lateral corticospinal tract is located in lateral white column. Its origin is primarily from the motor area and the premotor area of the brain, or the opposite side of the cerebral hemisphere brain. It terminates in the anterior horn cell of the spinal cord. And the major function, actually the function of lateral corticospinal and anterior corticospinal tract, if I talk about, so very easy to understand. If we are talking about anterior corticospinal tract, what does that mean? It means it is located in anterior white column. It is located in lateral white column. And basically the function will be contraction of skilled movement. So function is controls concise skilled movements. So if I talk about lateral one, the control skilled movements which it controls is basically of hands, and the second one, that is anterior corticospinal, it's also having the same function controlling the concise skilled movements. So basically the limbs. So that is very important for you to know. And if I talk about the other one, like we will talk about the rubrospinal tract. The next descending tract is the rubrospinal tract. So if I talk about the rubrospinal tract, again its location will be in the lateral white column. So again its location will be in the lateral white column. Okay, so again its location is in the lateral white column. And if you want to know from where it is originating, the rubrospinal tracts, if it is originating from the red nucleus of the opposite side midbrain. It is originating from the red nucleus opposite side midbrain. And where it terminates. So if we talk about the terminates or termination, it is terminating in anterior horn cells of spinal cord. It terminates in anterior horn cells of spinal cord. Function. The function is unconscious coordination of movement. The function of rubrospinal tract is it is controlling unconscious coordination of movement. Unconscious coordination of movements. Controls unconscious coordination of movements. Controls muscle tone and synergy. It controls muscle tone and synergy. It controls okay, this is the function of rubrospinal tract, and let's talk about the other tracts and all. So if I talk about vestibule, the next tract which I want you to talk is the vestibulospinal tract. So we will talk about the vestibulospinal tract. The next is vestibulospinal tract. So if I talk about the vestibulospinal tract, it's very important for us to know the vestibulospinal tract. Location of vestibulospinal tract is again in the anterior white column. Its origin is from the vestibular nuclei. Origin is from the vestibular nuclei. And termination is in the anterior horn cells. Termination is in the anterior horn cells of the spinal cord. Let's talk about the function. The function is it controls unconscious maintenance of posture and balance. Unconscious maintenance of posture and balance. So after that, let's talk about the next one, tectospinal tract. Tectospinal tract, that is originating from the superior colliculus of the upper tectospinal tract. Actually, tectospinal tract is having another function. It controls the movement of head and neck and arm in response to that of visual stimulus. So the other one is tectospinal tract. Tectospinal tract. So if I talk about tectospinal tract, the tectospinal tract is actually having a function of it controls the movement of head and neck and arms in response to visual stimuli. Now the sixth is lateral reticulospinal tract. Lateral reticulospinal tract. So if I talk about lateral reticulospinal tract, it is actually important function is, if I talk about lateral reticulospinal tract, the important function is responsible for facilitatory influences on the motor neurons of skeletal muscle. So it gives, it is mainly responsible for facilitatory influences on motor neurons of, so I just want everybody to just cut it, then we will start. Influences on motor neurons of skeletal muscle. And the next one is, we have got another one, that is the medial reticulospinal tract. So we have got the lateral one, we have got the medial reticulospinal tract. If I talk about the medial reticulospinal tract, it is having inhibitory. It is just the reverse. It is having inhibitory influence on the motor neurons of the skeletal muscle. So please write down medial. So let's talk about the next. We have got medial reticulospinal spinal tract. The medial reticulospinal tract, the important function is it's mainly responsible for, so major function it's mainly responsible for inhibitory influences on the motor neurons of skeleton system, on the motor neurons of skeletal muscles. So done with this. Now the next is the ascending. So we have got few ascending tracts which important function you have to know. So I would like to talk about the first ascending tract, that is the lateral spinothalamic tract. Lateral spinothalamic tract. Lateral spinothalamic tract. So if I talk about the lateral spinal, I will just check with the students. Yes, dear. Okay, one of the students are asking lumbar enlargement and conus medullaris. Asif, if I talk about lumbar enlargement, it is the enlargement for containing more motor neurons for innervating lower limb. But conus medullaris is the ending point of the spinal cord. It is the level where the spinal cord is ending. Cervical and the lumbar enlargement is because there are upper limb and lower limb, more muscles and structures are there for innervation, the spinal segment is enlarged. If I talk about conus medullaris, it is corresponding to the level of lower border of L1 where the spinal cord is ending. So Asif, have you understood? Asif, understood or not? Asif, have you understood? So please let me know, have you understood or not? Otherwise, I will repeat once again. Sorry, I missed your message. Lateral spinothalamic tract. Lateral spinothalamic tract. So the lateral spinothalamic, lateral white column. Actually, the important thing is that if we talk about the origin of lateral spinothalamic tract is originating from the posterior horn cells of spinal cord. Of opposite side, and if I talk about termination, so it is terminating in the ventral posterolateral VPL nucleus of thalamus. Now talking about the function, carry pain and temperature sensation of opposite half of the body. Carry pain and temperature sensation. It carries pain and temperature sensation. From opposite side of the body. Now we will talk about the other one, that is if I talk so this was the first one which we talked about, lateral spinothalamic tract. I would like to talk about the anterior spinothalamic tract. The next is anterior spinothalamic tract. Is it okay, Asif? Have you understood or not? If you are having any doubt, please let me know, Asif. Anterior spinothalamic tract. So if I talk about anterior spinothalamic tract, again its location will be in the anterior white column. And if I talk about origin, so the origin will be from the posterior horn cells of the, it is originating from posterior horn cells of spinal cord, opposite side. And what about the termination? So the termination will be in the ventral posterolateral nucleus of thalamus, which is called as VPL. The important function has to be known. The function is it carries the sensation of light touch, pressure, tickle sensation of opposite half of the body. So let's talk about the function of anterior spinothalamic tract. So anterior spinothalamic tracts function. So the function is carry light touch pressure. It carries light touch pressure, tickle and itch, sensation, tickle and itch sensation, from opposite side of the body, Now this is the third. Let's talk about the third. The third is spinotectal tract. So if I talk about the spinotectal tract, it is again having the location in the lateral white column. Termination is in the superior colliculus of the tectum of midbrain. I would like to tell about the function, that is visuomotor reflex is the function. So head and eye movement towards the source of stimulus. So our head and our eye both moves towards the source of stimulus. That is the function of spinotectal tract. Function visuomotor reflex. The function is visuomotor reflex, that is of head and head, HEAD. Please write on the full, otherwise you can just get confused. Head and eye movements towards source of stimulation, Okay. Now few more ascending tracts are there which you have to know, like spinocerebral tract and the dorsal column, the fasciculus gracilis and fasciculus cuneatus. So I would like to talk about few more. So if you just can use this. So in short we will write it. So in short I am just writing it. Please write it. So see here. So we have got a few more, like the function, just the function, the spinocerebellar. So I'm just talking about the spinocerebellar, that means anterior and posterior spinocerebellar, anterior and posterior, spinocerebellar tract. So if I talk about the function is the unconscious proprioceptive sensation kinesthesia, unconscious proprioception, that is kinesthesia. Now talking about the fifth, the fasciculus gracilis and that of fasciculus cuneatus. Actually these are dorsal column, these are in the posterior white column, and these are also called as tract of Gall and Brudal. And the important function which is related to the fasciculus gracilis and fasciculus cuneatus is, it is very important for the function of joint sensation. It gives the function of joint sensation, vibration sensation, 2-point discrimination sensation, other sensations like so stereogonosis and kinesthesia. So you will just have 2-point discrimination sensation. Oh, it's nice. What is this? is the joint sensation, 2-point vibration sensation, 2-point vibration sensation, vibration sensation, 2-point discrimination sensation, stereognosis. These are the functions. So done with this. Now I just want to tell about few of the clinical aspect related to the topic. If I talk about the clinical aspect, which is important for you to note down, like in case of syringomyelia, there is a case of syringomyelia. Actually, in case of syringomyelia, there is a fluid cavity which is formed. So there is a formation of cavity which develops near the center of the spinal cord, and that is generally involving the cervical segment. So usually involve the cervical segment. These leads to the destruction of the spinal cord surrounding area of the spinal cord. So the surrounding area of the central cord and spinal cord is destructed. So this is destructed, and this condition is called as syringomyelia. Actually, the sign and symptoms. So basically what happened, the lesion will be involving the decussating spinothalamic tract. So it involves the crossing spinothalamic fibers in the anterior white column. So you can see here the crossing fibers. So exactly the crossing fibers in the anterior white column. So basically the lateral spinothalamic tract fibers, bilateral loss of pain and temperature sensation. So the fibers which is crossing, mainly there is involvement of the crossing fibers of the bilateral destructions will be there in the pain and temperature sensation below the lesion, but the other sensation below the lesion, the uncrossed tracts are well preserved. So only the patient will have this kind of sensation loss, because there is loss of sensation of only pain and temperature sensation below the lesion because of the formation of the fluid cavity around the central canal, but the other sensation is not lost in the posterior white column. So this kind of loss of sensation is called as decussated sensory loss. Now the next condition is called as hemisection of the spinal cord. The other name of hemisection of spinal cord is called as Brown-Sequard syndrome. What is it called as? Hemisection of spinal cord is called as Brown Sequard syndrome. It is called as Brown-Sequard syndrome. So if we talk about Brown-Sequard syndrome, so actually in this condition what happens, ipsilateral upper motor neuron spastic paralysis below the level of, so exactly pyramidal tract is involved. So exactly there will be actually paralysis will be there below the level of hemisection, pyramidal tract is involved, so that will be ipsilateral. Okay. Loss of proprioceptive sensation, sense of position, posture, vibration, fine touch discrimination, and posterior white column tracts, posterior column tracts are involved. Contralateral loss of pain and temperature sensation due to involvement of lateral spinothalamic tract. So I just want you to show the image, because this is an image showing the hemisection or Brown-Sequard syndrome. So basically when there is a case of hemisection or Brown-Sequard syndrome, the sign and symptoms which you have to pay attention is, so exactly if I talk about hemisection, so there will be ipsilateral spastic paralysis. There will be ipsilateral spastic paralysis because of the involvement of pyramidal tract, loss of proprioceptive sensation because of the involvement of posterior column tracts, contralateral loss of pain and temperature sensation because of involvement of lateral spinothalamic tract. So these three features you have to know about in the case of hemisection of spinal cord, which is very, very important for you to know. Now, tapes dorsalis. The other condition is tapes dorsalis. When I talk about tapes dorsalis, it is a condition of syphilitic degeneration lesion. So, it's a condition of syphilitic degeneration lesion. Mainly, what happens in this case, posterior nerve roots or posterior column are involved. So, either there can be involvement of posterior nerve root or there can be involvement of posterior column. So, it is a degenerative lesion where posterior white column is characterized by proprioceptive sensation loss. The patient will have loss of sensation of discrimination, vibration, passive movement, and appreciation of the posture. So exactly the patient is not able to maintain the balance, and such patient will also have rhombus sign positive. So basically the involvement is of posterior nerve roots. Now, posterior rhizotomy or cordotomy. So, actually, this point I have told you in the topic of ligamentum denticulate. So, when I am talking about ligamentum denticulate, that is a 21 triangular projection of the pia mater extension, which is lying between anterior and posterior nerve rootlets. So, basically, what happens? There is two procedures which can be done. One is posterior rhizotomy, another is the posterior cordotomy. So exactly what happens, in this what happens, there is sectioning of the spinothalamic tract. So this is appropriate, posterior nerve roots can be sectioned or the posterior cordotomy can be done, so that the spinothalamic tracts of the is involved and the pain sensation of other side is controlled. The knife is passed 3 mm deep to the ligamentum denticulatum and is swept forward. So this will be involving the lateral spinothalamic tract, and the patient is relieved from the intractable pain, and generally these kind of treatment is done for the palliative treatment in case of cancer patient to relieve from the intractable pain. The anterior spinal artery syndrome. The next condition is of anterior spinal artery syndrome. It occurs due to the occlusion or thrombosis of anterior spinal artery. So basically what happens, we know the anterior spinal artery is supplying blood supply to anterior 2/3 of the spinal cord. So when there is involvement of anterior 2/3 of the spinal cord, the occlusion or then this case condition, when anterior part of the spinal cord is involved, motor symptoms will be involved. Why? Because of the corticospinal tract being involved. Bilateral loss of pain and temperature because of the ischemia of spinothalamic tract. So that means there is involvement of spinothalamic tract also. So in short, we have finished with this topic of spinal cord in brief, and I just want to solve few MCQs along with you. So all of you just solve few MCQs related to the topic. Which of the following is concerned with pain and temperature sensation? Which of the following is concerned with pain and temperature sensation? Track. So those who are live, they can give me the answer. Those who are live, they can give me the answer. So all of you, those who are live, they can give me the answer. Which of the following tracks? So many times, so exactly PDF we will see, but firstly I want you to solve this. Actually many things are there, but firstly I want you to solve this MCQ. So which of the following is concerned with the pain and temperature sensation? Pyramidal tract, anterior spinothalamic tract, lateral spinothalamic tract, dorsal spinothalamic tract. Which is the right answer? The sensation carrying, the tract which is carrying the sensation of pain and temperature, the correct answer will be lateral spinothalamic tract. Lateral spinothalamic tract. If I talk about which of the following sensation is not carried by the posterior column tract? Posterior column tract, that is the tract of Gall and Dural. So which sensation is not carried by the posterior column tract? Position sense, temperature sense, vibration sense, and the pressure sense. So just now I told you the temperature sensation is carried by lateral spinothalamic tract. So that is the answer. So all of you can give me the right answer. You can write your answers. Which of the following pathway is involved in the ability to recognize an unseen familiar object when placed in the hand? So exactly when you place something in your hand and if your eyes is also closed, you can feel whether, for example, if I'm using this block and I'm holding it in, I know it is rectangular, it is having four corners and all. So we are knowing that that sensation is called as a sensation of stereognosis. So can you tell me that that sensation is carried by which tract? Dorsal spinocerebral tract, anterior spinocerebral tract, posterior spinocerebral tract, or the dorsal column? So the right answer is, please mark the right answer. The right answer in this case is dorsal column. posterior column, stereognosis. Actually, this sensation is called as stereognosis sensation, which is called yeah, this is too volatile, ma'am. I have to go through the this again later on. Yeah, actually, not actually, so many things I have covered in a single session. So if you go once again with the session in the beginning, you will understand everything. Okay, Vrishali, don't worry. We will have small sessions also. Actually, this is the neuroanatomy most important part, or the difficult topics which I have searched. But if you want to go systematically, also stepwise, we can go like that also, Vrishali. Don't worry. Okay, stereognosis. So, an anterolateral cordotomy relieving pain in the left leg is effective because it interrupts which of the following sensation. If there is a condition of anterolateral cordotomy relieving pain in the left lung, it will be effective because it interrupts which of the following column: left dorsal column, right lateral spinothalamic tract, left corticospinal tract, or the left spinocerebral tract. Anterolateral cordotomy is done. Okay, in the left leg, the catch point is cordotomy is done, anterolateral cordotomy is done in the left leg. So it will interrupt which of the following sensation? So the right answer is you can revise, dear, you can revise. Okay, the right answer is the left. So actually here the involvement will be of right lateral spinothalamic tract for the left side effective cordotomy and involving the pain sensation. So right lateral spinothalamic tract is the right answer here. All are true about Brown-Sequard syndrome except all of the following is true about Brown-Sequard syndrome, which I have just explained to you, except so hemisection of the spinal cord. So yes, I just told you hemisection of the spinal cord is the another name given to Brown-Sequard syndrome. Ipsilateral loss of vibration sense, ipsilateral loss of crude touch sensation, ipsilateral paralysis below the level of lesion. So can you tell me what is not included as a part of Brown-Sequard syndrome? All are true about Brown-Sequard syndrome except. So hemisection of spinal cord is correct. Loss of vibration sensation is also correct. Loss of paralysis is also correct. Loss of crude touch sensation. So basically the right answer will be, please mark it as a right answer. The correct answer will be loss of crude touch sensation. Crude touch sensation will be not the right answer. You can correlate with the with the 3 points which I have told you. If you write along with me, if you write whatever things I am writing, you just take a whenever my session is there. For example, tomorrow also there is a session starting from 11 p.m. 11 a.m. sorry 11 a.m. So you just keep your notebook, write important points whenever you can correlate. I can definitely understand if you have not given one or two revision at that time, same you are not able to regain everything, but you can solve it along with me. So I would like to tell you certain points about external features of brainstem. Maybe I am not able to finish all of it because I will continue till 7 only because tomorrow also I have to start with the session. But I just want that you should know all these points very importantly. So let's talk about the brainstem. So if I talk about the brainstem, it is consist of. It is consist. So if you will see this, you can see the brainstem is having following parts as you proceed from lower to down. So it is having the parts, it is having the spinal, it is having the medulla oblongata, then it is having the pons, it is having the midbrain. These are the three parts of the brainstem, and brainstem is consist of three parts as from below to up. That is medulla, that is pons, that is medulla, pons, and the midbrain. Now it's important to know what does the brainstem is consist of. Brainstem is, if I talk about the brainstem, it is consist of nerve fibers, it is consist of nerve cell, it is consist of, actually the arrangement of this nerve cells, nerve fibers is according to the formation of longitudinal tracts in the spinal cord. So brainstem function is to provide the passage of various ascending and descending tracts that is constituting and forming the function for the forebrain. So it is containing vital centers. So what I want everyone, that you should know what all structures are lying here. So basically that is very important for you. So I'm just going to finish it. I just want to introduce you with the brainstem important points. Okay, don't worry. So write on brainstem contains vital centers. Brainstem contains vital centers. Like it contains respiration centers. It contains centers for heart rate, blood pressure. It is consist of reticular activating system. It contains reticular activating system which control the consciousness, which is important for, so that means it has an important function of controlling the consciousness. It contains a very important point which is related to the brainstem function is that, if I talk about a very important point which is related to brainstem is that you will so you will see the cranial nerve nuclei. So it is consist of important cranial nerve nuclei. Actually the last 10 cranial nerve nuclei is located in brainstem. So you can just write on last last 10 cranial nerve last 10 cranial nerve nuclei, that is from the 3rd to 12th cranial nerve nuclei is located here. Now if I talk about the clinical, if I am talking about the vital centers, so brainstem is having very important vital centers. So that means if there is an injury to the brainstem, that means the center of respiration gone, center of blood pressure, heart rate gone. So ultimately the patient will die. So it is seen in the case of respiratory failure is happening if there is a compression of medulla oblongata, and also you can see bulbar paralysis is seen because the muscles supplied by the last 4 cranial nerves will be also affected. Now I just want that you should have an idea of the cranial nerves emerging out. So I just want you to show the 2 images. So you can see I am just enlarging this. You can see the image here. This is the ventral. What is this? This is the image which is showing ventral aspect of, this is showing ventral. So this is showing the ventral aspect of brainstem, and you have to see the important structures or the cranial nerves which is emerging from the ventral aspect of the brainstem. That is very important. Okay. So students, those who are live, just I will just want you to introduce. I will just wrap up. Don't worry, because you are sitting from morning, and I'm not morning. It's from the afternoon only. From 2 p.m. you are sitting, but maybe so much of things in the first class you are over. So many things, so you are feeling it's quite tough. Please don't worry about this. I just want you to introduce with the blood supply, means arterial supply and the cranial nerves emerging from the ventral aspect and the features seen in the ventral aspect and few important features seen in the dorsal aspect of the brainstem. And that will be all for today's session. We will start tomorrow at 11 a.m. So just be connected for another 25 minutes. Is this okay? Just half an hour, another half an hour. So if you will see this, the lower part is the medulla oblongata, and in the medulla oblongata, important features which you are see here, this is the ventral aspect. So this is the anterior median fissure is there. This is the pyramid. Pyramid is formed by corticospinal tracts, and also in the lower part you can see the crossing over, decussation of the fibers of pyramid is there. The crossing over of the fibers of pyramid. We know that pyramid is formed by corticospinal tract. The function of this is to control the movements. It is important for the movements of the contralateral side of the body. And also you can see there is olive just lateral to the pyramid, which is formed by elevation inferior olivary nucleuses. And actually what you can see, the last 4 cranial nerve. So just lateral to the pyramid, the nerve rootlet which is emerging is the hypoglossal nerve. So we have got an hypoglossal nerve emerging out, and lateral to olive from top to bottom, if you will see, we have got the 9th cranial nerve. This is the 9th cranial nerve, this is the vagus nerve, this is the 9th, 10th, 11th cranial nerve. Vrushali, yes, actually, yes, but tomorrow class will be, so one good point about tomorrow class is that it is starting from 11 a.m. So that means you will be fresh from 11 till evening 6 or 7 I will end. So that is good, because I want that most important points of the head and neck should be completed, and cranial nerves are still remaining. So I think I will require a session of 6 to 7 hours. Is it okay? But I'm starting early. Tomorrow I'm starting early. I'm starting at 11 a.m. only. So we will have a session on 11 a.m. only. Okay. Now, here is another image where you can see this is showing the dorsal. So exactly, if you will see this image, you can have this is showing the dorsal aspect of brainstem. So I'm not going into the details of dorsal aspect of brainstem, because if you will see dorsally in the medulla oblongata also, you can see there is gracile tubercle, cuneate tubercle, and there is the tuber cinerarium, and lower down it is called as fasciculus cuneatus and fasciculus gracilis. Actually dorsally, if you will see, we have got this rhomboidal structure which is the floor of 4th ventricle, and already we have finished the floor of 4th ventricle. So here you can see this is an image which is showing dorsal aspect of brainstem, which is having, so exactly, dorsal aspect of brainstem is formed by the structures of floor of 4th ventricle, which is formed by the dorsal part of the upper medulla and the dorsal part of the lower pons, which is already done. So I'm not going into repetition of this. I just want everybody to know about the important structures. This is the sagittal section of the brain. See here, this is sagittal section of the brain where we can see the 4th ventricle. This is P for pons and this is M for medulla. So we have to just know about the cranial nerves emerging out. Okay, so let's talk about that. So features, medulla oblongata is upward continuation of, it is an upward continuation of spinal cord, extending from, what is the extent? So it is extending, if we talk about medulla oblongata, it is extending from foramen magnum to the lower foramen magnum. It is extending from foramen magnum to lower border of pons. It is bulb-like and truncated cone, and the important nerves emerge. So I just want that you should know important features and you should know the nerve emerging out from it. So features on the anterior aspect. So medulla oblongata is having vital centers. It is having vital centers, that is, it is having the cardiac centers located on it. It is having cardiac centers. It is having vasomotor centers. It is having respiratory centers. And it is having medulla oblongata is provides attachment to last 4 cranial nerve nuclei. Now actually what happens when you see the so actually I just want you to show this when this image. So exactly, if you show this image, so this is exactly the P for medulla. So this is the medulla, this P for the pyramid, and this is the olive which you are seeing. And exactly, pyramid is basically formed by, and above it you can see the pons. This is the pons, and you can see the pons, the nerve rootlets which is emerging from the pons. If you will see, the pons is the fifth cranial nerve, and also at the pontomedullary junction, this is the pontomedullary junction, the sixth, seventh and eighth cranial nerve will emerge out. So you have to know about this. So exactly, this is the this is again, you are seeing the anterior median fissure which will divide the medulla, and there is a olive, there is a pyramid here. Pyramid is made of corticospinal fibers, which is already shown to you. So you just correlate with this image. So this is the olive which you are seeing. This is the olive which you are seeing, and this is the pyramid. Now anterior median fissure and posterior median sulcus divides medulla into two parts. So there is presence of pyramid, as we can see, and the pyramid is formed by corticospinal tracts and the fibers. So 75% of these fibers crosses opposite side and form the lateral spinothalamic tract, traverses it will traverse in the lateral white column, it will traverse in the lateral white column, forming lateral corticospinal tract. So it will form, yes, that is right, it is crossing the opposite side at the level of pyramidal decussation in the form of lateral corticospinal tract. What is that? It will form lateral corticospinal tract. So that pyramidal decussation will lead to the formation of lateral corticospinal tract. Okay. Dorsal aspect, अगर हम dorsal aspect की बात करते हैं तो dorsally, if you will see here, dorsal aspect, the features will be similar to the features seen in the floor of fourth ventricle. And so I'm not going into much detail. Okay, I just want to complete. So exactly, now if I talk about the blood supply of medulla, so it's important that you should know the blood supply. So we have got a multiple source of blood supply: anterior spinal artery, posterior inferior cerebral arteries. We have got, so you can see here the blood supply. So here I just wanted to show the important blood supply of the medulla is shown here. So the important source of blood supply is from the posterior spinal artery. So we have got a blood supply via posterior spinal artery. We have got a blood supply by vertebral artery, we have got a blood supply by anterior spinal artery and posterior inferior cerebral artery. So all these arteries which is mentioned here is giving blood supply to the medulla. So actually you can appreciate that it is receiving multiple source of blood supply. So it is receiving multiple source of blood supply. Now I just want everybody to solve this MCQ. Those who are live, can you tell me olive is seen in which part of the brain? Olive is seen in medulla, olive is seen in cerebellum, olive is seen in midbrain, olive is seen in pons. So olive is seen in which part of the brain? Olive is seen in which part of the brain? So olive is seen in which part of the brain? And the correct answer is olive is seen in, anyone? Okay, I got an answer from Vrishali. Absolutely correct. So I just want to give you a thumbs up. Absolutely correct, Vrishali. Absolutely correct. It is from the so absolutely correct, Vrishali. Yes, it's the medulla is the right answer. Which nerve does not arise from the medulla? So I have shown you 4 cranial nerves were emerging out from the medulla. Can you tell me which of the following nerve is not emerging out from the medulla? I have shown you 4 cranial nerves were emerging out from the medulla. Can you tell me which of the following cranial nerve is not emerging out from the medulla? So yes, anyone? So if you know, I told you last facial, Vrishali, you are absolutely right. Again, Vrishali has given the right answer. So I am so happy for her. Very good, dear. Yes, you are absolutely right. So absolutely correct. Yes. Last four cranial nerve. Last four cranial nerve emerges out from medulla. That is 9th, 10th, 11th, 9th, 10th, 11th and 12th. Pons. So when you see the ventral aspect of the pons, you can see here, this is the ventral aspect of the pons. You have to know about the important features. See, so pons is having a basilar groove in which the basilar artery lies. On ventral aspect, you can see the trigeminal nerve is attached, and then the pontomedullary junction, abducens, facial and vestibulocochlear nerve is emerging. So exactly at the level of pontomedullary junction, the 6th, 7th and 8th, and from the ventral aspect, the trigeminal nerve is emerging out. So you can just write, there is a basilar groove on the ventral aspect of the pons which contains the basilar artery. And trigeminal nerve is attached to this surface, by motor and sensory part, by motor and sensory component. So the motor is small and the sensory is large component of trigeminal nerve. The motor will be medial to the sensory. So exactly, if we talk about the motor, it will be located medial to sensory and it will be smaller than the sensory component of trigeminal nerve. Okay, and actually it is also important for us to know the nerves emerging from the pontomedullary junction of the, so nerves emerging out from pontomedullary junction. So nerve emerging out from the pontomedullary junction. So exactly the nerves which is emerging from the pontomedullary junction will be following. 6th cranial nerve, the motor branch of facial nerve, the sensory component of facial nerve, the sensory component of facial nerve which is called as nervus intermedius. What it is called as? It is called as nervus intermedius because this nerve is sandwiched between the motor component and the vestibulocochlear nerve, and the next is vestibulocochlear nerve. It is the vestibulocochlear nerve. It is the vestibulocochlear nerve. Done. Now dorsal aspect will be, the features will be same as seen in the floor of fourth ventricle, So I am not going into the details because floor of fourth ventricle is already completed. So in dorsal aspect, you can see facial colliculus, and as I told you about the facial colliculus, it's a elevation seen in the floor of fourth ventricle formed by in the dorsal lower. So facial colliculus is seen in the dorsal lower part of the pons. So facial colliculus is seen in the, it's very important, facial colliculus is seen in the dorsal lower part of pons. Formed by motor fibers of facial nerve winding around abducens nerve, winding around abducens nerve. nerve nucleus. What is the sixth cranial nerve nucleus? And this is called as internal genu of facial nerve. Now, blood supply of pons, basically if I talk about the blood supply, it is received by the pontine branches of, basilar artery. It is getting its blood supply from the pontine branches of basilar artery. It is also receiving blood supply from anterior inferior cerebellar artery. Anterior inferior cerebellar artery. So please write down the source of blood supply. I would like to show you an image where you can see the pons, we can see the branches of the basilar artery, basilar short branches and that of pontine branches, midbrain. Now let's talk about the midbrain. Midbrain is the uppermost part of the brain stem, and it's important to know what structure the midbrain is containing. So on the ventral aspect, you can see an important nucleus, that is oculomotor nerve emerges from midbrain, from the midbrain, and from the dorsal aspects. And other than that, actually it's very important that nerve rootlets will emerge out, and exactly if we will see the nerve emerge, its location will be, when it emerges out, these nerves run forward between, superior cerebellar artery and posterior cerebral artery, and PCA means posterior cerebral artery. Now you can see here, this is the oculomotor nerve nucleus which is emerging out from the ventral aspect, and this is the crux cerebri, which you can see cerebral peduncles and all, and also you can see the mammillary body above shown. Now on dorsal aspect of midbrain, an important features which I want you to show, when you see the dorsal aspect of midbrain, you can see 4 colliculus is there. These colliculuses which you are seeing is called as superior colliculus and inferior colliculus. Vrushali, it is on the clinical aspect. Okay, pontine hemorrhage, the important, if I talk about the pontine hemorrhage, many important structures will be destroyed. Okay, and it's an extensive bleeding or extensive ischemia in the pontine hemorrhage, and the patient will have high grade temperature and many important structures which we know that pons is having the facial nerve emerging out, pons is having the abducens nerve, and also having the emergence of the lower down the corticospinal fibers will be involved. So actually it will give a huge pinpoint, people will be there, many adjoining structures will be involved, and it is a case of devastating or many of the important blood supply or ischemia of the blood supply involved in case of pons. Okay, pontine hemorrhage, actually that is also in the, that part is also coming up in the clinical aspect. Let me complete the gross anatomy first. So I think this is okay, Vrishali. We will come to that point. Also, superior inferior colliculus together is called as the quadrizemina. So so actually today I will be not able to complete that brainstem syndrome. In brainstem syndrome, I have made certain slides, and I have detail about each and every clinical aspect. Don't worry, tomorrow we have the session of head and neck, but I think this brainstem syndrome, it will take another half an hour. I will explain that also, Vrishali, because I think it's too late, so I will not continue after 9, but in tomorrow head and neck part, I will give you all syndrome, medial medullary syndrome, lateral medullary syndrome, Weber syndrome, pontine hemorrhages, and all in detail. So rounded elevations are there. There is 4 rounded elevations which is formed by 2 superior colliculus and 2 inferior colliculus. So superior colliculus is connected by superior brachium to lateral geniculate body. So exactly you can see superior colliculus is connected to lateral geniculate body, and inferior colliculus is connected to medial geniculate body. So you can write superior colliculus is connected by superior brachium to lateral geniculate body of the thalamus. So lateral geniculate body is the nucleus of thalamus, and this is a part of visual pathway. This is the part of visual pathway, auditory pathway, visual pathway. Now one more is there, that is called inferior. So if I talk about inferior, so you can see here also superior brachium connecting the superior colliculus, inferior colliculus is connected by inferior brachium. So if I talk about inferior colliculus, it is connected by inferior brachium to medial geniculate body, which is a part of thalamus nucleus, and it is a part of auditory pathway. This is connected with the function of auditory pathway. Now blood supply of midbrain, a very important point is about the blood supply of midbrain. If I am talking about blood supply of midbrain, it is having multiple source of blood supply. So midbrain is getting blood supply from the branches of posterior cerebral artery. It is getting blood supply from the branches of superior cerebellar artery. And also it is getting blood supply from the posterior communicating arteries. And that of anterior choroidal artery. Yes, sure. Posterior and that of anterior choroidal artery. Anterior choroidal artery. Okay. Okay, dear, just going to finish. This topic is going to end only just 5 minutes more. I want to summarize this and a MCQ related to this topic. So this is about the blood supply. So you can see the quadrigeminal artery, the branches from superior cerebral artery, the posterior cerebral artery, all these are giving blood supply to the midbrain. Actually, why blood supply is very important for you to know, because if you are knowing the blood supply, you are able to solve all the MCQs related to it. You can understand the syndromes, you can understand the syndromes. Okay, so let's talk about so I just want everybody to solve this MCQ for me. So yes, Vrushali and all, Asif, whoever is live, can you tell me corpora quadrigemina? Actually, superior colliculus, inferior colliculus together is called as corpora quadrigemina. So corpora quadrigemina is present in which part of the brain stem? Superior colliculus 2 plus 2 inferior colliculus, 2 inferior colliculus. So together these are called as, yes, Vrishali, you are right, it's the midbrain. Yes, you are right, it is the midbrain. So together it is called as, one more point I have to tell about midbrain, which is very important. I just missed out. I will tell now. It's the quadrigemina. Together it is called as quadrigemina. Now I just want to tell about the dorsal aspects. Please see this dorsal. Actually, there is an important point in the dorsal aspect. So this is actually dorsal aspect. You can see the nerve which is emerging out. Yes, so can you see the nerve which is emerging out? The nerve which is emerging out is a trochlear. So exactly, if I talk about the nerve, only trochlear nerve is the odd man out. All the nerves will emerge out from the ventral aspect of the brainstem, but trochlear nerve is the nerve which is not emerging from the ventral aspect of the brainstem, but it emerges out from the dorsal aspect of midbrain. So it's very important for you to note down. So write down trochlear nerve. Trochlear nerve means the fourth cranial nerve, means the fourth cranial nerve emerges. So yes, both of you are right. Emerges out from the dorsal aspect of, it emerges out from the dorsal aspect of midbrain. And one more point is that after emerging, they decussate, the fibers decussate, and then they reach the ventral aspect of the midbrain. Then they come to the ventral aspect. So actually, I will summarize here itself. I am ending for today. But before ending, I just want everybody, we have that what all things we have covered up. So today was the neuroanatomy session, and tomorrow is the head and neck series. So just a quick recapitulation of the things being covered up. The meninges has been covered up, where we have talked about all the dura coverings. We have talked about the dura mater, arachnoid, and the pia. We have talked about the clinical aspect, extradural hemorrhage. We have talked about subarachnoid cisterns. We have talked about flux cerebelli, tentorium cerebelli, diaphragm sella. We have talked about arterial supply in the innervation of the dura mater. We have solved MCQs related to this topic. We have also talked about the ventricles of the brain. So in detail, I have told you about the fourth ventricle, the floor of the fourth ventricle, the roof of the fourth ventricle, the communication of the ventricular system of the brain, how the fourth ventricle is connected to the other ventricles. We have talked about the maximum amount of choroid plexus formed by the lateral ventricle. The CSF flows from the lateral to the third via interventricular foramen of Monro. From third to fourth, it is via the cerebral aqueduct of Sylvius, and how it communicates. So there is two openings in the roof of fourth ventricle, foramen of mesentery and foramen of Luschka, forming communication of the CSF in the ventricular system to that of subarachnoid space. So actually that is very important. And other than that, we have also talked about the spinal cord. We have talked about the external aspect of the spinal cord, the blood supply of the spinal cord, the artery of Adamkiewicz. We have also talked about the tracts of the spinal cord. We have talked about motor tracts and the sensory tracts, the function of each. We have talked about we have also talked about the dural venous sinuses in detail. We have talked about cavernous sinus in detail. We have talked about the relation, the extent of cavernous sinus, the clinical anatomy, that is cavernous sinus cavernous sinus thrombosis. We have also talked about the cranial nerve nuclei. So I have talked about the functional component of the cranial nerve nuclei and the all the cranial nerve nuclei location. Ma'am, any group that we get information about the class, you will definitely provided information here itself. Tomorrow the session is very important, and I want everybody to be present for the session, because the session will start exactly at 11 a.m. and in brief few of the nerves also I will explain, and I want everybody to present, because after each session of important topic, few MCQs will be discussed and it will be highly beneficial. So tomorrow head and neck series is there, and all of you please come on time. We will start at 11 a.m. so that we can end it fast. By 6 p.m. we can end it 6 to 7. We'll not end it more in the night, because after a certain time you all get exhausted. Okay, so take your breakfast, adequate amount of breakfast, and be attentive to the session. Okay, so all the things which we have covered up is very important, and conceptually we can't have a very superficial knowledge for cracking any exam. We have to go in depth. So only we will study slightly in depth, we will know the concepts, and we will solve the MCQs related to it. So that will be fine. Okay, so tomorrow's session is head and neck. I will also write in the groups in this message box, so that you can be present on time. So keep on studying. All the best. Any doubt, if you have, you let me know. So tomorrow session is at 11 a.m. head and neck. So tomorrow's session will be of head and neck, highly important. So please don't miss out. Okay. Thank you so much, and we'll meet in the tomorrow session. Thank you. All the best. Keep studying. We'll meet tomorrow exactly at the same time, 11 a.m. and we will have a session of important topics we will cover up with the head and neck series. Thank you. कल की सोचेंगे. Okay, done. All the best. Thank you. So I'm not, I'm ending down.